Okay. Good morning, good afternoon, or good evening, depending on where you're tuning in from. My name is Shapiro, and I'm here to welcome you to the 12th Global Forum on Nicotine conference, coming to you from Warsaw. So I say, this is the 12th year. I've been coming for 10 years, so I've been coming here since 2015, which is really where I started to get involved in the tobacco harm reduction space. All the conferences I've been to have been exemplary, both in logistics and in content. But I'm particularly interested in this one because it's all about communications, which has been my sort of stock in trade in drugs, HIV, and more recently, tobacco harm reduction for over 40 years now. But we know in 2025 about the challenges of communication around communicating the benefits of tobacco harm reduction to the wider world, to professionals, politicians, and the media. For those of you who are going to be sticking with us, we have a really top, best of the best, really, people coming to speak here about the challenges of tobacco harm reduction and hopefully some of the ways of either getting over the hurdles or swerving around them. Talking about the best of the best, I'd like to introduce you to the commentary team that are sitting here. Over on my far right, we have Marcela Madrozo from Mexico, who represents Promoting Health Without Frontiers. We have Gabriel Oki from Nigeria, but resident in Liverpool. And he's a Liverpool supporter, Paddy, by the way. He's a public health. And Will Godfrey, who many of you will know, editor of the esteemed Filter magazine. Where truth and justice meets harm reduction. There you go. There's a slogan for you.
Giving me that tagline for free.
Yeah. No. You can pay me later. So let's start off with Marcela. I mean, you've come all the way from Mexico. So kind of what apart from the possibility of getting a free pen and a nice bag, what brings you all the way here to GFN? What are your kind of hopes for the conference that focuses on communications?
Well, thank you very much, and good morning to all of you. As you know, in America, we have a lot of challenges. And one of the challenges we have to confront better is how to communicate with our population. And when I talk about population, I mean which population, because the message cannot be the same one to everyone. Right. The message to young people cannot be the one that we want to send people that want to quit smoking, for instance. So what are the messages that are working, that are targeting the population we want to reach? What kind of new messages should we send to the population? Because we've talked about THR for a long time. We've talked about how many people die because they consume tobacco, how many people die in each country, how many people smoke around the world. But this has been said so many years. We have to be fresh. We have to start with new messages. Right. And something I expect is to learn what is working in other regions of the world. Right. What type of messages are being make us able to reach the population we want to reach and give them the message we want them to receive. Right. That's what I would like to, and I'm sure I'm going to learn a lot during these 3 days.
Thank you for that. Okay. So, Gabriel, what about you?
Okay, I'm really excited because I work in health communications. Since my undergrad, I've been working, in health communications, writing articles, working on newsletters, social media communications. So when I left uni, I was like, okay, I wanted to do something, very novel. And then I realized, tobacco harm reduction doesn't have enough research, and enough communication. Right. You don't see enough about it online. And that was why I joined the Tobacco Harm Reduction Scholarship. And since then, I've been coming. This is my 4th time. And my 4th time now hearing that we're talking about communications, so I'm really excited. Right. I want to know what is working from even Will, who runs his own organization, learning from people what is working. Because as we all know in communication, you zone in on what is working. You keep iterating, and then you leave behind what is not working, and then you keep working on, on things that are working. So those kind of research combined with communication for advocacy is what I'm really excited about for this conference, to be fair.
Excellent. Mr. Godfrey, you've been here before, but I don't think we've had a GFN that actually does focus on what you do every day. So what particularly, I mean, you've had a look at the programme, I assume. What kind of sparks your interest, do you think?
Well, I mean, I'm particularly thrilled with the overall theme of the conference to begin with, because to me, and not denigrating the really important work that people do in so many areas of this field, but communication is the absolute #1 priority. Because with science, yes, there's always more that we can find out, but we have the basic knowledge in place about relative risks, about cessation, and the gap is that the public and of course lawmakers don't know it or refuse to know it. And so we have a situation where in country after country, majorities of people believe that THR products are as harmful or worse than cigarettes. And imagine if we could find ways to reverse that. And then it would not only see people changing their behaviors, as some already are in their millions, despite governments not deigning to permit or condone it. And you'd have governments that implement prohibitionist or restrictive policies suddenly realizing that those policies are wildly unpopular. And so that's... I don't know if that quite answers what you were asking, but that's why I think the theme of this conference is so important.
Fine. You can ramble away. We don't mind. It's all very friendly and informal. No worries. No worries. So, Marcella, this kind of combines the two questions, really, because you come from a country which is not exactly tobacco harm reduction friendly, if I can put it like that.
Not at all. Not at all.
So, in terms of promoting health without frontiers, what are you actually doing? How does all of that work for you in Mexico?
Well, in the last 3 years, we've been engaged mainly in communicating what really THR means. What are these tools? How can they be used if you want to quit smoking? Because a lot of people in Mexico, this is something very important. The prevalence of smokers has grown in Mexico, despite FCTC.
Right.
All right? And it went down to 16.8% of the population. Well, and after all the presidential decrees banning them, it went to 19.6.
Okay.
So as soon as they started banning it, even though you were able to buy them, because many, you could go to many places where you could really buy vapes, even though the prevalence grew. Now, what I'm trying to say is we focused on communicating through social media.
Right.
And we also worked and we had training with doctors, first contact doctors that can, because in Mexico, when we started, 77 out of 10 doctors thought nicotine was the cause of cancer and heart attacks, for instance. So you have to, how do you consider they're going to be able to advise their patients if they don't have the information or they have misleading information? So we started to work with them, and we also worked with, we had workshops with journalists, because those are the ones that can help us send the message to their audiences. Okay, so we focused on that, and we also started working regionally. We did case studies of Argentina, Brazil, Costa Rica, Colombia, and we went there and we presented how how is the status of tobacco control and THR.
Right.
And it was important because we had a lot of media when we did the presentation. So we were able to reach that population of South America and Central America.
Okay.
Now, what's going to happen in Mexico? That's a big question mark. Because the Constitution says that any activity that has to do with vapes and electronic devices will be sanctioned. But they don't say how they're going to be sanctioned. They don't say they are banned or prohibited.
Right.
They said they will be sanctioned. But any activity, does that mean that talking about this in Mexico is going to be a sanction? We don't know yet.
No.
Because the secondary laws have not been approved, and we don't even have a project of secondary law. We don't know how it's going to be. I mean, there's no project registered, nor even in the Senate or the Deputies' Chamber.
Right.
So we don't know how
You
it's
don't
going.
know. I'm going to come back to challenges in a minute, because that, for you, for Mexico, that's a big one.
It's a big challenge.
That's huge. Gabriel, I know I've seen stuff online that you've written about media responses in Africa. I mean, I'm obviously particularly interested in Africa because for all sorts of different reasons, which I'll come back to. But what's been your focus in terms of tobacco harm reduction communications work?
Yeah, thank you very much for that question. So as I said earlier, when I wanted to start into research communications, I realized that there wasn't, you don't even have enough journalists, enough people talking about it. So I didn't have enough to even work with. That was why I decided to organize a fellowship program when I joined the Tobacco Harm Reduction Scholarship Program. So to do a fellowship program and then recruit people who are interested in the topic, have discussions about it, and then experts come in, they talk about it as well. And then alongside, pre the fellowship and after the fellowship, collected data as well. And then look at the data, what was their knowledge before they joined the program, and then what was their knowledge. So that was how I got to publish the research you're talking about. And I realized that more than 70% don't even have proper knowledge of what tobacco harm reduction is. And these are emerging journalists, these are emerging public health advocates. More than 400 people were part of that study. So imagine 70% of these people who are going to become journalists tomorrow, who are going to be in front of televisions tomorrow, talking to people, not even having, full understanding of what.
And is that in Nigeria? Was that a study done in Nigeria?
Nigeria and
Africa generally.
Africa generally.
Oh, right.
So that was really concerning, to be fair. So and then I realized, there's something here because the knowledge gap is really huge. And then you probe further to know, where are you even getting the misinformation you're getting? I realized people are, lots of people who call themselves advocates as well, who just read something read something online and all, just want to gather likes on Facebook and the likes on, push anything out there. And so when you are getting misinformation from other type of media, and then the real media, which is, not the real media, but your TV, your radio, and the likes are not giving you the right information, then there's a lot of problem in the future. So the gaps, knowledge gap, is where I'm really interested. Science and communication, trying to ensure that there's enough to drive advocacy, really. So that's why I'm interested in.
Thank you for that. That's really interesting. Will, how long has Filter Magazine been going?
We pushed it live in 2018, which was actually the first year I came to this conference as well.
Oh, right.
And we've been continuing ever since.
Right. And the mission statement, if I can call it that, for the magazine is what? Because you don't just talk about tobacco harm reduction in your magazine.
Yes, so we cover and communicate about drug policy and harm reduction and related human rights issues in general. But within that, tobacco harm reduction is centrally positioned, and that's something that was very deliberate in the concept right from the beginning, because how can you adequately cover drugs without covering the world's biggest cause of drug-related death? To me, it would be absurd. And so we're very proud to do that and to make efforts to integrate THR within the wider harm reduction and drug policy movement, where I think it belongs. And unfortunately, the two have often been siloed.
We'll come back
as you
to
know.
that one if we've got time, which I think we probably will, looking at the clock. So what kind of, I mean, presumably Filter goes global, doesn't it? Presumably you've got readers all over the world. Do you get?
Yes.
Yeah.
We, the biggest segment of our audience is in the English-speaking countries. United States top of the list, but all over the world. So yeah, we've generated a direct audience of millions, but also, of course, been picked up, republished, cited, blogged about in many other publications, including kind of national mainstream media in the US and other places. So hopefully our reach is bigger still.
Is big. Excellent. Okay, so back to some of the challenges which Marcelo you've already touched upon. I'm just thinking in terms of talking to journalists, talking to doctors, two things really. One, how receptive do you find them? And two, depending on what a definition of sanctions means, there's a potential that you just won't be allowed to. People won't be allowed to talk about this. This sounds weird.
We could go there. We don't know. We hope we don't.
No.
But we don't know. When the Constitution was reformed, the same reform said that the Congress had 180 days to publish, let's say, the secondary laws.
Right.
Now, this is going to, the 180 days are due next July 17. I mean, it's right now.
Right.
They should be approved by now. As I said, we don't even have a draft. We don't know of a draft.
Right.
So how is it going to be worth it? We have no idea.
No.
But also, Don, and I didn't mention it, and I think it's important, we had a weekly podcast. We have a weekly podcast. And we have experts there. Roberto Sussman has been there several times. And he explains in a very casual vocabulary so everybody can understand.
Which is difficult for
Which
Roberto.
is very difficult for Roberto. It's very difficult. I have to recognize he's been very good at it. And because, as you said, many people thought that THR was even worse than smoking, using THR devices. And many people think that the vape, the aerosol that comes out of the vape is even worse than smoke emissions. So he was there to explain, well, they're not the same, they're different, and of course you cannot compare the danger or the risk of one with another. But we also had people testimony of people that were able to quit smoking after 30 years of maybe consuming 2-3 packs a day, and they did it through vape and or electronic tobacco comprimido, compressed tobacco devices.
Yeah.
But we also had families, children that said, "My father doesn't smoke anymore. We don't have to be smelling the smoke." So it's been very, very interesting.
Right.
And I think we hope we are going to be able to
carry on.
Yeah. If not, what we are going to do is move to the region and have our broadcast and everything from another country of the region. And hopefully we could reach audience in Mexico, but we're not going to be doing it from Mexico. But it all depends on how the secondary laws come.
So there's no definition of what sanction means in Mexican law?
I mean, somebody even said that if you had a vape in your car, not even using it, just to have it. 36 hours of arrest. And 180,000 pesos of sanction. I mean, this is absurd.
This is
but
weird.
Somebody in the media started saying that this was, but as you go to the portal of the Congress, there's nothing there. Nobody has registered.
And you haven't, people who you might define as activists or others like yourself, have not been able to make representations to anything like that?
But what happens is that the ruling party has more than 2/3 of Congress under their control.
Oh, okay.
Okay.
Right.
So we have and there are doctors that are in Congress that feel that this ban is absurd. And,
Right.
it's going to put at risk everybody because we don't know what the quality
Right.
of the products you're going to buy.
Okay.
And what we are doing is strengthening the black market.
Yeah,
Okay.
of course.
And in Mexico, as you can imagine, the black market is in the
Huge.
hands of the cartels.
Yeah, of course.
So if anyone is happy with this, are the cartels,
Yeah,
not the
right.
rest of the population.
No.
But what they say is we are going to go to Tribune.
Yeah.
We're going to win the discussion, but we are going to lose when they vote,
Yeah,
when
sure.
Congress votes.
Okay.
Okay, so yes, I'm not personally because I'm not at advocacy,
No.
but they're also saying, well, let's wait until someone
Free.
registers
Bloody hell. Right.
a draft, and then we can discuss
Right.
on something. Right now, we don't know.
I've got a
Wait.
lot less time than I actually thought I had, so I'm going to move very quickly. I was talking about public health messaging in Africa. I was talking to a delegate from the DRC yesterday over lunch, who told me that his country has got 100 million people, 75% of them haven't got any electricity, most people live in rural areas. Very briefly, how on earth do you get public messages, actually about anything, but about this to people who don't know, haven't got mobile phone because you can't plug it in anywhere.
So it's
tough.
Huge. It's really tough, to be fair. I was also trying to build on what she said about the kind of communication. What you would tell a doctor when you're even trying to advocate about CHR is different from what you tell the journalist. The messaging itself.
Yeah.
So I feel like to an extent we really don't understand how bogus the problem of communication really is, because it's like everything. While I was traveling on a plane, I was reading this book by Gladwell, Malcolm Gladwell. That where he did research on how Nickelodeon did some of their cartoons and all that, how they were able to reach children and make them about stickiness. He was talking about stickiness.
That's right.
And I was thinking about this conference, like, wow, we really need to do a lot of work.
Yeah.
When I was looking at the robustness of the research in that area. So as you said, DR Congo is just one of the countries.
Yeah.
There are lots of countries like that in Africa.
Exactly.
Lots of countries.
Exactly.
So, even some don't even have television.
You have to be innovative.
So you have to be
In some
innovative,
ways.
as I said.
Okay.
And then I think sometimes you now have to look at what is existing already.
Yeah.
So I think a place like Rwanda now, they have a huge program around community healthcare workers. I think I wrote an article about it on Filter as well.
Right.
So you can now work with that. So if you are able to educate community healthcare workers very well, then they go into communities. Alongside other communication that they're doing, when they see someone smoking, then they can administer that.
Okay.
I think so that's one way in, because that is already working in a place like Rwanda.
Right.
In Nigeria, maybe you use the radio because whenever there is maybe a word tobacco day, word this day, or word that day, people always come on radio. So if people that are coming on radio on these days don't pass the misinformation and they are really saying the right things, then you are reaching people on radio, things like that.
Mr. God, I'm gonna leave it there because we've got a presentation later about the problems of integrating tobacco harm reduction with drugs and HIV harm reduction, which is a big issue. People who you would think are our allies are quite often not. So I'm gonna, where are we? Where's that camera gone? Right, we're doing this camera now. So there is an issue here which we didn't get to talk to, but there is a presentation at the conference about integrating drug, HIV, and tobacco harm reduction because we should all be allies, and sometimes we're not. So thank you to my commentary team for a very interesting conversation. Have a good conference, everybody. My name's Harry Shapiro. This has been the first commentary team. And now we're going to switch over to the main hall for an opening keynote speech on why is everyone so terrified? What's wrong? Why are we all terrified about tobacco harm reduction? Well, we're not, but there are people who are. Thank you very much. Thank you.
direction of travel for legislators and regulators seems to be primarily to ban new, safer nicotine products without due consideration of science and evidence. Obviously, communication is a key issue in this, and the importance of honesty and accuracy in this cannot be overstated. Given this year's theme, it's good to see a robust representation from media organisations here. And we're also very pleased to welcome all of our media partners for the conference: Drink and Drug News, eCig Click, Filter Magazine, Two Firsts, Planet of the Vapes, Tobacco Intelligence, Vaping Today, Vapor Poland, and RegWatch. We hope that we will get some positive coverage from the events over the next few days. Ill-informed and often misleading representations can be seriously damaging to individuals and communities at large. I think everyone in the room will be familiar with the panics caused by stories about Ivali and popcorn lung, which triggered disproportionate and damaging responses based on false narratives. Communication obviously has got two elements. There's those who provide the information, and there's those who communicate that information to a wider audience. The former have got an obligation to ensure their information is accurate and evidence-based, and the latter, the responsibility to ensure that the messaging actually reflects this. Inevitably, there'll be some questions to be addressed and disagreements about the content, but a balanced and informative approach, rather than a polemic, enables people to make better decisions and thus improve their health. Critical, inquisitive, and responsible journalism can play a major role in public understanding and can really help create the conditions where individuals' decisions are more informed. Misrepresentation, whether accidental or deliberate, does not serve individual or public health. With regard to the proceedings here in Warsaw, we ask that everybody approach them with an open mind, with respect for different points of view. In this field, where certainties are a luxury that we don't have, constructive and vigorous debate can assist in achieving a consensus that can give momentum to new approaches to tackle smoking, which we all know is the world's biggest killer. You'll see from the conference reader that the main programme has 77 hosts, speakers and panellists from 32 countries and comprising a range of professions, disciplines and perspectives. This year we have the GFN Film and Photo Festivals, which I hope you'll take advantage of and go and have a look at. And again, there's entries for these competitions from all around the world. Importantly, we have a number of social and networking events, which we hope will also add to your enjoyment and use of time in Warsaw. Our team are available to assist with any questions you might have, and we aim to make the experience of GFN 25 equal to our previous events. So, turning to our first keynote speaker, it's my pleasure to introduce Dr. Mark Tyndall. Mark is an internationally renowned physician and a pioneer in harm reduction. A proud Canadian, he's worked for over 40 years in Canada and internationally as a clinician, researcher, teacher and advocate, principally with a focus on HIV, illegal drug use and harm reduction. He's authored over 250 academic papers and presented a 2017 TED Talk on harm reduction. He's been at the forefront of needle syringe programs, methadone maintenance therapy, supervised injection sites, and most recently, safe supply projects that greatly reduce the risk of illegal drug use. This work included being the driving force behind the establishment of Insight, the first supervised injecting site in Vancouver in 2003. And this has since become a model for similar initiatives in other countries. He's currently a professor at the University of British Columbia and was previously the director of the British Columbia Centre for Disease Control. In 2018, Mark hosted the first public event on vaping in Vancouver. At the time, KAC was a partner for this event, and it certainly attracted a mixed reaction, including a boycott from public health authorities in the locale. Happily, this didn't deter Mark. In his determination to bring this experience with harm reduction into other fields, to bear on advancing tobacco harm reduction, and he remains committed to seeing an end to combustible cigarettes through vaping and other low-risk nicotine products. His book, Vaping Behind the Smoke and Fears, will be launched here in this room tomorrow at lunchtime. But for now, I'm going to invite him up to tell us all about what's so scary about tobacco harm reduction. Mark.
Okay, thank you very much, Paddy. And it's really my pleasure to be here in Warsaw to be part of the opening session for this conference. I've been to Warsaw on one other occasion in 2007, and the International Harm Reduction Conference was held here. And I checked back in Google, and Jerry Stimson opened that conference. So that was 18 years ago. And the other interesting thing is that the theme of that conference was harm reduction, coming of age. And it reminded me, if harm reduction came of age 18 years ago, nobody told people in tobacco control that. So here we're kind of starting from scratch almost again. I wasn't asked to do this session because of a long career in tobacco control or research. In fact, most people with long careers in tobacco control and research wouldn't be found at this conference. They'd be at the conference for a global forum on the elimination of nicotine if that was held somewhere else. So this is my opportunity to try to introduce my experience with harm reduction and how it would apply to tobacco control. Now, I got into harm reduction not because I took a doctoral degree in harm reduction, but because that became a big part of my work in HIV prevention. And I quickly learned that approaching behaviors and exposures that had inherent risk, the only approach would be to offer interventions that reduce that risk because we couldn't eliminate the risk. So that was really my motivation for a lot of the work that I did in harm reduction as far as HIV prevention. Now, I thought long and hard how I'm going to try and present this kind of information. And about a week ago, I watched the new Bono film called Stories of Surrender. So for those of you who couldn't care less about U2 or Bono, he wrote a memoir about 2 years ago about his life experiences. And he turned that into a 1 hour, 1.5 hour movie, and he demonstrated some of the things from his book and acted it out in role play. And that gave me an idea, maybe I could do that here. Now don't worry, I'm not going to sing or act things out, but I thought that I'd demonstrate some of the work that I've been involved in by coming up with little conversations that I've had along the way. So it's just kind of an experiment, but bear with me. After I do these little role play things, I'll summarize some of the learnings from the experiences that I've had, look at some of the barriers to harm reduction, and finally address some of the way forward that we can use and leverage so that we can move vaping and safer nicotine products forward. Okay. So I want you to picture with me the year's 1989. It's in Nairobi, Kenya. I'm doing my infectious disease fellowship, and I'm doing it with the University of Manitoba, who has had a long-standing program on sexually transmitted disease infections in Kenya. And all of a sudden, HIV hit, and it became sort of a major international center for this research. And as part of my infectious disease training, I went there to work on this project. And I'd never been to Africa before. I was married with 2 young children, one 2 years old and one 6 months old, and we arrived in Nairobi. And I was assigned to work in a clinic called the Special Treatment Clinic on River Road in Nairobi. And it was a part of the city that no tourists would ever visit. And there was a large clinic there that saw people who had problems between their waist and their thighs or suspected sexually transmitted infections. And they'd be referred to this clinic. And there would be up to 1,000 people lined up there every day. So picture me transported in here. One other context is HIV at that time was rampant. There was really very little documentation of the infections. Estimates of HIV prevalence ran from 10% to 30%. Nobody really knew much about the transmission. Obviously, there was no treatment at that time, and even very little testing. So it was quite a historic time to arrive in sub-Saharan Africa. So here I was at this clinic, a little cinder block room with a wooden chair and a wooden desk and an interpreter, and a lineup of young men would come into my room. And so picture a guy coming into the room, and I'd introduce myself, and Dr. Tyndall, what can I do for you? And he'd kind of point down that he had a problem below, and I'd examine him, and I won't get into the details of that, but I determined that he had gonorrhea. And actually, I became pretty expert at sexually transmitted infections. There was really only 5 possibilities. 2 caused drips and 3 caused ulcers. So you had either gonorrhea or chlamydia, or you had herpes, chancroid, or syphilis. So by the end, I could pick people out even before they came in the room. But anyways, so the conversation would be that I'd examine him, say that, I think you have gonorrhea, and we can treat that. I have antibiotics at the clinic, and I can treat your gonorrhea infection. But what I'm really concerned about is HIV. And as you know, there's a lot of HIV out there. We've done a test on you, and you're negative. But if you continue to expose yourself like this, I think you have a high chance of getting HIV. But fortunately for you, I have something that will help. And I gave him a condom, or I gave him a whole stack of condoms. And I said, if you use a condom every time you have sex, you won't get HIV, and you won't get these other sexually transmitted diseases. And in fact, if you use it, you have a 95% less chance of getting HIV if you use this condom. So he'd thank me, and I'd give him condoms and tell him that, when you run out, come back and we'll give you more. Fast track to Vancouver, Canada, 10 years later. It's now 1999. I had worked in Kenya I lived there for about 4 years, but was doing projects back and forth for almost a decade, and decided with my family that we'd settle in Canada for a while, and I wouldn't travel as much. And I took a job at the BC Centre for Excellence in HIV/AIDS. And then I was transported to another catastrophic HIV problem, only among people who were injecting drugs. And at that time, in that little community called the Downtown East Side, it was estimated that between 20 and 30% of active drug users were already HIV positive. And we knew that the way people got HIV is because they shared needles. And it was very difficult to get new needles. So people were basically forced to share. So somebody would come into my office, and I'd say, how are you doing today? He said, well, not so great, doctor. I have an abscess on my arm, and I'm, really heavy into the cocaine. I'm injecting a lot. I keep getting skin infections. I'm losing weight, not doing very well. And I say, well, look, I can treat your abscess. I have antibiotics for that. But I can also prevent you from getting HIV. And I have right here a needle. And if you use a clean needle every time you inject, I can guarantee you will not get HIV. And there's a new program down the street that they have a needle exchange program. And when you run out of these ones, I want you to take them and get new ones. And so if you can use a clean needle every time you inject, there's a 95% chance that you will not get HIV. And I think that's really important, because even though we have some treatment now, it's really difficult, and it's way better if you don't get HIV. Okay, fast forward to, again, in Vancouver, 2003. The situation by then is still HIV. There's a lot of needles out there. I don't see a lot of new HIV infections. There's still a lot of people that I'm treating for HIV. But the situation on the street is quite chaotic. There's a lot of homelessness, a lot of crime, a lot of open drug use, and things are really, people are getting a lot of pressure to clean this up. And the politicians are really clamping down, and law enforcement's becoming more and more aggressive in trying to get people off the streets. So somebody comes into the office. I'm, again, sitting in a small office, and I ask them, how are you doing today? And they say, well, doctor, I'm doing really terrible. I don't have a place to live, sleeping under the bridge right now. I don't have any money. I'm still injecting. I'm having to steal to get the drugs I want, and life is really terrible. In fact, last week somebody stole all my shit. I have nothing, and I'm really quite scared. And so I'd say, well, look, this sounds like a really dangerous situation for you. What we've opened on Hastings is a supervised injection site. So instead of injecting by yourself under a bridge that's dangerous, I think if you come to the supervised injection site to use your drugs, it's a clean environment. There's clean rigs there. There's people that can help you. If you have medical questions, they can help you. There's social workers there, and it will help you, to not to have to inject off the street and being chased by police all the time. And if you go to the supervised injection site, there's a 95% chance that things will be better. You won't overdose. People will be there if you did make a mistake and took too much drugs to save you. And I really think that this would be an excellent thing for you to get involved with. So he looks at me and says, "Yeah, doctor, that sounds like a really good idea." And they're off to the supervised injection site. Fast forward to 2019. So at this time, I'm the director of the BC Centre for Disease Control. I'm responsible for a wide range of public health programs, but I'm still most interested in injection drug users and what was going on in the community. And we noticed that overdoses were skyrocketing in the province of British Columbia. And it started about 2015, 2016, 2017. Every year, it seemed to double the number of people that were dying. And we knew from the toxicology that it was because of fentanyl. So there was no heroin left. We were a city that had a lot of really high-quality Afghanistan white heroin for decades, and all of a sudden the cartels must have decided it's too risky and expensive to do this. Why don't we give people fentanyl, which we can mix up in a bathroom somewhere, and it's super cheap, and people can get quite high on fentanyl. The problem with fentanyl is it's about 20 to 100 times more powerful per gram. So people were buying these flaps, what they thought was regular powder, and they were not waking up. And this problem is still continuing. The numbers are going down slightly, but at the peak, there was 2,500 deaths a year in the province of British Columbia, and about 12,000 across Canada, about 100,000 in the United States, all due to fentanyl. And clearly, people were not going to stop using drugs, even in light of the imminent risk of death. And so the only ethical way forward, I thought, was to give people a safe supply of pharmaceutical drugs and to avoid buying street drugs. And I got money to develop a program where I had these very secure vending machines that were biometric. People were enrolled in the program, and they could go and show their palm, and they'd qualify, and a bunch of hydromorphone pills would dump out of the machine, and they could go every day and get their medication and wouldn't have to buy street drugs. And so somebody comes into the office, and I say, how's it going? And they tell me, really terrible out there. A lot of my friends are dying. I've overdosed 3 times in the last month. If I wasn't helped by somebody with naloxone, I'd be dead. And I said, well, this is not, going to end well for you, and I'd like you to be in this program. You can come to the machine. It's open 24/7. You can go once a day. I can give you medications to use. And if you get in this program, I can guarantee you that 95% less chance you'll overdose. I mean, it's not impossible to overdose with these hydromorphone pills, but it's highly unlikely that you will. And I really think you'd be best not buying these street drugs anymore, because you really don't know what's happening. And so the person enrolled in the program and didn't overdose anymore. That's harm reduction. So let's fast forward to 2020. I'm sitting in the clinic still. Things are calmed down a little bit. I mean, there's still a lot of overdoses going on. Not everybody's getting safe supply. Not everybody's going to supervised injection sites. Most people are using clean needles. Somebody comes into my office and I ask them how they're doing, and they say, well, I'm doing okay. I'm off. I'm not buying street drugs right now. I'm on a methadone program. I have a place to live, but I have this really bad cough. I'm not feeling so great. My exercise tolerance is really low. I used to walk all the time. I can't do it anymore, and I can't get rid of this cough. And I said, well, how long have you been smoking cigarettes? And well, I started when I was 15, and now I'm 40, so 25 years. And I'd say, well, I think most of the problem you're having with your breathing is because of your smoking, and you should really, you really need to get off these cigarettes. And what I'd like to offer you is I have vapes, and these will, I think when you try them, you'll almost immediately feel better. Within a couple of weeks, I think your cough will get better, and you can wean yourself off cigarettes. And I'm going to give you a starter kit, and then you still have to pay for it eventually, but they're, excuse me, actually cheaper than cigarettes once you get on it, and I think this will really help you out. And it was a 95%, they're 95% safer. So I really think this would be, this would really be important that you start vaping. Thanks, Doc, and he's off. Now, that conversation happened because he saw the crazy doctor who gives out drugs and needles to people, and now he's giving out vapes to people. If he had seen the doctor down the street, the conversation might have been a bit different. So this is a conversation with the other doctor. Somebody comes in, how are you doing today? Or the doctor would say, how's the steroid inhalers that I gave you last time? Are they helping and with your breathing? And they'd say, well, Doc, no, they didn't really make much difference, but my friend gave me some vape, and I've been starting to vape, and I feel quite a bit better already when I've started vaping, and I've really cut back on my cigarettes, and I think, like my friend, I can start vaping. And the doctor would pause, and he'd go, "You're what? Haven't you not read about vaping? Do you not know anything about vaping in the news?" And he'd said, well, no, I heard that it might be a little safer or something. It might be safer, but do you know who's using vape? Well, my friend's using vape. Kids are using vape. Haven't you seen the high school kids? Everybody's using vape. It's an epidemic, and they'll see you vaping and think it's okay. I don't think it's okay. And we can't be allowing you to get vapes because it's going to end up in the hands of kids. And don't you know who makes vapes? And the person would go, I don't know, vaping companies? No, big tobacco companies. Those tobacco companies are now addicting a whole new generation of people to nicotine. They don't care about you. They just want you to buy new products from them. And this is a huge scandal. I don't think you should be vaping. These tobacco companies are out to get you. They want to hook you on something else. And haven't you heard of popcorn lung? This is something that could kill you, and we don't even know in the long term what's going to happen with these things. You might feel fine after a week or 2 weeks or a month or a year, but what about 10 years, 20 years, 30 years from now? We don't know what these things are going to do. And the guy will go, well, probably I'll be dead in 30 years, but yeah, we don't know. So if you continue this path of vaping, I don't really want to see you as a patient anymore. And I've been trying so hard to help you with your breathing. I've given you steroids, and we're doing a chest X-ray every year just to find out if you get so we can detect lung cancer early. Patient would I kind of hoping to avoid lung cancer, but anyways, I could go on, but that's a much more common scenario for most of the physicians in Canada who would actually discourage people from vaping and basically tell them they should continue with smoking. So those are my 5 scenarios, and they're all about harm reduction. They're all like almost real-life examples. And there's some common themes to all of this thing. So you'll notice that I use the 95% effectiveness taken from Public Health England, but it's really true. All these harm reduction things are really effective. So like extremely effective. And I can tell people that if you use a condom, you won't get HIV. If you use a clean needle, you won't get HIV. If you use these drugs, you will not die of an overdose. I mean, these are highly effective interventions. They're also extremely simple. So these are, most of them are little pieces of plastic that we're doing there. It's not a big deal. We don't need big infrastructure or big investments to do it. They're all based on strong scientific evidence, and not only strong scientific evidence, but just common sense. So if we know how HIV is transmitted and we can block it, then it won't be transmitted. If we know the chemicals that cause lung cancer, and we can give you something that doesn't have those chemicals, then I don't think you're going to get lung cancer. So there's a lot of common sense as well as strong academic evidence to support these interventions. They're extremely cost effective. So because of the simplicity of them, compared to what the outcome is, treating a case of HIV in Canada over a lifetime probably costs over $1 million. I mean, and a needle or a condom are just pennies. And so the cost effectiveness argument of these interventions is very clear. They're easily scalable. We don't need an infrastructure. We can just by our policies and just supplying these things, we could scale them up big time. And probably most importantly, they're enthusiastically supported by people who will benefit from them. So this is not a nanny state type thing we're trying to foist on people. This is like what people want and what people need. And so there's people knowing that they could get HIV are quite happy to use a condom. People injecting drugs are quite happy to use a clean needle, and people using nicotine are generally quite happy to find alternative sources. So these are driven largely by the people that will benefit it from the most. So, sorry here. So with that in mind, it's kind of a bizarre twist that these interventions are controversial. So I've talked about all these things as though it should be a slam dunk, but it's not. And it's not because they don't work, it's because of ideology. And this prevailing thought that anything that we do will make things worse. So this is not anything that doing right now, but if you give people drugs, it'll be worse. If you give people needles, things will get worse. If you start giving people vape, things will get worse. And there's three main obstacles then to harm reduction. One is this focus on primary prevention, which I'll talk about, stigma and discrimination, and finally apathy. So this idea that public health is really about primary prevention really doesn't make any sense. I mean, I'm not going to sugarcoat addiction. I've personally seen the worst that can happen when people get addicted to heroin and crystal meth, when they get addicted to alcohol and even nicotine. Things end up very badly. I know people have trouble stopping when they start, and I know that primary prevention on the surface makes total sense. But I also know that substance use and addiction are extremely common, that I know it's naive and unhelpful and even unethical to tell people just quit. I know that people are using drugs for a reason. I know that everyone has their own story of why they're using these drugs, and I'm not really in a position to judge that. I know that most people, addiction is not forever, so most people get over it. I know that prohibition doesn't stop people from using drugs, so any ideas we had to ban things will not end up well. And I know that if we put people in difficult situations where it's difficult for them to access the drugs or what they need, they'll find ways to get them in a much more dangerous way. And this idea of catastrophic scenarios when things happen, again, doesn't make any sense. With condoms, when I was in when I was in Kenya, there was a huge backlash for giving out condoms because what would it tell kids? Wouldn't it encourage them to have more sex? Wouldn't giving clean needles out to people injecting drugs encourage kids to start injecting drugs? Wouldn't supervised injection sites encourage kids to go and start joining the community? I mean, I've taken my own children down there, and I can tell you that it's not a place that they want to start going to. And vaping, the whole idea that we really need to control this because it's going to affect the kids. These are really made up catastrophic stories that will never happen and have never happened. The second thing is really just basic stigma and discrimination against people. So the history of harm reduction is controversial mainly because of the people it's designed to help. So generally people choosing risky or socially unacceptable behaviors are frowned upon in society. And this idea of moral panic comes up where we create all these scenarios and really discriminate against people that are most vulnerable and most in need of our help. So you just imagine a scenario where 15% of Canadians, or 15% of the richest Canadians, Americans, Europeans were smokers. And they knew that it cut 10 years off their lives and resulted in a number of chronic illnesses. Then along came something like vaping that could reverse that. Do we really think we'd be holding this conference? I don't think so. They demand that they get a safer product. So there's a lot of discrimination and stigma that's attached to our responses. Also, imagine, like from an international perspective, what if 50% of American men smoked and 15% of Vietnamese men smoked? Do you really think that Michael Bloomberg would go in there and ban vaping in North America? It would not be possible. He wouldn't do that. So he can do it in Vietnam because they're poor and reliant on Americans to give them aid and listen to Americans. But basically, he's depriving a whole nation of getting access to a safer product. So the third thing is just apathy and how we've become so comfortable with the status quo. And that applies to the medical profession. So we've developed a whole medical system in some countries around smoking. So we have excellent cardiac care wards, we have excellent lung cancer centers, we have excellent respiratory clinics, and people need people to keep coming, and there's really not a lot of impetus to make any changes with that. And the other irony of people who work in these type of clinics only see the patients once something bad has happened. So if you have a heart attack, you see a cardiologist. If you have a lung cancer, you'll see an oncologist. If you have bad COPD, you'll see a respirologist. And they don't really think for 1 minute about prevention. They're really focused on helping people at their current situation and don't really look at the big picture of prevention. But the point is, we've really created a whole medical infrastructure around treating these chronic illnesses due to smoking, and nobody's in a big hurry to change it. Also, tobacco control organizations aren't in a big hurry to change things. So they've really had decades of working on abstinence-based programs. I think at the very beginning, when safer products became available, they were cautious. But now, instead of starting to discuss the possibilities of how these could help people and help people's health, they just continue to double down. And now, 10 or 15 years into it, it's really hard for these tobacco control organizations to take a big breath and say, maybe we were wrong all along. And that's probably not likely to happen because then people would ask, well, what else have you been wrong about for the last 10 or 15 years? So there's a lot of credibility at store there, and it's very hard, I think, for people to change course when they've doubled down and dug in so deep against these safer products. And finally, tobacco companies are also not pushing hard for change. So certainly, there's a lot of industry here, and there's a lot of new products, and the websites of PMI and BAT are very forward-looking and want to go smokeless, but they seem to be in no hurry. And they're quite happy to kind of let this transition happen slowly, don't really want to take leadership in it, and kind of let the consumers drive things. And that's so much different than how vehemently they've pushed back on any tobacco control regulations in the past, where they've had whole teams of lawyers trying to change policies. In Canada, and I think in many countries, tobacco companies aren't allowed to say that vaping is safer. And so that's a huge problem as far as getting a message out there. And you would think that these companies would have a whole team of lawyers trying to push back on things like that, but it really hasn't happened. And the slow transition that these companies will support, but are not aggressively trying to make this change quickly. So I think the future of safer tobacco is promising, but it's taking far too long, and we really need to find ways to speed up this transition that I think will inevitably occur, but there's things that we can do right now, and I've come up with 3 things. So one, and I get this information from my experience with community in other harm reduction, is that community activism is extremely important, and we need to encourage and get people who have started to vape and people in the community who can really advocate for themselves and have a voice. And I think we can all gather around and really help these groups to have a voice. You'll hear from Maria in a couple of days, and she's kind of a Canadian hero to try to mobilize the community and push back on policies that are discriminatory and damaging. We also can use people who can speak truth to power. So there's people in the world who are coming out for vaping, and I think we need to do a better job and really get to policymakers and really put pressure on it. And we have so many enemies out there, people that are fighting back, and it's very difficult to keep up with it. I get a lot of requests, did you read this article or what this person said? You need to respond to them, and it's important that we do that and to try to push back, but we need a whole team of people and organized to make sure that we keep on top of all the false claims and narrative that are out there. And finally, to use the legal justice system better. So I know with other harm reduction things that I've been involved in, taking cases to the courts has been very successful. So the supervised injection site, needle exchanges have all gone to Canadian courts, and they've ruled in favor of access to these things. And I think it's pretty hard from a justice perspective to say that people who want a safer product can be denied. And I think the legal system would be in our favor to open up access to these things. And I think we need to bring more cases. And I know in Canada, I've been involved in one case around flavors, and that I think it's going to go up the court system, but I think it will be come out in favor that you cannot tell people that what kind of nicotine flavors that they can access. So I think I'm going to end there, but I just want to tell one last story. So just bear with me for one more minute. So one of my experiences with HIV was around HIV treatment. And I started medical school in 1982, and the first HIV was, the first cases were 1981. So my whole career has been around HIV. And at that time, I saw mostly young gay men dying of HIV, and there was really no treatment. And there was a turning point about 1996 when combination antiretroviral therapy was tested, and to everybody's great surprise, it was highly effective. So all of a sudden, these people that have been told that, you have a few months, all of a sudden got a new life. And quickly, in rich countries, antiretrovirals became widely available, and many lives were saved from that. I was still working on and off in Kenya during that time, and I'd go back after working in a clinic and seeing these people come back to life in Canada, and then go back to Africa and have to explain to people, well, sorry, there's no treatment for you. It's too expensive. The companies don't want to release their patents. They're not willing to, rev up manufacturing of these things. And this went on until 2003 or 2004 when PEPFAR, the American under George W. Bush, put in some billions of dollars and set up these generic manufacturing plants, mostly in India, and really made a big effort to get medications out there. And that's always thought of as a success story, but from my perspective, that was 8 years of people dying unnecessarily. We had treatment, and literally millions of people, mainly in Africa, died because somehow we weren't able to get them the medication they need. Now, you could ask me, well, what are you talking about this at a nicotine conference for? But I think there's a lot of similarities between smoking and HIV. And they're both behaviors, or both ailments that are very slowly progressing. So HIV, when they're stealth. You don't even know you got infected, and it's probably between 10 and 15 years before you get your first opportunistic infection. And much like smoking, you don't really realize anything's happening until 20, 25 years later, you start developing symptoms, and some of them are quite severe. And if you look at it in that way, that these are similar things, denying people safer products is basically like denying people antiretroviral treatment. Because we'd be saying that, you're going to die from this. We have things that can help you here, but we're not going to be able to get them to you right now. And then in tobacco harm reduction, it's even more bizarre, because we're not only saying that we're not going to supply them to you, but we're going out of our way to ban them. And we're going out of our way to make things harder to get. This conference will be talking about flavor bans and banning disposable vapes. I mean, these should be really small print things. We should be doing everything we can to increase access and increase the acceptance of these products, make them as easy to get as possible so we can get as many people off cigarettes. But that is not what's happening, and I really believe there's some urgency to this. So the HIV analogy might be a little out there, but from my perspective, I don't think it's far-fetched. And I think the policies that make vaping and safer nicotine products harder to get for people who smoke is much equivalent to denying them the HIV treatment, and they're going to die. So thank you.
Thanks, Mark. I think you made a very compelling case there for a job with the Global Forum. It's yours. Before I open up the discussion and for questions from the floor, I'd just like to introduce Dr. Carolyn Beaumont, who's going to make a short response to what Mark had to say. Carolyn is an Australian general practitioner. She founded the Australian Smoker Health National Telehealth Clinic, which was started in response to Australia's policy of having vape prescriptions. It's an odd country, to say the least, but she no doubt will tell you all about that. She also combines this with work as a locum general practitioner in remote Australian communities, so understands firsthand the complex healthcare barriers the smokers from these regions face. With the Australian government's hostile stance towards vaping, Carolyn plays an important role in keeping tobacco harm reduction to the fore. She's well known for her media engagement, presentations, publications and conference involvement. Engagement with the media has also brought its trials with some negative coverage related to her efforts, particularly in trying to engage with younger smokers, but she remains committed to the principles of harm reduction. She's currently writing a book which will be entitled Unfiltered, a collection of interviews with doctors from the fields of cardiology, vascular surgery, anaesthesia, neurosurgery and oncology. It aims to provide a compelling narrative across medical specialities which focuses squarely on the harms caused by smoking and not by nicotine itself. So, Carolyn, can you please come up and let's hear your response to Mark. Thank you.
It's a tough gig, isn't it? It shouldn't be this hard, right? Helping smokers become smoke-free and healthier via a range of alternative nicotine pathways. We shouldn't need to put our reputation on the line, risk media censure and medical board discipline, and amid false accusations of being beholden to the tobacco industry. But as a doctor, that's exactly what I've experienced. No wonder tobacco harm reduction isn't attracting more health professionals. So what on earth are two doctors doing on stage for the opening of GFN 25? It's incredibly exciting, and I hope the voice of health professionals continues to play a leading role in promoting THR. Not only doctors, pharmacists, nurses, dentists, social workers, psychologists, to name a few. I'd like to see a show of hands in the room. Who is a health professional? Quite a number. So maybe not quite 20, but more than 10. And let's aim for double that next year. And even though that number in the room is small, the impact a single health professional can have on helping many smokers is remarkable. So traditionally, the role of Keynote respondent is to critically analyse the issues raised, maybe bring some alternative points of view. However, my job has been made very easy. Everything Mark says, I can only nod in strong agreement. We are very aligned in what we see as the key issues in THR: health inequity in heavy smokers, public education about tobacco harm reduction, and concern about the stigma of choosing to smoke, which leads to apathy. Apathy by the general public, and apathy, or worse yet, punishment by policy. Mark highlighted the importance of education and health equity issues for smokers. I'll expand on this by sharing my clinical experience. I choose to practice medicine in lower socio-economic towns, which inevitably have much higher smoking rates than nationwide statistics suggest. It's an incredibly rewarding area of medicine to practice in, and I can really get to that very early level of primary care prevention, of reducing the cardiovascular risk and screening early for the lung cancer risk, and yes, getting them onto vaping instead of smoking. And it's very rewarding because we're stopping it right at the start. This year, though, I did some locum placements in a remote Australian mining community. It's a typical remote community, hundreds of miles from major towns. In fact, this particular town is 1,500 kilometres from its capital city, Perth. For all of you northerners, London to Rome. Smoking rates are higher than average, cardiovascular risk is high, mental health is poor, substance abuse is rife. The scale of geographical isolation in Australia is astonishing, and it impacts their healthcare in so many ways. For example, these towns can't retain regular doctors. Issues such as lack of childcare and poorer outcomes in schools are reasons why doctors won't relocate with their families. So towns like this have a series of locum doctors staying instead maybe 2 weeks like I did, or 2 months. There is no continuity of care, and even medical record keeping is affected. I did not truly appreciate the degree and causes of health inequity in high smoking populations until I worked in clinics like this. During one 2-week placement this year, I was able to engage about 20 smokers in tobacco harm reduction. They were current smokers who had tried to quit at various times with existing nicotine replacement therapies, but without success. Although they might have seen me for an unrelated reason, and yes, the appointments were brief, it was still possible to briefly mention the risks of smoking and to offer some alternatives. I would tell them that alternatives include patches and gums, but also pharmacy vapes. Note that in Australia, as Paddy mentioned, vapes can only legally be purchased from a pharmacy. I'll leave my thoughts about that to one side. Maybe you need a stiff drink to go further with that one. It was always interesting to see their reaction when I said pharmacy vapes. It would range from, isn't vaping as bad as smoking? Or even the memorable Aussie chap who bluntly stated, I wouldn't vape if you shoved it up my... But he did finish the sentence in that case. But more commonly, patients were interested and open to learning more about vaping. They liked that the quality of vape from a pharmacy was regulated and that access wasn't too difficult once I pointed them in the right direction. Ultimately, gaining their trust and letting them know we could chat further in a non-judgmental way was a crucial first step. A few came back to discuss further, and some followed up with me separately via my own telehealth business. I was able to supply them with some information and a script, and they could order their pharmacy vape products through some online pharmacies in Australia. I even managed to convince a few to have a lung CT scan due to their high risk of lung cancer. They would have to travel 400 kilometres, or London to Amsterdam, for a CT, but they did take my advice seriously, and I can only hope they follow up. Unfortunately, I was only there for 2 weeks each time. But if other locum doctors in this remote community could continue these discussions, the impact on smoking rates in this mining town would start to become significant. So although we won't easily get media or politicians on side anytime soon, we must focus on educating health professionals about tobacco harm reduction. It's simply about offering smokers more solutions, about acknowledging that many don't want to give up nicotine and they're sick of being lectured to and judged by doctors. I'm not telling doctors to ignore existing replacement therapies. I'm simply telling them there's another extremely effective tool in the toolbox. I want to briefly talk about the future of nicotine products, in particular nicotine pouches. And all I can say about this is 3 things: innovate, regulate, educate. Whatever helps a smoker quit has to be considered seriously and not just dismissed as yet another tobacco industry ploy to addict the next generation. Surely we could remain open to new nicotine technologies and at the same time ensure they remain regulated and as safe as possible. Of course, the trick is, how do we prevent teenagers from accessing pouches? I do wonder, though, if the general media and political concerns about underage nicotine pouch use is premature. Nicotine pouches on initial use are quite irritating and burning to the gums. It takes persistence. I'm only basing this on my hunch, but maybe teenagers won't be as excited about nicotine pouches as they have been with vaping. If their initial experience of a pouch is burning and an extreme and unpleasant head rush, maybe they won't bother experimenting further with it. This leads me to teenage vaping, which I'll address briefly. Such a loaded topic and the darling of media and politicians. It ticks every box. Who doesn't want our kids to be safe and drug-free? Who doesn't want to stick it to the tobacco industry? A politician would be crazy not to jump on the teen vaping bandwagon. I would like to consider teen vaping from a more holistic perspective. In my clinical experience, the numbers of undiagnosed and untreated mental health conditions such as ADHD must be considered in their use of vapes or other nicotine products. Also, is school demanding too much? Is there too much homework, too many late nights, poor sleep quality? Excessive phone use worsens these issues. Quite simply, I see that many teenagers are exhausted and overwhelmed. Is it then surprising teens resort to whatever stimulant they can easily find? Many schools these days have fancy cafeterias and coffee is not banned for kids. Maybe we shouldn't be too surprised that teenagers seek out whatever substances help get them through. Sounds like I need something to help get me through there. Developmentally, adolescence is the time of establishing our own identity and becoming independent from our parents. It's a time of excess and curiosity. Adolescence can be an overwhelming period full of extremes, seeking peer approval and craving new experiences as usual. Maybe it's unrealistic to expect teenagers to not be interested in nicotine. But let me be clear, teenagers should not be vaping or becoming reliant on nicotine. And if they are relying on nicotine to self-manage an undiagnosed condition such as ADHD, social anxiety or a mood disorder, then what is needed is good medical care. Of course, accessing good medical care is easier said than done in many countries. What tends to happen instead for a teenager who vapes is that they're caught, maybe even suspended from school, which simply teaches them to be more careful about where they vape. Or they're never found out, they continue to vape on the sly and no one is ever the wiser. Either way, in my clinical experience, it is very rare that the vaping teenager will have the chance to see a compassionate doctor who looks at the whole person and doesn't just judge them for being a teenage vaper. Last year, I attempted to promote my services to help teenagers stop their problematic vaping. It was an expansion of my existing smoker health clinic, which helped adult smokers get a pharmacy script. The concept was that teenagers, just like adults, need a holistic approach which considers their reasons for vaping, their physical and mental health, their sleep quality, their triggers for vaping. But fundamentally, the approach was to simply engage the teenager in non-judgmental conversation and start the process of them re-examining their vaping use. Unfortunately, last year, certain media forces took too much of my time and attention, and I reluctantly had to shelve this concept for the time being. I was reported instead of attempting to start a clinic for teenage vaping, which subtly but successfully managed to imply that I actually want teenagers to vape. Nothing could be further from the truth. So my take on teen vaping is that it's complex. There are many reasons why a teen will try vaping and continue it, but at least it's diverting them away from smoking. There's much data to support this. This is a generational win in my books. What does sadden me, though, is that the vapes they are using are generally illicit, unregulated, disposable vapes. Apart from smoking, this is the worst possible type of nicotine product. And sadly, with so many barriers and restrictions in many countries about accessing better quality products, it seems likely that today's teenagers will grow up only knowing of illicit disposable vapes. What is really needed, apart from effective regulation of vapes and the removal of the illicit market, not so easy, is a massive investment and commitment to accessing good medical care. These are huge requirements. I wish I had easier solutions. I don't. Mark also raised some excellent points about the importance of public education and community involvement to help remove the apathy and stigma about tobacco harm reduction. And my contribution to this is that clear, simple messaging is crucial to cut through the noise. Think about the signs we universally recognise. Stop signs. Green man means we can safely cross the road. No smoking signs. Let's consider airports. Many have a smoking room, a weird fishbowl packed with smokers and advertising. Unfortunately, vapers in airports have nowhere to go except these smoking rooms. Vaping and smoking is sadly packaged into the one evil, and the general public continues to believe that. Signs and symbols are powerful. I would love to see separate vape-only spaces in airports with clear signs showing vaping only, no smoking. An instantly recognisable sign easily seen by the millions of people passing through global airports. Whether or not someone vapes or smokes, seeing this sign may spark some recognition that vaping is different to smoking, that vapers need to have a separate space to smokers if they choose. I would love to see that extend to any public area that has a designated smoking space. Apart from the powerful public health messaging this could convey, imagine the benefit to vapers who are overwhelmingly ex-smokers. I can't think of any other product where the less harmful option needs to be used in the same space as the harmful version. Imagine if a recovering alcoholic could only have their soft drink at a bar, or someone who fought their food addiction could only have their salad in a lolly shop. It's ludicrous and damaging. Forcing vapers to use smoking areas exposes vapers to smoking triggers and the risk of relapse. So if I had the power to make one change right now, it would be to create vape-only spaces in public places such as airports. And that's me, over and out, hopefully within 10 minutes. Thank you.
Thanks, Carolyn. We're now going to take some questions, comments from the floor, and also potentially if anybody is actually wanting to ask a question who's watching online, we'll take a few questions from those as well. So there are people in the audience, volunteers with microphones, so if anyone would like to ask a question or make a comment, don't be shy. Gareth.
Hello. Yeah, that's good. Listen, thanks to both speakers for excellent presentations. I'd just like to ask Mark, one of the things my name is Gareth McGovern, I work as a GP addiction specialist in Dublin, and a lot of the sort of barriers that we're sort of seeing in relation to vaping, you know, you go back, I think you said you were in medical school in 1982, I'm a little bit younger than you, but we had a lot of this barriers to try and, like in Ireland, for instance, opiate substitution treatment probably didn't arrive until early 90s. It wasn't formalised until 1998. We had a raging injecting drug use problem for probably about 15 years. How many people died of HIV, hepatitis? It was actually public health, who sadly are probably our enemy today in relation to this, that changed that. They said, listen, there could be a HIV epidemic, there could be a hepatitis C epidemic. We need to get these interventions, needle exchange. We now have the first injecting room in Dublin. What's very interesting is if you look at the data, I think there's about 100,000 people a year who die from drug overdoses. There's 8 million a year who die from cigarette smoking directly. You would think that this would be a public health emergency. You would think that something like vaping, which is a game changer as far as I see it, not just vaping, but safer nicotine products, will be something for people in tobacco harm reduction policy positions to prick up and say, hold on, we can make a real dent into these 8 million deaths a year. Rather than do that, they're actually running counter to that technology that has a really great potential in reversing the damaging effects and the mortality related to cigarette smoking. Listen, thanks for listening to my question.
Yeah, I mean, I've spent over 2 years writing this book, and the more I got into it, the more ridiculous it really seemed to me. It's just so obvious to me as a public health person that we should be embracing it. I mean, it's I've had, I don't know, 100,000 conversations with people in public health. The one thing that's striking to me is they don't know much about it. They haven't. I'm pretty convinced that most haven't even thought through it. They had an opinion right from the beginning that they're called e-cigarettes and they must be the same as smoking. They stick to this idea that there's all kinds of chemicals in vape, even though some of these studies are 10 years old. Like, it doesn't, you know, it's just not true. And they really have not made any effort. And I think socially, from their medical perspective, they're so ingrained into that people can stop smoking. Like, quit smoking is continues to be. And this is, you know, it's quite amazing to me that people would have somebody in their practice who smokes cigarettes, and for 20 years they tell them to quit smoking, and they didn't, and they couldn't, and that didn't change their like, you know, if you asked somebody to do something and after 20 years they didn't do it, you'd probably think maybe there's something else I should be trying. But it's just like, it's just so programmed that why should you use an alternative nicotine product when it's just easy to quit? And, you know, why would you, you know, why are you worried about HIV to stop using drugs? You know, why don't, you know, yeah, so I think we've been socialized in our medical training that cigarettes, people can quit, and that that should be our go-to thing. And then my second point, I'm just always amazed how little people know about it. How, you know, they're so entrenched in it. And when I try and tell them, no, like, these chemicals don't even exist in vape. Like, it's implausible that you'll get lung cancer. Like, there's no mechanism for that. And they don't seem to know that. So I don't know. I can take if I get 10 minutes with most people, I can at least get them to admit that it's safer. But it's doing it person by person is a really arduous task.
Sure. It's on? Good. Okay. Yes, I think all I would add to that is, you know, absolutely, Gareth, the scale of the problem is just staggering. And I compare it to like the figures of the COVID deaths. For example, in Australia, there were more smoking-related deaths every year in Australia than there were for the entire COVID pandemic over 3 years. And, you know, we rightly addressed the COVID pandemic as being of a huge urgency, and we needed to do something right now, and even if that solution wasn't perfect. And so, you know, COVID vaccines were produced and they were tested, and we know that they weren't perfect, and we knew we couldn't wait 10 years to get all the data on the vaccine, but we knew, look, it's safe enough for now, and the threat of COVID is so bad that we just need to get this vaccine out there. And so that's what happened. And we're still learning about the vaccine, but I think it's a fair call to say, look, yes, we had to do something. And then as we can now relax and the threat of COVID has fortunately receded and we can now exhale and spend time on the vaccines and really fine-tune them, that's good. You know, I think that's a reasonable way to go. And so why can't we be doing that with vaping, just saying, look, we don't have the 50 years of evidence that we need, but we've got a pretty damn good product right now, and we've got something that's killing more people than COVID did and is going to continue to do forever. Let's just do something. Let's just get these vapes out there, and we'll start to refine it as we go, but at least we're going to stop that lung cancer and heart attack and stroke in its tracks.
Anybody else? Gentleman at the back. Next.
Hello, good morning. I'm Baharudin from Malaysia. And I actually very captivated by the life journey as shared by Professor Dr. Mark Tyndall just now. And I think what you have done probably saved a lot of life. And I think basically what we are, you know, as a doctors, that is what is our main contributions about saving life. And I think about this tobacco harm reduction is about saving life. But the problem is whatever measures that we do may not be seen as something that is palatable for some segment of the society. I would like to share with you, in Malaysia, we are basically a very conservative society. And whatever things that we mentioned just now is rightly so, is probably considered as unacceptable to them. And coming to the smoking campaign and whatnot, they always adopt this all or nothing. Either you stop smoking or you continue smoking, but there's no other way in between. And for me, as I'm basically as otorhinolaryngology, ear, nose, and throat surgeon, and I see a lot of patients. They have allergic rhinitis, they have chronic rhinosinusitis nasal polyp, bronchial asthma as well. And I think for them, not to be exposed to smoke probably will actually solve a lot of their issues and problems. But the thing is, when we talk about vaping, we talk about that it's not being supported by government. And I think for my patient at least, it will benefit them. And I think probably what we need to do, and from my own perspective, is that probably we can still convey the message in the right way, work together in a concerted effort to enlighten everybody as to the benefit of having this sort of options. At least there is an option for these people to at least continue in this sort of habit without causing more damage to them as well as their, the other people that is surrounding them. And I think it's not going to be easy because when those who are in power not supportive of this sort of efforts, it is not going to be something that is going to be smooth sailing. And what I've seen over the years is whenever anyone spoke about this, it will be something that will be like, they will be going, the efforts will be going to discredit them. And as always, the messenger gets shot first. So when they want to hear what they don't want to hear, then they will not be able to, they will not be supportive of this sort of, efforts or measures. And I think I give you the credit for sharing that very interesting journey. But then again, I think probably what we need to do is probably keep on giving the right message and being consistent in what we can do to save life and make life better for everybody. Thank you very much.
Thank you. Gentleman further down the aisle. I'll just take this comment or question and then I'll ask the panelists to respond.
Okay, thank you. I'm the KJ from Taipei Medical University in Taiwan. I have a question for Dr. Caroline. I fully agree with you about we have the smoking room for smoker and we should have the vaping room for vapor. But in Taiwan now we ban e-cigarette, but we permit heated tobacco products. So how do you think about the people who use heated tobacco products? Because the toxicity, I think, for the heated tobacco products is between the vaping and the smoking. So should we have the room for them, or maybe we should put them into the smoking room? That's my question. Thank you.
Oh, thank you. What a great question. Yes, so if anyone didn't catch the question, basically, yes, it would be good to have smoking rooms and a separate vaping room in places like airports, but what about people who use heated tobacco products, or HTPs? Much safer than smoking, but maybe is the exhaled aspect of things like that worse for vapors? I'd have to admit I don't know in terms of the exhaled aspect of HTPs. As far as I know, I don't think there's much of an issue, to be quite honest. Obviously, it just makes sense to have them in with vapors, but again, it's one of those things, as the fellow from Malaysia, I think, was saying over there, we need to have unity and consistency of our messaging. So again, it would be something like, smokers here, everyone else over there. And let's just get that initial thing of smoking versus everything else. And then we could sort of fine-tune it to, you know, depending on the market and the country. Yes, there might be an HTP area and a vaping area and whatever. So, yeah, I think very much big picture, smoking here, everything else there, consistency, unity of messaging, symbols.
Mark?
Like she said.
Any more? Gentleman at the front.
Hi, Caroline. I'm Rashidi. I'm a consultant primary care physician. Here, I'm here. I'm in front of you. I was sitting behind you. I'm a consultant primary care physician and an addiction specialist from Malaysia. As a fellow primary care physician running a quit smoking clinic in Malaysia, I'm curious, in Australia, who primarily funds the use of e-cigarettes for smoking cessation, and what's the strategy or evidence which has been used, which is most effective in engaging policymakers to support their use as part of the National Harm Reduction Program?
Sorry, I'll just make sure I've got the question correct. So you asked who funds the,
the use of, you mentioned that you use e-cigarettes as part of your smoking cessation program?
Yes.
Yes. And who funds it? And how do we actually convince policymakers to actually use it?
Yes. So sort of asking who funds the clinic that I run. Well, I've set that up myself. It's the great thing, I guess, about telehealth and learning how to set up a website through YouTube. You can do, you can actually establish a medical practice quite easily. So I've set that practice up myself, and the patients pay a private out of pocket. It's the type of consult it is via telehealth doesn't qualify for a Medicare rebate. So it's a privately sort of funded clinic, very minimal overheads. So it's very easy to set up actually, which is great. I love how telehealth is really opening up all sorts of options. The second part of your question, sorry, can you please repeat what that was?
What is the most effective strategy to convince policymakers to use e-cigarettes?
Oh goodness, yeah. So, what is So what is the most effective strategy, maybe as a doctor, to be able to convince health professionals, politicians, other people about it? It's really hard. I'm probably learning more what's ineffective actually, and what's damaging, rather than and through a process of exclusion, then working out what's effective. So what I found is that I can't do, which I'd love to be able to do though, is to engage via webinars or through information on my website. I'd love to be able to engage more health professionals and just the general public about vaping, just basically telling it how it is. But I'm not allowed to do that because that is then seen by a Therapeutic Goods Administration, who arm of the government that oversee medical advertising, etc. That is seen as me promoting vaping. And it's, I've got to be so careful what I say. So anything it's something like that it is or it could be reasonably seen by the general public to be promoting in any form whatsoever the use of vaping. So they just keep the language so broad. So essentially, I can't say anything. It's very limiting, very, very limiting indeed. And you know, it's why I've had issues with the medical board in the last year. Yeah, very minor things that I thought I was still playing within the rules. Things were still caught out because it's like this person may think that person thinks that you said vaping's okay. It's like I've committed vaping advertising fraud. So what to do? Well, I guess. I mean, that's why I've decided, well, look, I like to read, I like to communicate, as you can probably tell, and I've been long interested in writing a book, so I thought, well, let's write a book about smoking harms. Again, I can't put in it things that are pro-vaping, because, again, that can be breaking laws, but it can be all about smoking, and I think there's still a lot of interest and appetite for people to learn about the issues of smoking itself, and I can certainly separate in the book the smoking harms from nicotine. I just can't talk about vaping per se, but I can definitely get that dialogue. Because if people could just understand, health professionals, general public can understand smoking and nicotine, different things, different issues, then it's not difficult to then say, okay, nicotine, all these other things, vapes and pouches and whatnot. So I guess to sum it up, my approach is to learn from bitter experience what isn't working and keep to the rules, stay on side with policymakers in Australia, try to continue to be seen as a reasonable, honest voice in this, just do the best I can, keep engaging with patients one-on-one.
Just add to that, it brings up the idea of having to follow what the policies are. When I was head of a provincial agency and I was a deputy provincial health officer for the province, there was quite a heavy-handed view of what I said, and the communications people. There was probably more communications people than public health people in the ministry. But now I'm unshackled by that. And I do think that we need some brave voices just saying, screw you, I'm not going to do that because it's stupid, and just be disobedient. And I think we're so much on the right side of history and so much on the right side of advocating for people's health that I really think it's, the media can kind of find ways to decimate what you're trying to say, but I do feel that we can't be shackled with these ridiculous ideas and policies, and we need to show some civil disobedience. And all my experience, when I think about, Paddy introduced me as, being part of harm reduction, but I was supportive of it, but none of them were my ideas. They were people that went against policies and went outside and did things that took some bravery, and I think that's the position we're at. So if we're given, if the government gives us what are clearly kind of ridiculous guidelines of what we can say, I think we're in a good position to go outside of those guidelines and say what's right, and let them try and come after you. But I mean, people are in different positions. If I still wanted to get paid by the province of British Columbia, I probably wouldn't be quite as bold at saying that. But I'm not doing that. I'm not getting paid by them anymore, so I don't really care. And I think that this particular topic, we're so on the right side of history that I think that we need to not follow the rules.
And maybe...
Sorry.
Sorry.
Lady there, and I'm going to take one more after
Thank
that,
you.
and then ask the panel to
Thank
wrap
you.
it up.
Thank you for very interesting keynote speakers. And my questions goes to Mark, and to save your time, I will just read from what I was thinking about. How can we reframe tobacco harm reduction into the human rights issues? As me, as well as you, are working with the marginalized and addicted population in general, who may not benefit from absence-only messaging. Thank you.
Yeah.
So just take one more, and then I'll... Axel.
Yes, I will, yes.
Should I respond to that?
No, can you take one more question and then give you both a chance to wrap up?
Okay, this is to Mark. Well, thank you very much for both presentations, and I really liked the journey you took us on, arriving from, taking us through Nairobi. I just wanted to invite you to modify your argument, because I think you're right in your analysis that there are systemic obstacles to achieving harm reduction. And when you mentioned this, when we're inviting people to say that if we allow condoms in, if we distribute them, then we encourage sexual behavior. And do you think that's quite false? I think I agree. Ditto for when it comes to injection sites. These are not incentives to young people to start injecting drugs. However, when it comes to vaping, I do think, that there is perhaps something attractive about vapes. And I just wanted to invite your response on how we can modify that argument, because we need to really bring it further, and the rest of the parallels are really apt and opposite. Thank you.
Okay, I'll answer that first, but I think that's when I planned my talk, I did think about that, because it isn't quite as clear-cut with the other examples that I used. And clearly vaping is attractive to kids, and they try things. And smoking's not attractive to kids anymore. So it's quite fascinating that the idea that if you see an adult smoker, the kids will turn the other way and go, well, that looks disgusting to me. But if they see somebody vaping, well, that looks kind of interesting and fun. And I think that the approach should be how we deal with other things that we don't want kids getting a hold of. We're not that successful at alcohol and cannabis and these other things, but I think it's reasonable to have age restrictions and to talk to kids openly about it. I think we don't want to, the current way that these NGOs try to discourage kids from vaping with these kind of scare tactics and things, I don't think work very well. But I think we need to have open conversations with the kids about nicotine, and I think they're going to definitely try. They're going to try things, and I think that it's just trying to differentiate the conversation between access for people who will benefit from this from a smoking point of view to trying to protect kids from it is really two separate discussions for me. And we certainly can't. We focus 90% on the primary prevention in kids, and I think we need to switch that around and focus 90% on people who can benefit from this technology, and spend 10% talking about how we can help kids not get a hold of it.
Could you
and then
perhaps answer the...
Yeah, I mean, my one of the things I learned quite a bit about when I did work with Jonathan Mann in my HIV work is human rights and health and human rights, and I think that's a very strong argument for safer nicotine products. It's people's right to have access to those things. It's a human right to do that. It's a human right to use substances. And even though we don't like them or think people should use them, people do use them. Nicotine itself is a legal substance, and if people want to use a flavored nicotine, or they want to smoke cigarettes, or they want to use it by vaping, I think that's their right to do that. And as health professionals who are worried about people's health, then we should direct them to the safer and incentivize the safer selection of that. But I do think from a legal standpoint, definitely we cannot have prohibition laws that tell people that want these substances, that they're banned. You cannot have them. That is that's a human rights violation to me, especially when people are trying to seek out something that could save their lives.
Just before we wrap up, we have actually had a question come in online. Unfortunately, it's on a screen a bit far away from me and I can't see it. But it's a question about India. I don't know, could you read it out, Mark? And then perhaps both of you could address that as a final...
You said consumers are seeking vapes and therefore THR is going strong. In a country like India, wherein diverse products are used, cigarettes, BDs, various smokeless tobacco products, how do you foresee THR to be a success if consumers don't prefer it?
I think that's actually quite a good question.
Yeah. Well, I think India does present, one thing when I've been writing the book especially, I tried to have kind of an international perspective. I think a lot of my perspective is in Canada, but I lived the last 2 years in Bali, Indonesia, actually, and so knew quite a bit about what's happening in Southeast Asia. And I looked at India. India's obviously really stands out because that's probably the biggest prohibition policy in the world, and for such a massive population. And the WHO gave them an award for banning alternative nicotine products. But I still think even though it's complicated because there's different forms of tobacco use there, I think that vaping still there's a lot of cigarette use, and it's a really it should be an option for people. So I think, and maybe some of these other tobacco delivery systems that people have, that they could also be, vaping could also replace those. So I think, the other thing, somebody mentioned the all or nothing thing. So there's so many people that could benefit from this. I don't think we should approach safer nicotine as we have to change the whole world. I mean, that's ultimately maybe what we'd aim for, but we can do such an amazing difference to people's lives if we even take a segment of people and get them to switch to safer products. So there's so many people in India who use tobacco products that obviously that's millions of lives at stake if we can switch people from what they're doing to a safer product. So I think it is international, but each country does have its idiosyncrasies and how you'd have to introduce and approach these things.
We're coming to the end of our time because the tech team need to split this room for the next session, but I'll give each of you 1 minute, 60 seconds, to make any final comments that you'd like to make. Carolyn.
Oh, 60 seconds, gosh. Okay, so no easy solutions. It's so hard to know where to start. I think health professionals, as I've said, we need to get health professionals as engaged as possible, and just to bypass media and politics in some ways, because they're going to remain negative for so long. But health professionals are really interested. We really do want to save lives. We want to know, and just like Mark was saying, one-on-one, I can have a really productive conversation with anyone, health professional or otherwise. Give me 5 minutes with them, and they can really open up and be very interested in it. So that is just so key. And I guess in the last 60 seconds, I suppose the issue though is the type of education that health professionals will respond to. Immediately, we'll tend to be suspicious if we see education event about vaping products put on by tobacco industry. So, but then unfortunately the reality is that no one else is really funding these things. Like the GP College doesn't want to fund some sort of education night like this. The Pharmacy Guild don't want to. Who's going to, really, except for those with the bigger pockets? So it's tricky, but gosh, we've got to really keep focusing on educating health professionals about THR. They get amazing reach to so many thousands of people every day. And then one day when the media and politicians come on board, that's great, but we could quietly have been doing our thing for a long time before that.
Mark?
Yeah, I mean, I think I'd like to leave the idea that there is some urgency to this. This is not something that we've got so used to people smoking and dying that we're really kind of not in the urgent kind of space that we need to be. And this should really be approached as vaping and safer nicotine is a revolution, and we can really change the world if we let this happen, or got this to happen. That I think we need to get, and this is sort of what this conference is about, a kind of a counter-revolutionary group of people to fight against this. I think banging our heads against a wall, trying to change people's minds who are entrenched in their tobacco control is pretty much a waste of our time, and we really need kind of a counter group that can push back on this. And we have history on our side. We have all millions of people who could benefit from this on our side, and I think that we really can make some very important changes.
Thank you. I think you know, the aim now is to actually win over medical professionals one at a time. And I think we've got two empirical evidence that we've already got two here. I'd like to thank Mark and Carolyn for their contributions, and for all of you who asked questions, and generally for all of you who've actually bothered to turn up here today. I think it's a really important session, and we will now end it, and I'd like you to show your appreciation for both the speakers. Thank you. That's it.
questions with yourselves and with the panel. So firstly, on the far end, we have Tiki Pangestu, who was an advisor on health policy at the World Health Organization, Director of Research and Policy. He's a biomedical and microbiologist specialist, and he is a graduate of Australian National University and a fellow of the Malay Academy of Medicine. He's going to talk about the impact of the WHO's policies on tobacco harm reduction. Next, we have David Kayat, who is a professor of medicine and he's an oncologist. He's the past president of the French Cancer Institute, and he was also an advisor to the French president. He's going to be speaking about the comparison of the FCTC with the Charter of Paris Convention against Cancer. Next, we have Asa Salagupta, who is from Thailand, and he's a consumer advocate. He also works in the area of probiotics and herbals, and he is a member of the Thai Law and Regulatory Committee of the Thai Parliament. And he's going to be speaking about Bloomberg and Big Pharma's impact on the role of tobacco harm reduction. And here we have Derek Yak, who many of you will know. He's the former head of the non-communicable diseases and mental health at the World Health Organization, who worked on the beginnings of the FCTC at the World Health Organization. He's also a past president of the Foundation for a Smoke-Free World. He's an epidemiologist and a swimmer. And he's going to talk about, outline some of the FCTC's history and from the perspective of someone who was there at the beginning, and some other insights into the treaty itself. But first of all, I'm just going to speak a little about what many of you probably don't know, is that the FCTC treaty actually wasn't something that the WHO thought about. And in fact, initially, the WHO actually said, no, we don't want to do that. But where did it in fact come from? It came as a resolution from a conference in 1994, which is the World Conference on Tobacco or Health. Now, if you look, this particular conference happens every 3 years. It's happening again this year in June in Geneva. And it started in the 1960s. And if you just plot what is the resolution of the outcome of that conference and add 5 years, pretty much you get what happens in the world in the terms of policy in this area. So in 1994, in Paris, they said, let's go to the WHO and create a multilateral treaty exercising Article 19 of the WHO Constitution to do that, and that's really how it happened. And as I said, there was a lot of resistance at the beginning to do that. I first met Derek because we both sat through the negotiations from 2000 to 2005 and the development of the FCTC, so we've become quite expert at it. But I think one of the things I think is really important to know is when you consider treaty success, for any treaty, not just this treaty, there's 3 key things you have to look at: legal effectiveness, political effectiveness, and objective effectiveness. Did it actually achieve the objectives? On the measure of legal effectiveness, you could say this treaty has certainly met its legal obligations. In the first year, it was open for negotiation. 168 parties or countries signed and went on to ratify or accede to the treaty. And that is very, very fast in treaty making. So yes, tick that. When it comes to political effectiveness, that is all a measure of have the countries that were party to the treaty actually done what was in it. You could say pretty much most of them have done a lot of the aspects of it in terms of advertising bans, public smoking bans, packaging and labelling, taxation, all of the things. They haven't done the harm reduction aspects, and that's what we're going to be talking about. But in a sense, most countries have done that. But has it achieved the third measure of treaty effectiveness is, has it met its objectives? And the objectives of the FCTC treaty was to reduce the exposure to tobacco smoke and the reduction of disease, etc., from smoking. And you could certainly say that that has not been achieved at all. So that sets the scene for what we're going to talk about, and I think I'm going to go the other way now and first ask Derek to give, we're going to have 5 to 10 minutes each just to speak on issues, and Derek will open with the beginnings of the FCTC treaty negotiation.
Thanks, Jeannie, and what a real thrill both to be on a panel with so many colleagues, many going back many years. We were all 12 or 13 years old when we started this work, I think, if I'm right. It is interesting to think, I never thought about it before, that so much actually did start in Paris. David will talk us through the charter. I remember the World Conference extremely well in '94. Ruth Romer, at the time, one of our greatest global health lawyers from UCLA, wrote the book on global health law, saw that treaties were becoming the in thing in international affairs. It was the era of the environmental treaties, the seedbed for the climate change conventions, a lot of the work that today is now underpinning a lot of the work on climate and health was in vogue. Governments were willing to engage in treaty-related discussions at the time. The geopolitics was much smoother, and countries who had had difficulties during the Cold War had emerged from it and were willing to realize that to address the downside of globalization, we needed to have international norms and standards, particularly to cover those aspects of environmental or health issues that you couldn't control by any individual country alone. And that's the point of a treaty. It's not to drive national policy per se, but to address the transnational aspects. And that was the context that Ruth Romer gave a very thoughtful, scholarly address, actually first time a year before, in a meeting I hosted with the then Minister of Health of Zimbabwe, Tim Stamps, in Harare. In '93, we invited her to talk about what she thought was missing from the tobacco control scene, with a focus on Africa, recognizing that African legal capacity was very weak in ministries of health, to virtually non-existent, and that there's no ways that they'd be able to write their own legislation and draft it. There needed to be an international framework to give them support. And that was when she said, we need to have an international framework, an international legal framework to address the transnational aspects and to build capacity. And remember, this was in Africa. The meeting was supported at the time by the ex-president Jimmy Carter, who many from Africa will know how beloved he was in Africa because of his incredible work. And he sent a video address to all the ministers of health of Africa about the meeting, saying that Africa really needed to lead the way since the smoking rates were lowest. We needed to keep it that way. And that was, again, the context Ruth spoke to it. Shortly after that period of '94, before Brundtland came in, the Canadian government, which was at the time, I would say, the leaders in global tobacco control and chronic diseases, actually, proposed a number of resolutions at WHO that laid the basis for the treaty. What made it possible was that the first resolution on tobacco control at WHO had been introduced in 1970, and for every few years since, many of the national components were being introduced. So there was a general resolution in 1970 saying smoking kills, we better educate the public. By the late 1970s, it had gone towards saying we've got to restrict advertising, restrict, not yet ban. By the middle of the 80s, there were calls for taxation, and taxation started taking off. And by the late 80s, you had countries like New Zealand, Sweden, the UK, Canada, Singapore, all providing examples of how their national laws and their national approaches were bringing the smoking rates down. And I think that's one of the important lessons, is that the countries who are way out front, already achieving success, like the ones I mentioned, continued to achieve success that probably they would have achieved without the treaty. But they were trying to encourage countries which were so far back to make progress, and I think we still have that gap. So the treaty process went through, as Jeannie said, fairly successfully, and unusually. Our mandate in the Secretariat was to complete the negotiation before Brundtland left office. Now, if you know anything about international treaties, you usually can't predict when this is going to end because of the vagaries of government and government relations, and it gets complex. The second treaty, WHO agreed, the pandemic treaty, was much more complex, and it's just been approved without the support of some of the most important powers, particularly the US, which means that it's going to be pretty toothless as we look forward. I would say the most important lesson I learned was that getting an agreement is one thing, and what we say in simple terms is that law on the books, particularly if the books are in Geneva, doesn't mean law on the streets, particularly the streets of the bustling capitals of India or Bangladesh or Nigeria or the Middle East. It's very easy for bureaucrats to sit in Geneva, even when they come from their capitals, and feel very comfortable about saying, oh yes, we are going to raise the taxes by X%, we're going to ban advertising and marketing, we're going to provide cessation services and sign on the line. Well, if you don't have the resources, and you don't have the political will, and you don't have the organizational capability on the ground, and you don't have the legal competence, very little happens. And that was the lesson of the treaty, was that the thought and the intent was great. The funding was zero for many years, zero. There was virtually no extra funding for governments to actually mobilize the support needed at a time when infectious diseases, HIV/AIDS was a huge issue dominating the agenda, thousands of competing priorities. This was not a top priority for most countries, but they needed the funding to do it. The Bloomberg funding did actually provide some support, particularly for some of the more traditional aspects of tobacco control, encouraging advertising bans and so on, but had very little impact on taxation, by far the most powerful single intervention on smoking rates, and of course opposed vigorously anything that even came close to being related to tobacco harm reduction. On net balance, I think it's important to remember this is 20 years since the tobacco treaty came into force, which means that countries actually signed on to implement it. I would say that the success rate can be looked at in terms of two measures of outcome that I focus on. Do we have more smokers today than we did in the past? Well, we have 1.3 billion users of tobacco, according to the WHO documents that now put out. That is a huge amount. Smoking rates exceed 50% in many countries in the world, particularly among men. Excess exceed 50%, for example, in China and Indonesia, it's what, 65%. Jordan, which got a fantastic prize from WHO, smoking rate among men, 57, 58%, not something you should get a prize for. And I could go on. And more importantly, the deaths. When we started the treaty work 25 years ago, we were predicting there were about 4.5 million people dying a year of tobacco-related deaths. The figure today is about 8.5 million per year, and the figure is likely to continue to grow to 10 million before we start seeing a decline, even if all the measures are put into place. And just to put that figure into context, the official figure of how many people died in the entire COVID pandemic was 7 million over all the years. The estimate is probably wrong. It may very well be 14 million. But compare that to 8 million deaths per year, every year, relentlessly for the next many years, meaning 1 billion people will die this century of tobacco-related deaths. And staring us in the face is the obvious way to halt it in its tracks that I hope we'll move on to, tobacco harm reduction.
Thank you. Thank you, Derek. I think it certainly shows that that third measure of effectiveness in terms of the FCTC meeting its objectives certainly has not done that because it has not embraced all of the elements, the harm reduction aspects of that treaty that governments have not taken on. I think, first of all, we'll continue on the WHO side of things before we move to the others, and I will ask Tiki to make his presentation.
Thank you very much, Jeannie, and wonderful, Derek, to give us that background to the FCTC. for my intervention, I think basically I don't need to tell this audience that WHO has taken a very strong anti-tobacco harm reduction position. It has continued along that path. In fact, during COP10, it had actually been strengthened, and current indications are it may not change that much with COP11 in November of this year. The main issue that I have, and I think many of you have, is that position has a tremendous influence on policies in lower and lower middle income countries. Now why is that? I think, first of all, there is the lack of capacity within many of those countries to independently evaluate their evidence and make their own decisions on policies that are useful to deal with their problems. I come from Indonesia, and many of you know we are #1 in the world in terms of prevalence of smoking amongst males. 70%, 2 out of 3 of our male adults are smoking cigarettes. So that's one, lack of capacity to evaluate the evidence. Secondly, is the lack of context-important local research. And policymakers, you know, they don't really look at research in the US or in France or in Japan. What they need is local research. And that is sorely missing in many of the LMICs. And as Mark Tyndall mentioned this morning, there's apathy within government. Okay, so all this means they take the easy way out. Well, if WHO says THR or vaping is as harmful as combustible cigarettes, we'll just follow WHO guidance. Okay, so that's particularly important. And you know, it's particularly pleasing for me to attend the GFN. I mean, you're addressing all the key issues here. There's obviously the very exciting science. There's the exciting highlighting of the importance of communication, okay? Be it to overcome misinformation, be it to advocate to consumers and to policymakers, the highlighting of the importance of regulation, for example. So these are all key issues in our battle to advocate for harm reduction. But let me give you my own personal view. The elephant in the room is the WHO. Okay, as long as that position doesn't change, many countries are going to continue with apathy. Many countries are just going to say, we follow WHO. That is the impact of the position of the WHO on many lower and lower middle income, even middle income countries. So despite all the important things that are happening in the GFN, I still firmly believe that we all need to do our bits to advocate to our governments, to take the lead, to develop a movement to try and change the position of the WHO. Derek will agree. There's only one thing that will move the WHO. It's when a Minister of Health calls the Director General and say, we want this issue discussed at the WHO. All the experts in the world can send letters, Nobel Prize winners, doesn't make any difference. It's only the countries that can move the organization. It is a politically driven organization. The only members of the board of directors of WHO are sovereign member states. There are no other stakeholders in the governance of the organizations. No industry, no civil society, no consumer organizations. Okay, so, you know, at the end of the day, that's our aim. We need to change this, what I call, pardon the strength of the term, the evidence-blind policy of the organization. Okay, really, that is the elephant in the room. Any of you, if any of you have been to Geneva, when you walk in the front door of the WHO, you see the mission of the WHO, the highest possible level of health for all people. That's the mission. That is equity, that is social justice, That is human rights. They seem, as far as THR is concerned, they have seemed to have forgotten that mission. Let me finish by saying that despite all that I've said about WHO, I still passionately believe in the value and the importance of the WHO. There's no organization that can replace it. Thank you.
Thank you, Tiki. And I think what you just said on the human rights aspect reminds me of the very opening line of the FCTC document itself. It says, and I've written it down actually, the treaty opens with the parties to this treaty give priority to their right to protect public health. I mean, that's how the treaty opens. And the preamble in treaties is always used to interpret them if there's any dispute. So it's very important. And I think another thing that you said, Tiki, which was very important, with a lot of people don't realise, is that it is the member governments, it is the sovereign states that actually have the power to do anything. The governments created the treaty and the words and the text and everything in the treaty, not the WHO. At COPs, the Conference of the Parties, that are the parties to that treaty, they are all, now it's up to 183 governments out of 193 in the world that are party to that treaty, and it is only they that can move on anything. And as Tiki said, one or two ministers of health can, or the delegations who are speaking at a COP, COP11 will be later this year, can actually change the direction. But they need to, as was said earlier, have the political will to actually do that. And I think that's where we'll come on to that a little later as well. But I think now we'll move to David, who is going to talk about an analogous sort of multilateral agreement, the Charter of Paris. And over to you, David, to take us through that. Thank you.
Thank you, Jenny. Thank you. It's a pleasure to be here with you today. I would like to start my talk by asking you a question. And if you can raise your hand, is that who knows why the 4th of February is the World Cancer Day? One, okay. So let me tell you the story. In 1999, with groups of friends, including Dr. Harper from London, Gabe Ortobaghi from the MD Anderson in Houston, we were coming to the millennium, and we thought that it was time to raise awareness in the world about the epidemic of cancer and the burden of cancer. And we sat down in different places, in airports, and we wrote that document which became the Paris Charter Against Cancer. These documents, after a preamble, and you have the charter, a summary of the charter on your seats, that document was giving a preamble about the burden of cancer, the stigma, the difficulties to struggle against this disease, the huge cost of money for every nation because of the premature deaths and everything, and then 10 articles dealing with freedom of research, respect of the end of life, empowering patients, and so on and so forth. And the 10th article was, the last one, was that all the parties who are going to sign the charter must make the day of the signature becoming the World Cancer Day. And I came with that with President Jacques Chirac, President of France, and when I explained to him that so many people were suffering because of this disease, because of the stigma around the disease, because of the difficulties to get the CT scan, to get the latest treatment, and to the difficulties of equity and access to the latest innovation, he decided to sign it officially, and it was very rapidly joined by not WHO, but UNESCO. Question, why UNESCO was signing that? Because if you look at the most important determinants of cancer, it's education. 80% of all cancers in the world are due to lifestyle habits, smoking, eating, being under the sun, lack of activity, obesity, and everything. And this is education. If we can teach to the kids to do some sport, to eat not potato chips, but tomatoes, etc., all what's called lifestyle medicine today, they won't have the same prevalence of cancer when they become adults. So this is why UNESCO said, okay, we agree, we're going to support that. And on the 4th of February 2000, at the Élysée Palace, which is the equivalent of the White House in my country, the director of UNESCO and the President Chirac signed that charter in front of all the media from all around the world. 400 million people saw it on the news in their country. And that was the reason why the 4th of February became the World Cancer Day. So now I have been asked by Gianni to make a kind of comparison about what is inside the charter compared to the FCTC. And there are some points that we can discuss of. One is that the total difference in terms of tone and attitude toward human beings. If you look at the Charter of Paris Against Cancer, the first article says cancer human rights are human rights. Because at that time, a woman who had cancer has maybe many times the husband left. When you get cancer, you lose your job because, as you are under human beings, you are not a real human beings, and you are not allowed to get the same rights than the others. So this is why we made Article 1. Cancer patient rights are human rights. This is the basis of the Charter. We deal with patients. We respect their life. We respect their hopes. We respect their chance to, in case they get a cancer, to be diagnosed as early as possible and get the best treatment. We teach them. We raise awareness to them about the determinant of cancer, so that they can do something to try to prevent themselves about that, whether the FCTC is dealing with the control. So we are helping people, they are trying to control people, and that is, I think, the main difference. We are at the level of human beings, dignity of human beings, dignity even at the last week of the lives of these people, whether the FCTC and today the WHO, in general, to my point of view, is very far for what is the life of one single person in the world. They don't care about that. And we can see that in a second thing. We are very much in the Charter, and I think this is Article 2, working on the stigma. As long as, when I launched the national breast cancer screening program in my country, we found out after 3 years that only 40% of the women in the age of the program were going to get a mammogram. And when we made a survey to try to understand, 1/3 of women will say, whether I made the diagnosis early or late, I'm going to die. Second third, they say it's the mammogram that gives my cancer. And third is that I'm too busy, I'm struggling just to get enough money to survive and give food to my kids. I don't have time to go to do a mammogram. But so the stigma are a barrier to health. And we are in the Charter, in the essence of the Charter, trying to work against that. Whether in the FCTC, the stigma is part of the plan. They are, threatening the governments about what is there with cancer instead of trying to help removing some of the stigma that are barriers to her. And the last point is that the Charter is very optimistic. One day we will defeat cancer if we work all together, if we put enough money on it, if we commit ourselves significantly. Whether the FCTCs regarding the main cause of cancer, which is tobacco smoking, is saying, you don't want to quit, die. It's quit or die. And we cannot accept that because we are oncologists. We see patients every day in our clinics. And when you see a patient with lung cancer, do you have any idea how many of them are going to continue to smoke after the diagnosis, knowing that they might die, that they are going to suffer radiotherapy, chemotherapy, surgery, and everything? 64% on the average will continue to smoke until the end, which means it's not that easy to quit. So when the only message you have is quit or die, it's not acceptable for a clinician. Now, if you look at the measurement, this is the second way to look at that comparison, the measurements of success. In the Charter, measurements of success is raising the awareness on the disease in the world, is raising the respect of dignity, raising the respect of the end of life, and give some hope to people that are either affected or the relatives of the people affected with this disease. Whether the FCTC, because they don't count on people, they just look at the number of countries who ban tobacco smoking. And the problem is that the third part of comparison is that the Charter is saying, in its essence, is please take into account the innovation, take into account science, the result, the control studies, and try to provide people with the best and the latest improvement in the diagnosis, the treatment of, and the prevention of cancer. Whether the FCTC is saying we are going to even more than just control tobacco smoking, but also all the alternatives that could give a better outcome for the smokers. So the mistake is that risk is not binary. It's not you are safe or unsafe. It's not you are drinking or not drinking. I mean, it's a relatively risk. It's not eating meat or not eating meat. It's not binary. The risk is more complex. It's personal. It depends on the way you live. So as long as you are so binary as the FCTC is, you will be wrong and you will not get the results you are expecting, which is a lower number of smokers, and which is not the number of smokers, and the lower number of people dying because of the disease related to tobacco smoking. And unfortunately, this has never been achieved by the FCTC. As Derek said, we had 1 billion smokers. We still have 1 billion smokers. And in many countries, we are, even my country, 30% of smokers in France, very rich, developed country, put a huge amount of tax. And did it work? Not at all. The only thing that happened is that the poorest people in my country, and this is not me, it's a study, it's an official survey, the poorest people, in order to be able to continue to buy their cigarettes, either they buy illicit cigarettes, about 45% of the cigarettes sold in France, or, that's more important, they are spending less money in food for their diet. So they have a poorer and poorer and poorer diet just in order to be able to continue what is not just a pleasure, it's an addiction. You can tell to a drug addict, stop injecting drug, he will continue. You can tell to a smoker, stop smoking. If you don't help him, will not. And here we have a problem of the perception about nicotine, and I think that we will have maybe some points to discuss about that, because there is a misperception about nicotine and cancer, whether it's tobacco smoke that gives cancer. Thank you.
Thank you, David. And I think we'd all agree from hearing that the Charter of Paris has a much more humanitarian approach than the FCTC. Although the FCTC does have in the preamble various references to human rights. One in particular, it draws on the Article 12 of the International Covenant on Civil and Political Rights, which outlines the highest attainment of health as being a right that humans should have. Now, that treaty, and also from 1966, and the other one from 1966, the International Covenant on Economic, Social and Cultural Rights, both have a lot of human rights aspects that are very relevant here. And one of the things which I'll just mention now before we go to ASA is both of those treaties have what is called an optional protocol. Now, an optional protocol is, in treaty law, it gives individuals or groups who are affected by their national policy the right to take their case against their government to either of those against those treaties. Now, most governments in the world are parties to those 1966 human rights treaties. Now, an optional protocol, one group of individuals who wish to vape and their government stops them from vaping can take a case as individuals only to those human rights bodies and take that through. Now, the reason I know about this and when it worked was because, as you can tell, I'm from Australia, and in 1997 I was working in the Department of Prime Minister and Cabinet on international treaty issues, and it was back then illegal to be homosexual in one of the states in Australia, and 2 homosexual men took a case personally invoking these human rights things in these international cases, and they actually won and forced the Australian government to do that. Now, in Article 12, the issue of health is even far more significant and very well spelled out, that any individual could take a case using their country's being party to that treaty against the national policy that is inherent in their country. And I think we should all think about that. I did write an article in Filter magazine last year on it, and no one has yet done that. So I think it's worthwhile to think about. Now, moving on to Asa. Asa is going to talk to us about Bloomberg and some of the anti-tobacco control and anti-harm reduction areas. Thank you.
Okay, thank you, Ginny. I'm going to talk a little bit about Bloomberg, not a lot. I don't want to get sued right then, because I think most of us here already know who Bloomberg is and what Bloomberg Philanthropies does. What they do is they fund anti-tobacco. And we have to look back at FCTC. It's tobacco control. It's not tobacco destruction. Nothing is completely 100% good and nothing is 100% completely bad. You know, all the honored speakers had mentioned something or others, right? And we are going through, like, the end of this year, the WHO FCTC is coming up, and what Bloomberg is trying to do is to get rid, or at least the intention is to reduce smoking rate, which, you know, we all know that it's not working. And what they are doing or trying to do is they try to limit access to what we know is safer alternatives, something like vaping or snus or pouches. And a lot of countries have banned on less harmful products, like in my country. And in some countries, the ban are really crazy. You know, like in my country, it's illegal to import and it's illegal to distribute. You think about that. Only 2 illegals. So it's not illegal to possess, it's not illegal to vape per se. You know, so you cannot import. So it's really weird. Also, there are public confusion. This is one of the confusion, right? And we also heard about the misinformation and all the false information that's going out, spread out. And the local people, the regular people, especially nowadays, you know, the internet and the media society that we are going through, a lot of people, they just look at their Facebook, they look at their Instagram, X, and Twitter, and they see whatever jumps up at them in the first glance, and especially older people, they believe what's in there. It's like older generation, we believe the news, you know, whether it's come from ABC, NBC, where the Fox, it's come from news, it must be true, and then they just like, so it's this generation, it's going through social media also, so they believe. In my country, even though Bloomberg doesn't have a direct impact on the tobacco harm reduction itself, it's not known to the public, there are quite a few local NGOs that play a similar role, you know, by pushing prohibition. Especially they are ignoring science always. And like I said, you know, they use ideology over evidence, like Tiki and David had mentioned before, right? And I want to also speak a little bit about, like, there's a lot of people that, I don't know if you're trying to work, but I've been trying, like, wherever I go, I try to mention, like, the other players are big farmers. You know, lately we started to see, like, I'm trying to say like, okay, listen, who's the, usually I said I don't blame big tobacco as much as big pharma, but this is, I have to say, first I have to say this is my personal opinion, right? Big tobacco is our enemy. Of course, you know, I used to smoke for almost 40 years before I switched to vaping. The doctor said, don't use the word quit, use the word switch, whatever. So the big pharmas, they try to come out with like patches, gums, and medications. And it had been said that Nicotine is the best way. It had been proven it's the best way to get smoking, to quit smoking. And the second best way is vaping. But Nicotine had been removed from market because of side effects. Of course, all medicines have somewhat more or less side effects, right? And so the big pharmas also, they are opposed to vaping and snus and THC, the tobacco harm reduction in general. They also fund a lot of selective research, right? And they try to lobby for regulations. Like Jeannie had said, I work with the government. I'm a member of a committee of the government, of a Thai parliament, still ongoing, and we are getting that close to legalizing vaping. Right now, the cabinet is taking a break. That's why I could be here, could attend. And then earlier in July, it's going to reconvene, and one of the first things will probably be maybe entertainment complex, and then followed by vaping, if all goes as well as I thought. But getting back to what we are discussing, so they're trying to regulate. In many countries, the regulations kind of varies, right? I heard like in Ireland, they are kind of want to do like simple packaging, plain packaging, maybe flavor ban or maybe not. And in many countries, it's like various and you know, kind of ban with different level. And I don't think they are looking at real tobacco. And you know, we had mentioned how many days in Thailand there are at least 70,000 people die of tobacco related each year. And you know, we haven't seen even one death case related to vaping. And you know, so we were going on about tobacco harm reduction, and that would be pretty much, unless, you know, like if maybe later if somebody wants to ask something more, but you know, this is from consumer point of view.
Thank you, Asa. Now, you've all heard some very interesting commentary from each of our panelists here, and I think I have some questions for them. But first, I'll just take a couple of questions from the audience if anybody has. Oh, I can see one straight away from Martin. Martin, we need it. And if you can say who on the panel it's for or whatever.
Yeah, Martin Cullip, Taxpayers Protection Alliance. Derek, you wrote a while ago about the early years of the FCTC treaty, and you said that Grohal and Brundtland wanted to hear from all voices, including from industry. Why did that change, and what's the effect been?
One of the things, you're right, she was, just also remember her background, she was the Labour Party Prime Minister of Norway, and often one associates the Labour Party with being antagonistic to the private sector. Well, Norway was not. And she believed that all the complex social, environmental, health problems of the world could only be solved through private-public partnerships. And she did that as the Minister of Environment, she did it as the Minister of Health. At WHO, we had roundtables with the pharmaceutical industry. We were hosted the first and only one with the food industry, and even, believe it or not, with the alcohol industry. Because we saw there were some issues of common ground. On tobacco, we recognized very early on, before the formal negotiations started, that we needed to give them a voice to say what did they think was going to be the way of addressing the health issues. And so we had 2 public hearings in the WHO building, and the one was where the industry was invited to present on whatever they wanted. They were not alone. We had NGOs, activists, and for 2 days we had these public hearings. The major companies, PMI, BAT, Japan Tobacco, all sent representatives, and they all gave speeches. We then had a second meeting, which was the start of what became the Tobacco Regulatory Advisory Committee to WHO, where we wanted them to send only their scientists to answer the question, what did they have in their armamentarium that was likely to advance harm reduction? So what was the research evidence that they had? And for that meeting, again, those same companies took part. And there was a decent discussion. I don't think we on our side were convinced that they had much at that point to offer, which if you look at the evidence, they actually didn't, except for snus. The end result of that, unfortunately, then was the discussion around 5.3 about the irreconcilable difference between tobacco industry and public health, meant that you had an inability to have any discussions anymore with the tobacco industry. So it actually ended by the start of 2000. And I remind people that that language, irreconcilable difference between the interests of tobacco companies and public health, is now belied by the FDA language on appropriate for the protection of public health. If something is appropriate for the protection of public health, you can't have an irreconcilable difference, and the FDA has recognized that and seen that in the case of harm reduction, we should be making more progress.
Thank you, Derek. And there was another question here at the front as well.
Thank you. Dylan Human, health diplomats, and a question to Derek and Tiki. The FCTC is not silent on harm reduction. Article 1D explicitly acknowledges harm reduction methods as part of tobacco control. So the question is, how did that language get into the FCTC, and what can be done for that language to be elaborated, preferably by a work group? So just a bit on the history, and then the way forward, how we can actually enact it.
Thanks, Dylan. Again, one has to put your mind on to that period of the late 90s. The AIDS epidemic was roaring ahead, needle exchanges, condom use, harm reduction was central to HIV/AIDS. It was natural for us to think about how that might apply here. We had already started doing, WHO had started doing needle exchange programs in Zurich. The German Zurich citizens didn't like it and tried to actually stop the program. This was a WHO program which got led by the then head of the Swiss Health Department, Zeltner, and led the way worldwide for harm reduction. So it was part of an open understanding that there would be a range of options, and we didn't want to remove it from the list. Just while we're talking about the text, I think the other important thing that came up when David was talking related to really looking at what the objective always was for the Framework Convention. If you read the text, it's very clear that the governments saw the Framework Convention as being successful if it would lower the death and disease caused by tobacco smoke. Reduce the death and disease caused by tobacco smoke. Each word had incredible meaning. First, it meant that success wasn't going to be measured simply in smokers no longer becoming smokers. That wasn't going to be good enough. It had to go all the way through to preventing the cancer, cardiovascular disease, and respiratory disease. And at that time, the leading non-profits, of which Dylan was one, from the World Medical Association, along with the International Cancer Society, the World Heart, and the International Respiratory Association, were all very strong voices for their own patients' interests. And they were pushing very hard to make sure that what we did would help patients in the end. And cancer, of course, was a central one. And we've forgotten that. Instead, the debate has moved towards everything to do with kids, forgetting that the real purpose of this is to show benefits to adults in terms of very specific health outcomes. And the last comment I'd make before I forget was in response to David's other points about the Elysee Palace meeting that I was very thrilled to attend, initially illegally, because WHO forbade us engaging with the process, as you'll remember, and I think it took finally President Chirac making a direct intervention to say, you've got to have some representative there. So I was then the lowly representative. Sitting on the one side of me was Simone Veil, one of the greatest politicians and thinkers that France has ever produced, which is also ironic to talk about here being in the land of Auschwitz, which she survived. And secondly, on my left was Sir Richard Peter, one of our greatest cancer and tobacco epidemiologists. What I find poignant, and again reminds me of how personal this all can get, Simone Veil, in that meeting, I think, or before, announced that she had been treated for breast cancer, something that no senior diplomat in France had ever done before, and it was done probably with David's support to destigmatize the issue. On the left of me, we had Richard Peter, and Richard was in fine health, but years later would go on to have advanced cancer, which he is successfully treated from and celebrated his 80th birthday last year. And sitting in the middle was me, not knowing that I would land up having 3 cancers to have to survive, putting all of us in the position to understand that what David's talking about is both personal and professional. And the last point related to it is the reason people are surviving is because of the unbelievable progress in innovation in science and technology of cancer treatment, which is akin to the incredible advancement in science innovation that tobacco companies have practiced in tobacco harm reduction. The treaty failed to include any mention of innovation, patent protection, the investment in cutting-edge science, both to treat, prevent, or diagnose disease. And that is a real big shortcoming that I think the Charter could actually highlight going forward. Thank you.
Before we go to Tiki, because you put it to Derek and Tiki, because I'm going to ask him about COP11, but I would say, in a practical sense, how do you invoke Article 1D of harm reduction? You would do that in the very same way that all the other articles in the FCTC have been invoked at each COP. So, for example, Article 8 on environmental smoking bans. During the COP, one country put forward a resolution intervention to say we would like to bring this on for further elaboration and discussion and scrutiny. Another country backed it. WHO is a consensus, and COP is a consensus-making body. No one objected. That's exactly what happened. The next one, a country put forward, we would like to elaborate Article 5.3 on the FCTC. Another country backed it, and they then went on to have a working group to look at how Article 5.3 happened. Every single time, that is exactly how you invoke, or elaborate as it's called, an area of the FCTC. Some years ago, I drafted one to bring on how Article 1D might come. We saw at COP10 that St Kitts and Nevis, one country, kind of did something very similar to looking at that. But unfortunately, there wasn't really any country to back St Kitts and Nevis we were talking about earlier in political will. So hopefully at COP11, a government backed by another one, and there being no objection, that can actually bring that on for further discussion, elaboration, presentation of the science and evidence to actually bring it about in a very practical way. We have seen COP7, some while ago now, there is language in COP7 in the decisions which actually says something like, if I can remember, if we could fast track and have more people using e-cigarettes or ends, we can perhaps bring about a public health benefit and all that. It's quite good, because that's what governments were saying at the time of COP7, but none have come back and sort of said that further. So I'll hand over to Tiki because Delon asked him about that, about COP11 and what you think could happen there. I know you have some thoughts on that.
Yes, thank you for that, Jeannie. I think your preamble's very important in terms of the very practical issue. To me, this is a big challenge, and I think there is a very strong ideological divide, as well as what we know as the conflating of arguments between risk to youth and minimizing health risk to adults. That's well known. But the ideological divide is much more difficult, and that is between, you know, the public health perspective of reducing harms and the ideological perspective of a nicotine-free society. You know, that's almost irreconcilable. But moving on to COP11, and this goes back to what I said earlier. It's only the countries that can move changes within the WHO position. And I think Jeannie's mentioned St. Kitts and Nevis example. The Minister of Health, Dr. Denzel Douglas, made a very public statement at COP10 that, you know, this is a very important public health intervention. But as Jeannie mentioned, no other country supported it. But without really divulging any names, I'm aware, because I spent half my time in Geneva, that there are some strong moves to get that second country to support the proposal from St. Kitts and Nevis to form a working group. That's the critical step. And I'm a little bit concerned. Why is it so difficult to get another country? You know, you have so many countries around the world that have been very progressive in supporting THR. The UK is the obvious one. Okay, the Philippines, if you want to talk from my part of the world. I know, once again, confidentially, that St. Kitts have been working with a few countries in the Caribbean, and hopefully something will happen before November. I'm keeping my fingers crossed.
David, did you want to comment? Oh, sorry, I thought you were putting your hand up to comment as well.
Can I say something, like,
yes,
just to add on? Yes. I think one of the reasons, could it be the Dirty Ashtray Award? Could be, I mean, like, it's weird, right? I mean, there are a lot of, like, you probably heard of the Golden Orchid Award, you know, like, which, you know, to countries that did nothing, and then the countries that did really great on harm reduction lift the ban on tobacco harm, on vaping, especially because that certain countries had found that there are members, employees of Bloomberg sitting within the health cabinet, within the health department, the Ministry of Health. So it turned around, and that country received the Dirty Ashtray Awards. So I would just like to just take real quick for consumers, and actually for all of us, you know, to what Tiki just did. What we could do is we push our government, we ask our government, we put out petition. That's what we did. We had been doing it for over 10 years. And finally, you know, like the government will see, and then the representative of what our government will send, either from doctors or people in health department, as a representative of each country to attend the COP11, ask them to do what we want them to do. Just be a voice of the people of the country. Thanks.
Yes, I think Derek would like to say something. Just before you do, though, I looked at you then, we were both laughing in a sense, because when the international negotiating bodies were on between 2000 and 2003, when there were all these antics, the Dirty Ashtray Award, the Marlboro Man Award, the Good Orchid Award, the Grim Reaper, you know, there was the death clock. There were all these kinds of things that we would be confronted with when you went into the negotiation area. Anyway, Derek.
Yeah, and again, it's sort of quite historic, you know, sitting next to Jeannie, because she was, you know, from the dark side. And we also learnt in the negotiating rooms that there, if you go into the conference room, it's got these wood panels if you go down the corridors, and you wouldn't know, unless you really know, that some of them were doors. And if you needed to escape some delegate coming at you, and we had to often escape, you could sneak off and just disappear, and nobody would know where on earth you were in the corridors where the real interesting discussions happened. I just wanted to really go back to the last couple of comments, both Azar and Tiki much earlier, because most of you, or if not all of you, already come from the consumer advocacy, from the activist side, and are not here representing governments. And I just don't want you to think that the only way to change this is going to come through a change in WHO. My own view is that it's long overdue that I don't think we should waste too much energy on WHO now. I think we should be looking at the next Director General election, which is only 18, 20 months from now, and make sure that we find the right country to send the right delegate to become the Director General. And that will require partnership way beyond tobacco. They're not going to elect a Director General based only on whether they're going to support harm reduction. They're going to have to do everything else. But the really important point is to think of many of your careers, and certainly my career. I can remember my first success in tobacco control was on the campus of the University of Cape Town, where I stopped smoking in our student representative chamber. That was, for me, a big deal thing. It took an enormous fight. Then the medical school and the professors of surgery were violently against banning smoking in the medical school. That was a real time, I think many of you will know. Well, we succeeded then. And then we tried to ban smoking in the restaurants of Cape Town, which, when we first announced it, the head of the major tobacco company said that if we went ahead, and the city went ahead, they would withdraw all the money from the city orchestra. Now, you kind of figure out what the link is there. Anyway, he didn't, and that happened, and then Johannesburg banned it, and then we slowly went on. All to say that local activism matters. It builds the impetus, and I don't know what the equivalent is that we need to do. Should we be demanding access to vending machines in universities if you're sitting on a university campus? I'm sure Sud will agree we should be demanding access to vending machines in mental health institutions and get the mental health patients involved. That would make a massive difference. Should we be making very simple requests for access to nicotine pouches when you get on a plane and you're a smoker to actually reduce your anxiety on a long flight? There are many pragmatic things that we could be doing through activism, which means that we don't wait for WHO, because otherwise we'll be waiting for the end of time.
Yes, I said earlier, especially even in these multilateral forums, it's the WHO gets to decide nothing at all. It's the administrative part, it sets the agenda, it produces papers and background, etc. But it does not make any decisions. That is the role of the national governments. So it is, as Derek says, it's so important to educate and have the national governments aware and getting them to take action where possible. And I think, as Tiki said, the governments that we can get to take action, if one, I've seen it before, if one, then another one feels the confidence, then another one, you start to get a little bit of momentum, but you don't therefore get, it's a consensus, the absence of a formal objection. Unless anyone objects, something will go through. So, do we have any more questions from the audience to our panel here? Peter. Yes, Peter, please.
Hi, Peter Forster. I'd like to ask, well, whoever wants to answer, but Tiki in particular, you mentioned governments, especially in LMICs, relying on WHO policy because they don't have the resources, or there might be ignorance regarding the benefits of THR. Do you think there's an additional issue which is a conflict in terms of tax revenues? Indonesia, for example, I think about 13% of government expenditures funded by excise from tobacco. Do you think it's a convenient excuse for these governments to just say, well, the WHO says this is the, without wanting to think because, you know, there is such a big reliance on tax revenues?
Thank you, Peter. Excellent point, and certainly economic, political issues are part of the question. You mentioned Indonesia in particular. Derek and I were colleagues with a lady who used to be Director of Gender and Women's Health at WHO, who subsequently became Minister of Health in Indonesia, Dr. Nafsia Amboy. And Nafsia shared with me an anecdote. Well, first of all, you know that Indonesia and the United States are two countries that have not ratified the FCTC. So she shared with me an anecdote. Whenever she got up in front of cabinet meetings during her term as Minister of Health, and whenever she tried to promote stringent control against, trying to reduce that smoking prevalence, the first hand that goes up is the Minister of Finance. As you rightly mentioned, it's actually not as high as 30%. The latest I have is about 12% of government revenue comes from tobacco tax, okay? So the Minister of Finance would say, are you willing to give up 10% of government revenue? Minister of Agriculture will say, what are you going to do with the 1 million tobacco farmers? Minister of Industry will say, what about the 1 million people working in the manufacturing of cigarettes? So many exigencies, which is political, economic, in addition to what I mentioned before, the lack of capacity and the apathy. Thank you for the question.
Thank you.
Yes, governments are addicted to the taxation, that's for sure. I have a question for you, David. In terms of the Charter of Paris and the FCTC, I would imagine that most of the governments are signatories to both of those multilateral agreements. So how do you think we can educate those governments to actually take more of the approach, the humanitarian approach, that they've agreed to on one hand toward the FCTC in terms of going forward to bring out the tobacco harm reduction elements of the FCTC?
Okay, it's not easy for them because FCTC is based on the idea that we can prevent disease and death due to a lifestyle habit. The problem is that the political clock has nothing to do with the health clock. If a given government is going to invest a huge amount of money to try to improve prevention on cancer, for instance, is not going to get the profit, the benefit of the better outcome, which will happen 20 years later. And I was the advisor of Jacques Chirac for 6 years, so we had to discuss that with the Parliament, with the Minister of Health, and so on. The idea is that they spend money on treating disease, although they are called Minister of Health, but it's disease policy, not health policy, because it does not include really a significant amount of investment and commitment in prevention. So the problem is that if you put money to try to prevent a bad habit, you are going at the same time to continue to pay for the people who didn't have that attitude 20 years ago, before, and are going to have the disease at the time you are working, you are in charge of the government. It's only 20 years later, so 10 governments later, that they will see less lung cancer because less people were smoking, or less colorectal cancer because less ultra-transformed food access and so on. So that's the point. You can say everything you want, but at the end of the day, even Tiki said that about tax, it's the question of money. They have budget, they are government, they're in charge of the country, they need to check about what they spend, and spending on prevention, for them, at the day they spend the money, is not profitable.
No. Do you want to say something, Derek?
I think this issue of the importance of the money has never been more critical. Many of you are probably aware that we're now seeing, for the first time in 30 years, a significant decline in spending in global health. The period of the Framework Convention was also the start of the greatest expansion of funding and institution building. Gates hadn't created his foundation, just as one example. He then went on, and Gavi, the Global Vaccine Initiative, the PEPFAR, many of these programs got created. Now they've been cut by billions, a mixture of US policy, but the Germans, the Brits have also made massive cuts. And the result in tobacco, I don't think we fully understand, but it's meant that global surveillance, youth tobacco surveillance, is no longer supported from the CDC as it was. Many researchers from the NIH, the FDA, CDC have been cut. Massive programs have just been stopped. The Office on Smoking and Health no longer exists. The tobacco-free initiative of WHO is no longer visible on the org chart. The replenishment funds required for the pandemic are struggling. All to say that you can look at this with despair and say, oh my God, where's the money going to come from? And this is where I think we need to recognize that the private sector does need to step up at this time in dramatically bolder ways. Ideally, it'd be very nice if the philanthropic sector also would, but it's unclear that there's going to be much more money there. And be bolder about doing a couple of things. Number one for me would be to invest heavily in scientists and researchers in low middle income countries. Because without those scientists and without their research and their voice, we won't have the passion needed to drive their policymakers to go to WHO and say, we want tobacco harm reduction.
Thank you. Now, I'm going to ask each of the panelists to have a final minute, but before we do that, I would like to see if there are any more questions. Yes, I can see two here in the front. We can take both of them. One from Norbert and then the man in front of Norbert.
Hello? Yeah. My name is Norbert Schmidt, consumer from Germany, and I have a question specifically to people who were instrumental in the creation of the FCTC. When this was created, what was the thought process behind Article 5.3? And how do you feel how this is abused today for ad hominem attacks on everybody who disagrees with people?
Okay.
Yeah, I'll just be very brief. First, I think one has to read the text of 5.3, not the elaboration by the Secretariat. Right. The actual text is fine. I don't have a problem with it. It basically says...
I can read it if you like.
Just go ahead.
Okay. In setting and implementing their public health policies with respect to tobacco control, parties shall act to protect these policies from the commercial and other vested interests of the tobacco industry in accordance with national law.
It basically means declare conflicts of interest, which is pretty sound. The problem is that there were guidelines attached to it, not voted on by the member states, but it's developed by the Secretariat. That's where the prohibitions and bans, and it's then become part of folklore that 5.3 says ban people from meetings, from conferences, journals should restrict them. Well, journals are not privy to, they are not part of the Framework Convention. That should be challenged. That's also where I think the activist community should read this text carefully and challenge the British Medical Journal and all the journals banning this, the conferences that forbid it. And the good news, of course, is that we were talking earlier about the e-cigarette summit in the US just 2 weeks ago, where one of the most eminent people in tobacco control research, Robin Mermelston, said, isn't it time to reconsider this and have the SR&T meetings, for example, allow scientists on the same platform as public health people? So I think there are ways to challenge it. And the thinking at the time was to have a good conflict of interest protection in the text.
It's all to do with interpretation and government interpretation as to what they meant in that. And I recall very distinctly at the World Health Assembly meeting when the FCTC was adopted in 2005. I remember the government of Bangladesh, of all things. It said, we agree to the Article 11 packaging and labelling, health warnings, etc., that were in there. But they said, in our case, most consumers don't actually see the packets because it was it was to do with graphic health warnings and things like that. Most of our consumers don't see the packets because they're sold in a different way. But we'll agree to it, but we're not necessarily going to do that. And I think that's where that whole interpretation thing of governments and how they shape that interpretation, and Derek's absolutely right, it is far overstretched. It has got even to the stage in some counties in the UK that I understand where the police aren't even allowed to go and can look at illicit product, because that's illicit tobacco products, because they can't. They're invoking Article 5.3. They can't even address it. I mean, this is absurd and ridiculous. So I think definitely that area of interpretation and getting governments to be more pragmatic about it. The German government, where you're from, they actually sat in the public gallery for many parts of outside the negotiating room because they didn't agree to a lot of the things that were going on. So governments have taken stands. Cuba always takes a stand. They do things on various issues. They just need to be pushed. Anyway, there was a question in front of you, Norbert. Yeah. Oh, you don't want to have it. Sorry, it's very hard to see you because the light. Does anybody else have a question? We have one over in the far corner on the...
Hi, I'm Mark Tyndall from Canada. The way these policies work at the WHO are fairly blunt with banning everything, and obviously prohibition is not very successful in many ways, and many countries already are feeling the illegal push to get these products into the country. Canada is a good example, Australia is a good example, and already half of tobacco sold right now in Canada is from the illegal market in a country that's fairly wealthy. And vaping products, the problem of banning them is that they're going to continue to get in there, and it's going to just cause havoc for communities. And do you think that, I'm just wondering if there's kind of such a blunt response from WHO and all this talk about prohibition and banning will backfire, and governments will find that it's impossible to ban these things, and it would just cause chaos.
Tiki, do you want to take that, or Derek?
Derek.
Yeah, you
go. Thanks, Mark. I mean, I think that is a classical example of unintended consequences the minute you ban sort of a product. It's becoming a problem in many countries. You've already mentioned Australia, where people are actually firebombing pharmacies to get access. Singapore is another country where there's a total ban. We have endless problem with smuggling from neighboring countries in Malaysia, with the smugglers coming up with very creative ways of smuggling these products. So, yeah, absolutely.
Yeah, I saw this morning for Australia, 1,700 to 1 illicit products in Australia being consumed from official record out today.
Just a historical thing as well, Mark, and warm regards from Peter Singer, by the way. One of the curious things about the Framework Convention process that not many people may know is that in 2002, Alcohol, Tobacco and Firearms division of the US government approached us formally at WHO to host a meeting on illicit trade in tobacco at the UN. And at the time, they not only approached us, but they said they'll fund the whole thing. Now, anybody who knows the US government knows it's extremely odd for the US government to fund anything in the UN anyway. And they weren't going to be signatories in the end, so we knew that. So why on earth did they do this? And it was the time when the smuggling case had been detected, where cigarettes were being smuggled from North Carolina to Canada, and you can see the price differential, and the proceeds were going off to fund Hezbollah. This was the first terrorist case that eventually made it to court and a conviction. I mention that because people don't realize that illicit trade is not just something that gives cheap cigarettes and robs governments of taxes, but is also used not only to fuel criminal element, but to fuel terror around the world. And I know that the industry, tobacco industry, look at this very carefully, but they don't have the right fora to talk about it. The World Customs Organization was very involved. If I'm right, they were actually stopped from participating in WHO Framework Convention meetings because they, and Interpol. Can you believe Interpol and the World Customs Organization are not permitted to formally be part of the WHO meetings because they work with the tobacco industry, which is kind of obvious, they have to.
Yes, some very bizarre things, although when you look at the US, it is, in fact, from what I've been reading, the fact that there is so much illicit vaping and not FDA-approved vaping going on in the US, it's actually responsible for what's bringing the smoking rate down. So, we do have time for one more question, and then I'll come to everyone to sum up. There's one here in the front.
Thank you. More than a question, it's a commentary. I want to share with you two thoughts. I'm from Mexico, first country in the world that bans vaping in the Constitution. I would like to share two things. One, you spoke about FCTC and that the parties should have like an office for tobacco control. In America, there were no resources to create these offices, and they were financed by PAHO, but was Bloomberg, through PAHO. So in my region, there are not many health ministers that would come up and go against whose lineups, or because they are being financed by PAHO, but with the money of Bloomberg. And that's a reality mainly in Central America and the Caribbean. Okay, one side. The other one is, please make of Mexico a study case. The banning came in the beginning of this year. We don't have secondary laws. We don't know how wide the banning is going to be. Even there's people that have been extortionate by policemen because they have a vape with them. They're not vaping, they just have a vape with them. We don't know how wide this is going to be. But what I can say is that before it was banned in the Constitution, there were 4 decrees of the president to ban them. And the prevalence of smoking in Mexico was 16.8% in 2020. Now it is 19.6%. And it was not yet banned in the Constitution. So I am saying this in a very formal way. I mean, really study what's going to be happening in Mexico, because after the banning, the prevalence is going to rise. And it's going to give not only the momentum, but the data that you need to have to tell look what's happening in a country that even got an award because we granted, they gave us an award because we banned them. And I don't know, 3, 4, 5 years from now, the effect is going to be the contrary of what is expected.
I think that's very significant, and it would be interesting to see whether Mexico, which I'm probably sure it is, was a signatory country to either of those 1966 conventions that I mentioned, because that gives Mexican citizens, Mexican individuals, the right to take a case under that treaty against their government policy. And as I've said, I worked on that in Australia in 1997 for the case. It can work. It needs to be very, very well organised, very legally done, etc., to ensure that the individuals who take it do the process correctly to stop it. So maybe it's a sort of a global effort in Mexico to make this happen, to enable that to pass. And anyway, it's something we can talk about later. But I agree that you've made some very significant points.
Mexico was the first country to endorse FCTC, the first country in the world.
Yes, so it's a very significant thing. So
And you know why? Julio Frank had been the Minister of Health, and he was in the cabinet with us. So
yes.
It was no surprise.
Frank, I remember him as well. Just to we're just finishing up here, so I'll give each of you, please, just 1 minute. Tiki, would you like to start just to say your final comments?
Just a final comment to support what Derek had mentioned earlier, and that is for more research to be done in lower and lower middle income countries. And I would like to salute in particular Ricardo Polosa. I don't know whether you're in the audience, Ricardo, doing some amazing collaborative research with Indonesia. My second comment is a quick one, that I do have sympathy with policymakers who make policy on these issues. Indonesia, as I said, smoking is almost part of our culture. So it's difficult for our policymakers to make policies that are going to attack that sort of almost daily habit. And I think there's a saying that what is popular is not always right, and what is right is not always popular. So that's my sympathy for the policymakers. Thank you.
Thank you, Tiki. David?
Just a very short comment. I mean, I am a clinician. I see patients every day with cancer, and it is obvious that we are facing an issue with lifestyle. We know that most of the cancers are due to the way you live, the way you eat, the way you behave. So we have to invest more money, more commitment in governments, in universities, in research labs on these issues related to lifestyle.
Thank you. And Asa?
Yeah, I'm going to say as a consumer, right? We need a right as consumer to be given the correct information, like, everything we consume, water and everything, there should be labeled, and it should be not misinformation. It should be correct information directly from the government. So please, just work together. And this is a shout out from the consumer to the government, to the health department. Thanks.
Thank you. And finally, Derek.
Yeah, first, I would urge people, look at a LinkedIn thing I put up with a link to Yusuf Adebisi and our article on the size of the gap in low middle income to high middle income countries with regard to investing in tobacco harm reduction research. As I say, without this, we won't make progress. I saw the difference when this started to shift for AIDS. Suddenly, you didn't have people parachuting into African countries doing work. You had indigenous African scientists carrying out research which changed policies. And then another thing for you all to look at is a book by Margarita Melillo, and I can give it to you later, who wrote a book on the Framework Convention. She did a PhD in Italy on this, but then wrote the book, and she was at Georgetown. It's the only time I've seen an international legal opinion on 5.3 lay out the dangers of it from a precedent-setting approach across the UN treaties in general. And those people interested in 5.3 should take a deep look at the text. And finally, my last comment is just to re-endorse what Tiki and all of us have been saying about the emphasis for change must come from where the smokers live, which are low middle income countries, and don't be drawn by the research agenda of what happens in the US or the UK, where the smoking rates are basically gone. Yes, they can fuss around a little bit of flavors here and there, but basically they're gone. Whereas in places where the smoking rate of 50% plus, that's where 80 to 90% of the deaths are going to come. That should be 100% of our attention. Thanks.
Thank you all, and will you help me in thanking the panel for their wonderful comments.
Well, hi, everybody, and welcome to this afternoon's commentary session. I'm Barnaby Page. I'm the editorial director at e-cig Intelligence and Tobacco Intelligence. And I have with me today Sam Tam, who's from the Canadian Vapers Association, and also Jeannie Cameron, who many of you will have heard just now, giving chairing a really fascinating session on the FCTC 20 years later. So a couple of very different perspectives here. We have Jeannie, who's come largely from a government position, Sam, who's coming very much more from the sort of consumer advocacy end of the vaping world, of the THR world. So let me start off, guys. I know we're only sort of halfway into the first day of the full session. But let me start off with a general question. What are your takeaways so far from GFN? Jeannie, maybe you'd like to start.
Oh, I think probably the takeaway so far was listening to, just a reliving of some of the history that Derek Yak was speaking about at the start of the FCTC, and also Professor Kayat from France, who was speaking about the Charter of Paris, two very different multilateral agreements, but one that looks at a very humanitarian approach to cancer and death and disease and involving and thinking about the patient, and one that's very clinical, the FCTC, that, sort of says quit or die in essence. And, I found that very interesting. I mean, I also found the talker from Canada who was doing the keynote this morning, some of the things he was saying were very profound and putting things into language that were an example of what really is going on at the coalface and how to interpret it. So they're the only two things I've seen so far, so that's all I can comment on.
So two things, they're both highlights, great.
Yes.
And yeah, I mean, totally right. I thought one of the most interesting things in that FCTC session was about the history of it, and particularly some of the points made about Article 5.3 and the article itself versus the elaboration or guidelines to the article. And, a lot of the sort of fears we have about Article 5.3, actually, it seems, exist in the guidelines rather than the article itself.
Well, the legal obligation for the governments is actually what is written in the treaty.
Yep.
The guidelines are only guidelines that you may or may not want to adopt, and I think it's reminding them that that's their obligation, not what everyone else wants.
So, Sam, enough of me. What about you? What were your highlights?
I think the emphasis that we need more tobacco harm reduction research, especially in countries with low to middle income countries. There's more information. I would say, we've seen globally there's a lot of misinformation being spread around about vaping and the harms of vaping. But in essence, I think more work needs to be done. Misinformation needs to be addressed. And I think there's a great opportunity for that. And I think meeting with a lot of different people from different countries and associations, I think we can help one another and stop some of the misinformation being spread about vaping.
Sure. Well, that's been a pretty consistent theme, I think, of GFN for some years. And of course, it is the Global Forum on Nicotine. It's not the Global Forum on e-cigarettes or pouches or tobacco-heated products or whatever. But one of the problems that a lot of people in this space face, of course, is that conflation, that confusion between nicotine and smoking. Very much in the eye of the public health community, sometimes in the eye of regulators, and of course in the eyes of the general public. Coming from it at your point of view, Sam, from an advocacy point of view, how do we correct that? How do we address it and let people understand that nicotine in itself is not really the issue here? Smoking of combustible products is the core public health issue.
And we always have this conversation, right? It's not, people don't die from nicotine. It's they die from the combustion of tobacco. And it's important for us, to highlight that, when we talk about substance use, which is mentioned over and over again at GFN, is, what are the key points to addressing people consume, nicotine, for instance, because they have an addiction. And I think it's important to highlight there are safer alternatives out there for them. And I think it's important for us to highlight the importance of harm reduction in general, whether you're using vaping, whether it's nicotine pouches or snus. And I think government needs to change their position and to promote harm reduction alternatives. Sure. And in Canada, I just want to highlight Canada's moving towards that approach, right? They're incorporating harm reduction as part of their tobacco strategy. of reaching a less than 5% smoking rate by 2035.
Now, just to follow up on that for a second about Canada, is that something you think that is coming from, if you like, the traditional tobacco control community within the Canadian government? Is it something that's coming upwards from the world of consumers? Is it perhaps something that's coming from the harm reduction movement elsewhere? Of course, you know, harm reduction began very much with HIV, injectable drugs, and so on. Has that kind of informed those decisions?
Well, I think Canada is unique because there is a bit of a divide between our government and tobacco, or I would like to say nicotine control groups, as we like to refer them to now. You know, they don't, you know, their position is different. They don't believe in, you know, harm reduction. They believe you either quit or you die approach. And that doesn't work today with our government. So there is constant struggle between government and those groups, including health organizations. But I think, you know, the position is clear. Canada wants to potentially be the third country in the world to be smoke-free. So they've changed their approach in 2023, and I think that's the course that they want to take.
Great.
I think there's some interesting analogies at the multilateral level when you look at this and what you were saying on tobacco harm reduction. You look at the Framework Convention on Climate Change and the Framework Convention on Tobacco Control. They're both very similar in, you know, multilateral conventions about 10 years apart. And yet the world is very happy in the energy industry to look at all the harm of fossil fuels and a move to renewables, which are less harmful in terms of the environmental issues. But when you look at our issue, which relates to, you know, smoking and moving away from smoke to less harmful forms of nicotine, it's not embraced as you know, universally as it is with the Framework Convention on Climate Change's treaty. So I think that's really interesting. And also I think what you were saying about nicotine, I do think in the future, the way governments look at nicotine, when you look at its therapeutic benefits, which is something it's emerging to be spoken about, but the benefits in terms of its cognitive benefits, reduction of it was certainly used for Parkinson's disease, certainly being looked at in terms of Alzheimer's dementia. It's used for Tourette's. It's used for many sort of the big global issues where nicotine has an impact. So long as it can be disassociated with smoke, which, as you said, is what is doing the harm. And we know that's the harmful thing. So let's get rid of the smoking, but keep the nicotine. Well,
absolutely. I mean, you know, to quote famously Michael Russell, who is, of course, the guy after whom, you know, the oration at GFN each year is named, people smoking for the nicotine and dying from the tar. But Jeannie, I wanted to ask you something specifically about government perspectives on this. And let me give a little bit of background first on some research we've been conducting for some years at Tamarind, the publisher of e-cig Intelligence and Tobacco Intelligence. We've done surveys of MEPs, members of the European Parliament, on their attitudes toward novel nicotine products in general. And there's quite a range of attitudes, as you would imagine, and you know, these vary to some extent according to political affiliation, according to what kind of product you're talking about, etc. So it's not a wholly clear-cut picture. But one thing that does emerge very clearly from it, time and time again, is the more people know about these products, the more sympathetic they are. Opposition, to a large extent, seems to be bred out of ignorance, or perhaps ignorance is bred out of opposition. It could work that way as well. Now, you, of course, have worked in government in Australia. You've been very close to government-level policy making through things like the FCTC, and I believe you now, in fact, are a parliamentarian yourself in Alderney, in the Channel Islands. Is that right? So is that your experience? Is opposition uninformed? Is that the simple problem?
I think when it comes to the UK, for example, you know, anywhere really. I think most politicians have a lot to do. They're very busy. They're going from thing to thing very quickly, and so to get the depth of understanding that is often needed in areas like this, it's going to take a bit of time. So unless they have an advisor or someone who's giving them a briefing from their departments, the relevant departments, that is well informed, they're really not going to get that information. Politicians very often are driven by what they see in the news, in headlines, and as we all know, especially in this area, it's probably the same for almost every area, that we don't have the depth of understanding about. But in our area where we do have the depth of understanding, you see the headlines, you know a lot of it is junk news and not true and not based on any science, but that's what they're hearing and that's what they then take away. So I do really think, as been spoken about earlier today, the education of getting things into politicians before the issue comes across their desk or before they have to do it is very, very helpful to broadening the debate and getting out the issues better understood.
Sure. So let me follow up that, Jeannie, and then we'll get Sam's perspective on this as well. Let's just imagine that you had, that you were given the task of changing the minds, or at least improving the attitudes, shifting the attitudes of policymakers. How would you practically set about it? For example, would you go through consumer organisations? Would you go through the media? Would you go to politicians directly?
Well, I think you certainly need a bit of all of those things. However, when I look back to early days when I was a political staffer, one of the things when I worked for a cabinet minister for telecommunications, and I remember him coming out and he said to me, "I've got to go into the chamber this afternoon and I need to know what to say on how to privatise the spectrum." And I kind of went, oh, and I looked at him. For a start, I didn't know what the spectrum was, let alone how to privatise it. We're talking the 1990s here. And so what I did in those days, because it was before the internet, we didn't have Google or anything, I went to a filing cabinet and found what had been submitted to us. And I found a paper that had been written from someone about this particular thing. And that became what I then wrote about. So to draw that to this, I think, in my view, it's not waiting until things come up like tobacco and vaping bills in the UK or somewhere else. It's about constantly always finding reasons to educate whoever is the relevant decision maker and the policy makers who, or the advisors to the policy makers, and really doing a proper stakeholder map, seeing who are all of the relevant entities that may have an impact on any decision that you think is relevant, and gradually just educating them over time. So when that moment happens, well, they can go to Google these days, but when that moment happens, they have something already sort of formulated in their head, rather than just always waiting for, oh, we now have this we need to react to. Because you're not going to get in. It's a slow building up, and I think that works generally in my experience on any issue, really.
So it's being proactive and laying the groundwork rather than just firefighting, as it were.
Yes.
Now, Sam, you've obviously been involved in a very hands-on way in things like this. In Canada, how has it worked for you there specifically?
Well, in Canada, we engage government quite often, and I think it's really important when we talk about education is there's a lot of misinformation, as I mentioned. Sometimes when we meet with government, they don't have all the information that they need, and they do require education. And a lot of times, the information that's being given to government is not necessarily accurate. One of the things that we found is that every federal government agencies don't really talk to one another. Right, their own different departments, they're in charge of different things. So when it comes to taxation with vaping, excise taxes, finance doesn't talk to Health Canada. And what we've done over the years is really to have that, put that alignment together, getting all stakeholders involved to talk and to create better policies. We've been very fortunate enough to, our association meets with the government on a quarterly basis. And we have these discussions about policy and how we can focus on harm reduction, how we can focus on better, sensible policies to ensure that we don't over-regulate. And that's one of the major concerns that we're seeing from all over the world is over-regulations, right? Regulations that stifle innovation, regulations that stifle harm reduction. And we need to make those changes. And I think there's an opportunity for other countries to do the same work that we're doing here in Canada, which is really to to engage government and present to them there's a need between private and public sector to work together. And what was mentioned earlier, when I heard about the Interpol, not being able to attend WHO, which is quite really interesting, is because, our organization works very closely with the federal government on matters of illicit trade. We work very closely with the RCMP, with Interpol, with the Canada Revenue Agency, with the Canada Border Security Agency, and even with U.S. Homeland Security. But there needs to be a partnership between private and public sector in order to have better policies in place.
Sure. And let me just ask you about the WHO as well. Now, of course, Jeannie has just chaired quite a long and fascinating session about the WHO, as we said. I think it's generally sort of taken as read that the WHO has a fairly substantial input into at least the philosophy behind THR regulation in lower and middle income countries, if not the actual details of the implementation always. Do you find the WHO and specifically the FCCC are a factor in Canada?
It's interesting. I always read the Article 5.3 when I meet with government, but I think there is a mutual understanding from our health agency that we, as whether it's the vaping industry or the tobacco industry, we will always be called upon to the point that there's information sharing, right? When there's updated new policies or new regulations, that we do our best to educate the industry. So there's an understanding where, everything, we do the normal disclosures, but I think there's a government understands that, if there's any issues, that we need to involve all stakeholders.
And Canada was, in fact, I'm not sure if you're aware, the government that stood up at one of the COPs to try and stop what the WHO was doing in closing the public gallery. So Canada spearheaded, it's a public right, and we, as the Canadian government, cannot say to Canadians that you can't sit and watch us do our policy work in this sort of sense. And they were but as I mentioned in that talk, there was no other governments that supported Canada's position, but Canada did lead that. It's done quite a few things over the last 20 years, both positive and negative, but more positive than negative from the government perspective.
Sure, sure. Well, we're coming close to the end of our time now, so I'd like to have a couple of really quick questions to end up with, like just a minute each. Let me start by asking, perhaps Jeannie go first. What are you hoping to learn about most at GFN this year?
I think what I'm hoping to learn about, there's a lot of new things emerging, like, for example, synthetic nicotine. I find it fascinating. I think it's a really interesting area because it is definitely not tobacco. And if there was a session earlier which I heard about, where they make the synthetic nicotine via a biochemical process, and it has all the properties of nicotine, but it isn't actually from a tobacco plant. And I think that's the area I'd like to learn more about, because then you can genuinely say that your product is tobacco-free. And then all the ESG stuff about the carbon footprint that comes from it, I think that's an area I'd be really interested to learn a lot more about.
Great. So synthetic nicotine.
I think for me, this is my first time at GFN, and I really want to learn from everyone's experience and meet as many people as I can. When it comes to synthetic nicotine, is definitely a very interesting topic. We've seen that start to actually, we start seeing a lot of products that are being manufactured globally around the world are using synthetic nicotine. And I think I'm interested in learning what additional innovation that the industry is creating, because we are vaping, vaping and any safer nicotine products. There's a lot of innovation involved in it. So I'm here to learn more and hopefully meet new colleagues and friends that we can share our experience together.
Great. And of course, in addition to synthetic nicotine, we now have as well the emergence of nicotine analogues, which are not strictly speaking nicotine, but if you like, nicotine substitutes, which may well be a topic to take up with some of the scientific delegates here. So from my last question, we've got about 3 or 4 minutes left, I think. I'd like actually to go back to the title of today's, I think it was today's opening session, What's So Scary About THR? And actually, I'll give my answer first. What's so scary about THR? Well, I'd simply knock the HR off there and say it's what's so scary about tea. People confuse tobacco harm reduction with tobacco. That is the essence of the problem. For many, many years, for decades and decades, and from the late 19th century to the early 21st, really, nicotine was synonymous with combustible cigarettes. You couldn't have one without the other, to all intents and purposes. But maybe you don't agree with me. Jeannie, why don't you think what's so scary?
I do think the word tobacco in tobacco harm reduction is scary, because people who aren't as well associated with us, they hear tobacco and then to sort of harm reduction, then it's like, well, what is that? And even when I was checking in for my flight here, had this discussion with the lady, and I spent the time educating her. I got out some nicotine pouches and showed her, and but people just don't know what tobacco harm reduction is. So maybe we need to, the nicotine benefits or something else, or some other form of way to describe it. But it's not a scary thing once you understand it. When you put the analogies, like I said, with the fossil fuels, to renewables, when safe sex, condoms, all that sort of thing.
Sure.
It's not scary when you explain it.
We could call it nicotine harm reduction even, couldn't we?
Yes.
Sam?
It's interesting. I agree. I mean, tobacco harm reduction isn't scary. Canada's always been doing a lot of things very interesting. Canada never uses the language tobacco harm reduction. In a lot of the discussions with government, we've changed the concept to harm reduction, or a lot of less harmful alternatives. And even if we look at the new approach from Health Canada, they've changed our tobacco strategy to include harm reduction and smoking cessation side by side in regards to helping Canadians reduce smoking rates. So, and they mentioned their vaping, any tool that's harm reduction in their category, including vaping. They encourage Canadians to use less harmful products. So it's not scary. I think for Canada, we understand that concept. And I think it's important that, Canada should be speaking up more and talk about their approach and what the government's doing. And I think it's something we're celebrating. One of the important initiatives that I talked about that the government just recently launched was really a new youth prevention and education campaign, because the government understands that a lot of times youth are vaping because of social pressures, experimentation, stress, and all these issues. And the government's moving towards more focusing on prevention and education. And that's how we're going to reduce youth vaping rates in our country. So we're excited to support that initiative. And I think, tobacco, harm reduction isn't scary at all, but, I think, the word tobacco is probably the issue.
Absolutely. Hence the Global Forum on Nicotine, not the Global Forum on Tobacco. Well, our time's up, I'm afraid. We need to get back, obviously, to the main program in the conference rooms now. So thanks very much, Sam. Thanks, Jeannie, for joining us. And I believe the commentary teams will be on screen again later.
Thank you, Barnaby.
Bienvenidos a la sesión del GFN en español. Aquí estamos reunidos con personas que estimo muchísimo dentro de, no solo de reducción de daños por tabaquismo, que no solo se emplean en reducción de daños por tabaquismo, pero también en otras áreas, al igual que en el área médica, como es con el doctor Diego Berrastro. Además estamos con el señor Miguel García, que además de encargarse de lo que es creación de contenidos, también está en el sector de psicología y coaching de lo que es empresarial. Gina Lozano, que también se emplea en el área de comunicación, especialmente lo que es ASOAP Colombia y ART Iberoamérica. El señor Miguel, ¿cuál era tu apellido? Okumura, ¿verdad? Bueno, ya llegó Roberto también. Miguel Okumura, que es de THR Brasil, que es una asociación de consumidores, el señor Julián Quintero, director de Acción Técnica Social de Colombia, y el doctor Roberto Sussman, que es investigador de la UNAM. Entonces, si quiere, vamos empezando. Diego, si quieres empezar por ese panel.
Bueno, a ver, hoy estamos todos acá reunidos no para hacer diagnóstico de algo que ya todos conocemos, como la desinformación, las fake news y todo eso, sino para ver qué vamos a hacer a partir de ahora. ¿Sí? Estamos a mitad del año y la idea es que entre todos pensemos en hacer una especie de, a mí me gusta, de checklist de cuáles son las nuevas estrategias que tenemos que tener en comunicación. Y como vos decías bien, Jeff, venimos de la parte científica, de la parte de comunicación y de la parte de contenidos, medios. Y mi primer pregunta para todos es, ¿en qué momento se dieron cuenta que los datos médicos y científicos no alcanzaban y se tenían que convertir, ya sean activistas o médicos o científicos, en comunicadores?
Buenas tardes, yo soy Miguel Okumura de Brasil, THR Brasil. Yo soy ingeniero eléctrico de profesión y yo solo voy a decir eso para decir que yo no soy médico, o sea, no soy del área médica y soy de verdad alguien que se transformó en activista. Y tu pregunta es muy buena porque ¿quién regula esos dispositivos y quién tiene el deber de regular no solo la nicotina, pero cualquier cosa que haga, que pueda tener daño al cuerpo? Es Anvisa, en Brasil, es Anvisa. Y Anvisa es una institución muy fuerte, muy grande, muy importante en Brasil. Tiene mucho poder en sus manos también. Y durante la pandemia, nosotros vimos a Anvisa hacer una defensa muy fuerte a la ciencia. Entonces, a mirar ese ejemplo, yo pensaba ya, cuando llegue la vez de hablar sobre vapeo, será fácil, porque están del lado de la ciencia, están del lado correcto. Digo eso porque en la época de la pandemia nosotros teníamos una presidencia en el Ejecutivo, el presidente de Brasil es conocidamente anticiencia, Jair Bolsonaro, conocidamente negacionista de las vacunas y todo, y él como presidente había puesto o sea, él tenía el poder de indicar el presidente, uno de los directores de Anvisa. Y ese director mismo contra a quien fue, o sea, quien
who the director would be.
fuertemente la ciencia. Entonces yo pensé, ganamos.
Yet
O sea,
he defended
no
science. So
será fácil, porque
I said, oh,
Anvisa
we've
ahora
won this
sigue la
battle.
ciencia. Y no pasó. No
But it
pasó,
didn't
pero ni
happen.
cerca. Cuando empezaron a
It
hacer
wasn't even
las
close to happening.
consultaciones públicas,
When public
nosotros vimos
consultations
que ya
began,
estábamos jugando un juego de cartas marcadas.
we saw
Lo
that
bueno
we
es que
were
en Brasil
already
tienen una
playing
transparencia institucional, entonces
a
ellos no
game with
pueden hacer
the
esas
cards that were
decisiones
already
en
set
puertas
for
cerradas.
us.
Tienen que hacerlos en consultaciones públicas, hay un proceso.
They
Pero siguieron
had
ese
to,
proceso
there
y
was a
nuestro
process they had
miedo
to go through.
se quedó así, eso todo
But
es
despite
protocolar,
going through this
decisiones ya están
process,
hechas. Y cuando vino
it was,
entonces la
it was just
actualización de
protocol. The
la
decisions
RDC,
were
la
already made.
resolución de la directoría
So when the
colegiada, que era la 46
update for the
ellos no solo
RDC
apretan, o sea, dejan más
started,
duro la regulación contra vapeo,
they tightened regulation against vaping and by redefining the meaning of propaganda. So showing the equipment counts as propaganda now. So we ended up understanding that science is no longer enough. More needs to be done. We need to talk to people. We organized ourselves and spent 4 hours talking about consumers, with consumers saying that science had to be respected, had to be listened to. It was all online. We did a great movement getting people there. And that's when we understood that they're very good at cherry picking. We're the champions of cherry picking in Brazil. And that's where we noticed that it wasn't just science that was needed, but more had to be done. We needed to provoke an impact in these institutions. Anvisa won a prize from the World Health Organization for all that regulation, which is ridiculous. I don't want to spend a lot of time more, so I'll give away the mic. Yes, and there was people involved in education on decision makers. For example, in Colombia, along with Juliana and along with Gina, and how we've talked about changing, because just as like you said, science is a lot of times not enough. It can be a conversation starter, just like Roberto will talk about in a couple of minutes. But Gina, can you comment on your process to demystify things, how we can direct and amplify these measures?
Primero, gracias por la invitación.
Yes, first of all, thanks for the invitation.
Más de manera personal.
And I will talk more about my personal experience. How I started all of this is because I experienced health reduction for more than 30 years in my home. I had no idea what this was all about, what harm reduction on tobacco was. But about 6 or 7 years ago, I arrived at my house. I wanted to find out more about what all of this was, what these alternatives were. I started not just to investigate, but I also started to notice that this works. I have a medical problem, a medical issue, and the doctor told my husband, do you smoke? Yes. If you want to help your wife, you have to stop smoking. But I know that for many people, it's very hard. People that it's their habit. It's hard to leave it from the night to the morning. That's what the situation my husband faced was. So he started with this alternative. And I said, okay, this is just as bad. This will harm me. That was my original position. But when time went by, I noticed that not only did Francisco's my husband's life improve, but also the life of everyone around him. So that's why I wanted to find out more about this. Francisco was already fully involved, activist in all of this. And I said, okay, let's see what this is all about. I started to investigate, and that's when Francisco formed this group in Colombia and then in Iberoamerica. And that's when we started to work alongside each other. I started to notice that evidence exists, the information is there. Media have decided to ignore all of this, to follow this narrative of fear, mainly doing Francisco and I, is that we talk from our heart with the data in our hands, but what we need to do is grab this information and make it more digestible, more humanize it, not just showing graphs, but showing lives that have genuinely changed. I'm an example of this. I've experienced this for a long time myself. So I feel that there's a lot of strategies available, but we're always in a constant war trying to fill gaps. There's a news article that pops up, so we have to go and attack it. But we're not doing enough to bring out information because we're constantly in this race to defend ourselves. So I feel that there's a lot of alternatives, and we do it. We've created campaigns. There's so many strategies that we could use, but what really works for us right now is to show stories, and the information that we have, try to translate it and make it more easy to read for everyone else. Roberto, you come from science, you come from tough numbers, and through ProVape Mexico, we've known about you, informing everyone about vaping. When did you become a communicator? Well, I'm no longer at ProVapeo Mexico. I want to clarify this. It's important for me to say this. I'm a physicist. I have a career of more than 30 years. I work at the Autonomous University of Mexico, and I come to this world as a former smoker. I smoked for 43 years in my life. I occasionally enjoy a cigar, very rarely. And I started like many other people. I tried out these devices, not because I wanted to stop smoking. I was a happy smoker. I didn't have any major problems. But on one occasion at a congress in Dallas, there was an ice storm. You couldn't walk on the streets, so we had to be locked in at the hotel, and you couldn't smoke anywhere. So I was very anxious. One of the hotel workers, who's Mexican, told me, buy this e-cigarette. You can smoke that in your room, and no one will notice. This was in 2013, and I bought a couple of e-cigarettes that looked like real cigarettes. They were metal tubes. I went up to my room, and I used it. I set it up, and I felt horrible. It looks horrible, but it took away my anxiety. That kept me away from e-cigarettes for 3 years because I enjoyed the act of smoking. There was another similar occasion, another place where I couldn't smoke in India, and that's where I found an e-cigarette that you could change the liquid and all of that. And that turned me to a dual user, and I slowly started replacing due to the practicity and because my throat was also asking me for it. I felt the softness of the sprays rather than the toughness of the smoke. That's where I noticed, just like a couple of people described, that I thought this would take over. And I understood the science very quickly because it's physics. The difference between combustion and non-combustion spray, it's essential. It's ABC. 2 + 2 = 4. I understood it immediately. But well, just like everyone else has said, this didn't happen. There was politics involved. And for a long time, Between 2018 and 2022, I was an activist with Juanjito, with Tomás O'Gorman. We created Pro Apeo Mexico. And to shorten the story, in 2022, I retired from activism because I'm not very talented to be an activist. And there's people that do it much better than me, and I don't have enough time. I have a very demanding career. So what I did was investigate as a professional in sprays, which is physics. And from that point onwards, it's very important for activists to take into account the fact that the scientific justification for harm reduction is solid as iron. Absolutely solid. 2 + 2 = 4 in this case. And this doesn't mean there's not many articles going around, because one of the things that I've done is review the other articles. Not just have my own experiment with a French colleague who's got his own lab, also review the experiments that have been done before. And we've seen that many of the articles that say that there's a lot of dangers, talk about metals, that there's formaldehyde here present. It's just rubbish. Say how much there is and in what doses. Because if not, you can there's toxic components to a person. They won't understand. You have to say how much. And if they don't know, you have to say, sir, what you're saying doesn't make any sense. It's irrelevant. So it's important that when you have to convince people, that you do so with the utter conviction that you're right, because you have the possibility and the resources based on science to say all of this clearly. Harm reduction science is solid. Every article that says that they found dangers always have a deficient methodology, speculation. Those studies on cells, on rats, cells taken from smokers or from vapors, are studies that are idealized in a lab that give a biological plausibility. I find, for example, DNA that could produce cancer. Okay, I find it in vapes, but that's biological plausibility. It doesn't mean that vaping causes cancer. You can buy a lottery ticket. If you don't buy a lottery ticket, you'll never win the lottery. Buying a lottery ticket doesn't guarantee that you'll win it. Those preclinical effects that are found and that are talked about as being dangerous and all of that, simply plausibilities. There's not one study that can effectively prove that vaping is dangerous. It just doesn't exist. And just like with peanuts, for example, we can find people that will fall gravely ill or die because they've eaten peanuts. In every product, you'll find some cases, but those cases have to be taken as statistics. So the truth is that they emphasize on all of this because there's this lack of information which puts everything into doubt. Anyone that puts this into doubt is wrong. They're not based on science. Of course, as has been said, science is ignored when politics are involved. You can be right based on science, and then you'll still be ignored, and the media will keep disinforming. I'll finish quickly, but that doesn't matter. So even if they shut us up and all of that, we have to be aware that the science, the scientific investigation, the methodology supports fully the fact that there's a very significant reduction of the danger. Something very interesting I find about how Roberto champions the idea of making the information more digestible to explain to people, which was what Gina was just saying. So I want to ask you, Miguel. Talking about all of this that Roberto just said, the importance that people have this knowledge and understand it, and what Gina said about making it more digestible for them to understand. There's a lot of people with different communication needs, which means that we need different ways of transmitting the message. How can we talk to these different types of people? I believe that other than thinking about how we can communicate, we have to think who will we be communicating to. Talk about harm reduction is so broad. We can talk about the economics, the industry, the culture, the health, the science. So many times we've failed what our target audience is. For example, I went into Chamber of Deputies. You arrive at science and they won't care or they won't understand you. Do you understand me? So we create a Bible on harm reduction. We keep it under our arms. And once we meet someone, we talk about chapter 1 and we repeat what we always say, but we don't analyze who we're talking to. You have to first analyze the market, the audience, and based on your audience is how we build up our speech. Which topics will they understand, and how you have to speak to them for them to understand you. So you get all this information through. Many times we arrive at civil society with all our data and people just get bored. When you do it in a different style and you joke around and you've got interactions, you can get the message through, but you've got to get the way that you do it right. We're so technical sometimes, we're so aware that they lose interest quickly. Obviously, there's freaks like us. If we analyze people, everyone that's here, all of us are people that got into all of this without knowing what we were getting into. It became our passion later. We took an interest and we end up defending something different each time, which is what's incredible at this society. People from the whole world, you create friends. We reach an identification, but we all fight for different things. Some fight for science, some fight for medicine, some fight for health, some fight for rights, some because we want to defend our friends. But no one's got the right to come and tell me how I should live my life. If we analyze it nowadays, so we don't have the capacity in our hands to choose what we have to do with our lives. They make us think we do, but those at the very top are the ones that determine all the policies that determine how we can live our lives. And that's what's tough. So I consider that every time we have the opportunity to talk to someone, we first have to see who we're talking to, what language and what culture level they have, to see how we can speak to them. Get our message through. Julian, you're very quiet. So the next question will be for you. You come from harm reduction on other substances, right? You've crossed the bridge to dedicate yourself to nicotine. Do you see something in parallel with a fight on other substances and nicotine in terms of communication? What challenges did you face before, if you faced any? Hey, good evening to everyone. Thanks for the invitation. It's great to see all of you here. Can we get the presentation on and I'll answer the questions? You have just 2 minutes. But don't worry, I'll take only 5. But let's see. The conversation on nicotine has fascinated us because it's much more complex than the conversation on harm reduction on illegal substances. It's been very tough to get into the conversation on nicotine, and we've said this. It was easier in Colombia for me to analyze ecstasies with a youngster or a syringe with youngsters than telling him that harm reduction on nicotine with a vape is possible. So what we've done is put them all on the same level. When we started talking about nicotine, they didn't like it that we assimilated it to, that we talked about it at the same time as heroin. They asked us to do it at different times. So talk about harm reduction and risk. I will just take 5 minutes for this presentation if you understand what I'm talking about. As many of you know, we're Acción Técnica Social. We talk about harm reduction and risks with different substances, for different positions, for different elements. So we have different projects for self-cultivating of cannabis, the handing in of syringes. So to communicate on this subject, we're reminding them of the damages and the harms of prohibition. Every time they want to ban vapes, we talk about the dangers of prohibition. And the 2 big things that happened in Colombia are the structural damages, which is that related to destruction of the state by mining the society, but also the dangers of consumption. But on the other side, innovation has always faced resistance within science and within the experience of the consumer. As we're innovating constantly here, we'll always face some resistance. It's about fighting against this resistance, and also the experience of the consumer is always above everything. People have to be there with us. In the communication of nicotine and harm reduction in general, we don't have to get caught in the narrative that it's healthier or it's better. Why? It's harm reduction because it's less harmful. We don't have to say that it's better, and we don't have to fall into this trap. We say that smokeless devices are less harmful, but it doesn't mean that they aren't harmful. And the other thing that we did was put all of this conversation in that whether the substance is legal or illegal, anything in excess has the same effect. Something else we've talked about is the failure traditional media in terms of their economic and moral interests. The media are in crisis. We know all of this. There's more and more evidence that they respond to political interests, they respond to economic interests, and above all, there's a huge crisis in traditional media. Makes us understand what they consume, what people consume. Our public inform us about what the traditional media say. People used to be on the prime time at 8 p.m. because the people that actually want to listen to me, they're probably watching Netflix. They're somewhere else right now. So understanding this was very important for us. And there's some data there on the right that 51% get their information from social media and 28% get it from TV. TV has dominated for 60 and 70 years, and they're no longer dominant right now. So that's important to understand. And it's a chaos that it's causing. And the other thing that's important is is our relationship with the industry. Everything that we worked with, the UN, Save the Children, Carrefour, all of this is very important. Philip Morris too. So it's a variety. So we have to be tough when the industry has bad practices. And we talked about this, where with a delivery system, for example, denouncing that what you bought something and you got a free vape. So these things are negative for us. So we have to bring them up and hold them accountable too. Something else is a right for the to speak directly to the consumer, not to the people that decide for them. So we speak directly to the consumer. Yes, it's important to talk to doctors and all of that, but at the end of the day, we have to speak to consumers. And there's plenty of strategies. We're always available to talk. And we talk to vapers as equals to them. That's important in communication. For them to see us as one of them. Many people that talk about vaping have never vaped. They've never smoked a cigarette. They've never consumed any substances. And so medicine and psychology have now lost the monopoly on their interpretation on drugs. They no longer have this monopoly because they've always talked about dangers, and they say that everything's harmful. So that's why they failed, because danger is the only way of convincing, and harm has failed. In recent conversations that we had, in recent debates, we're finally talking about pleasure, finally talk about satisfaction, talk about what nicotine's giving me, that I'm willing to take the risk of either dying through smoking or of abusing a device and having a negative consequence. It's time to talk about pleasure and talk about the rewards and put them on the table and analyze them alongside other substances and what consuming more than one substance can do to you. What does someone do after consuming heroin is smoke 5 cigarettes in a row. What happens when someone consumes ecstasy at a party? They just get stuck onto a vape. So nicotine is close to and related to many other substances. So we have to be very aware and very specific on how in the fact that we consider that vapes and these devices should not be an entryway into these substances. Therefore, people are already consuming the substances and to improve their quality of life. And finally, it's a change of narrative. It's a long-term project due to the disinformation, due to a prohibition, due to the moralism. So the change is cultural and generational. For us that talk about harm reduction in nicotine, these changes won't happen in 5 years, it won't happen in 10 years. We're just starting to see the results of what we started to talk about 10 years ago. It will be very long term. This will have many downfalls and many uprises. Some advances and we'll fall back to, but we have to trust the science, trust the cultural change, and trust in the experience of consumers. Thank you very much, Julian. And you remind me of something about this change in conversation, which Julian just mentioned. It's very interesting to see how the media have changed, how all of this has changed. Just like Miguel was talking about before, because you participate in these subsets, but in a way, in a more empowering way of empowering small content creators, creating a community to battle this fake information, false news, and creating empathy within users?
Yes. When I was trying to quit smoking, my story with tobacco, I learned when I was a little child. I think it's a problem with my generation in Brazil. We know that smoking is bad. We learned that. But many people learned the lesson because they had studied about this, because of health campaigns. Other people learned this because of pain, because of the suffering, to see relatives suffering. I know my generation is not very keen on smoking, but one thing is what you learn, and the other thing is what you do or what you leave. So I always thought that smoking would never be a problem. But when I was studying engineering at an elite and Spartan university, I found that it was a means of escape. Smoking was a means of escape. So I started smoking. And when I got to know vaping, I thought, that's really nice. That's really dangerous. But I had the idea, because the idea in Brazil is not that vaping or smoking is bad, but nicotine is bad. That's harmful. That's what we learned in Brazil. The whole playbook refers to that, and you find that in other parts of the world. The nicotine is the bad product. The negative thing is nicotine. So that was integrated into my DNA, in my soul. So when I got to know vaping, I couldn't believe in it. Why would I change 6 for half a dozen? So I was writing my thesis, and I started studying vaping issues. And I wanted to find scientific journals and articles and the like. So the first thing was that the authorities in Brazil were talking about that. And I thought, maybe this is not a good thing. But then I found out what the United Kingdom was stating, and I thought, okay, there's something wrong. There's one side which is not telling the truth, which is lying. So I had to start to do deep research to accept vaping as an alternative. And it took me another year to be able to start using. I like gadgets. I know myself. I like smoking gadgets, but I was really careful. I didn't want to change, as I said before, 6 for half a dozen. So I found out that it's so difficult to carry out research, because I know I'm privileged. I went to very good schools. I went to a very good university. I learned how to do research, but that's not the normal thing for people. So I started this project, Vaporopers. So what happened to me at the beginning was the technology issue, because I'm an electrical engineering. So, I mean, technology in itself. So I thought it was a very powerful tool to quit smoking, because I had tried to quit smoking for 2 years. And throughout those years were terrible years for me. I left university. I didn't know where this anguish was coming from. And that was because I was trying to quit smoking in the wrong way. So when I understood this, I thought I need to let other people know. I need to speak out. So I started my project, Vaporocket, which simplifies that. And also in Brazil, people, I speak a lot, sorry. I know I have a podcast, so I like talking, yeah, and that one is ready. But the point is, difficult questions have no easy answers. So if you're talking about something complex, no, and people tell you, you should this or that, that's wrong. The person is wrong. It's not easy to talk about that. So the project means that I need to sit down, I need to talk about vaping with that person, always exploring how the person was, how the person started smoking, vaping, how the transition was, how the life was transformed afterwards. And I started realizing that all the stories were similar. In fact, international stories are similar. Our stories here are similar. So to try to find similar stories gave me fuel to start talking to different people. So I just realized we cannot keep on talking for our own circle. So there were certain issues that I was not able to answer because I was not an activist at that time. Sorry, I was a person talking about vaping. So we started sending emails even to the industry because I don't know what you think. Because I was aware that the tobacco companies didn't like this because we started talking with toxicologist. The first one was a student, and then I managed to meet people like Ingrid, who's here today. She's a renowned toxicologist in Brazil. She's a member of the academy. So in Brazil, if you are a member of the pharmaceutical academy, you're immortal because it means you are a very special person. So I started to see that we have to talk about this. We need to be clear and simple about this and straightforward and show our example, just to show or lead by example. So we had to show there's a problem. We do have a problem. This is not 100% safe, but it's a tool that is used in other places. Why can't we use it? Why are we so different, Brazilian people? Because worldwide science cannot be applied to us. Aren't we entitled to the same right as other people have, let's say, in the United Kingdom and in other parts of the world? So starting by wondering this, I couldn't try to answer the questions, but I had to find the people who would help me to answer these questions. And that was the path. So the example started to inspire other people. Nowadays, for example, the Toxicology Brazilian Society has started giving speeches within the university talking about harm reduction. And so many years ago, we were thinking that we were the only crazy people who are talking about this. So now we have the Harm Reduction Science and Technology Association. So we are represented by them. We feel supported because we thought we were the only crazy people talking about that. So we learned that example speaks by itself. So whatever we do speaks by itself. So we have to do this with lab because we can only start by this. Within your four last speeches, you just answered to my different questions. So I see the way in which you are trying to communicate harm reduction, just to put at the same level or just to be play the same field as the consumer. So we have to have the same speech when we talk to regulators or politicians. Do we have to change the speech? Do we have to generate micro learning for politicians? Do we have to make it so simple for them to be able to understand the message? That's a question. How do you think we should change the topic of the message? Or maybe you have done so because you have already spoken to politicians. How was your experience? We need to think about public health. Harm reduction, we have been talking about for ages. We thought, okay, yeah, you need to improve the way of living of a person and things like that. But this harm reduction is impacting other daily aspects of life. So this is how we deal with politicians. It's not only a public health problem, it's also living together, safety. If we talk about smoke, which is really important, for example, in flats, in building blocks, there are people who smoke a lot cigarettes, for example, and people have called us and just say, could you please help us sort this out because this person can smoke within his apartment, because now it's a problem for neighbors or for in the corridors, because this goes beyond public health. So it's a matter of living together. So we need to think about that. And in Colombia, the things are the regulation in terms of illegal substances. So people think that in Colombia, this is only regarding to people who consume heroin or cocaine or whatever. No, it's just a regulation because people want to get rid of illegal market. What's going on in Australia? It's something that we're all looking at, the situation in Australia, because extreme prohibition is leading to a chaotic situation of a cartel war. So Mexico is just leading to that. I think you have already mentioned this, because there's a control in terms of selling these devices. So this is in the hands of the mafia. So we need to just separate ourselves from harm reduction. We need to include other scenarios, safety, the social scenario, and living together. And they like to talk about money. For example, American people love to talk about money. So if you just think how much money you're collecting in terms of taxes and the like. So, for example, cannabis tax, they have collected so much that they had to go to return money to citizens, because that was set forth by the law in force. So I think those are strategies that we need to think, and this it just extends or goes beyond public health. I love your point of view, and I think we should follow that to try to switch, to change the message, to keep on moving. Are we doing this together? That's what we have to ask ourselves. Are we getting the expected results? So we shouldn't just leave that just to self-asking our own strategies. One strategy which has worked in Brazil is just to occupy every single space that could be occupied. For example, if we talk about the drug debate, the consumer could take part. So we need to be there. We need to be present. I'm not going to mention every single thing, because I will give you the floor to you as well. But we need to think about this, because many people in Brazil, many regulators in Brazil are not aware of what's going on with the vaping, nicotine, alternative products. It's not the same as in Europe. So maybe America can show something. So we don't have full data, because people who oppose to this are not honest, are dishonest. Not all of them, but those who attended the Senate in Brazil, they are dishonest. They change the graph, they increase the scale, they change the data. So we need to show international experience. We need to try to be in every single space we can. So we start to generate a debate, and that has really worked. No, you, come on. We also found that something worked. And this is basically to talk, to speak out about rights. The rights people have to choose, really. I cannot understand still now why they have to tell you what you should do with your life. If you want something, you need to try, you need to fight for that. And then you see which the results are. But it doesn't mean that the government or the politicians should tell you, no, we're going to ban this shouldn't be like this. So we have just realized that this will not get to any point, because it's always talking about black market, chaos, and the black market is not interested in the consumers. So it's a long-term task. We need to keep on creating communities, strengthening ourselves. We need to work with people who are aligned with us, who are just striving in the same way. So we need, this is a matter of teamwork. We are not so many people, but the ones who are working now 24 hours a day and are passionate about this, we need to keep on doing the same. We need to keep on campaigning, spreading information. We need to make it easier to read or user-friendly. We need to talk to a regulator, a politician. Would be the same to talk to a medical doctor who doesn't have the same tools. So we need to start to repair this, or just to change this, so that this speech, so as to say it can reach every single person, but we need to work hard, and we need to get to know how we can manage to get the message reach these people. We need to work with the media. I'm working as a community manager in a magazine. It's a digital magazine, and we are looking at fighting against misinformation. So we need to keep on working on a daily basis by fighting, arguing. We publish articles all the time, but the most important thing is to keep on working together, hand in hand. Maybe it's something very tiny, but maybe infography that you can publish in the social media, which are user-friendly. We need to create platforms to include some videos so that politicians, if they don't have time, they can watch it, let's say, part by part, in sequences, so it's easier for them to read it. So we need to work hard on this. So we need to keep on working like this. That's the most important thing for. I do think that if we think of what we have been doing, now, we have evidence, we have the science. That's the truth. So we are fighting against something that exists. This is absurd, if I can put it that way. So we have been playing a game against these people opposing, which is a war that seems that will never end. So I think my son will keep on fighting for the same thing. Why? Because we are fighting against lies. Lies come from imagination, which is infinite. So we are explaining what we are not. We are not worse than smoke, worse than cigar, but we are talking about what we really are. So if we keep on fighting against all those lies, if people keep on having imagination to change statistics, estimate, this is never ending. So we need to be strong on who we are, who's the opposition. So let's not promote the opposition. So sometimes people say, oh, look at this, look at what they publish. So we all start attacking them, So we start just telling them, don't lie, don't lie. But we sometimes we are accomplices of those failures. So we need to concentrate on focus on who we are and to try to find allies, because empires have always been defeated by alliances. So you need to share what's going on in your own country, because then you go back to your country, to your own work, instead of working with bigger projects in which you are joined together in order to have a wider outreach so that the public opinion can understand what you're saying. Can I say something else? And that's what you said about asking for help. I think that should be the priority, the main strategy. The first time I spoke as an activist, I asked for help, and I don't manage to see how much help it's available at the moment. You don't need to discover the wheel, because the situation in Brazil is critical. Our neighbors are facing critical situations at the moment. I'm asking them, what are you doing, or what have you been doing to help us? So we need to ask for help. So people come to us. I never thought that Ingrid would be somebody who's helping the Brazilian community. And when I asked her why, She said because they're consumers, there's just popular need to do things in the right way. So this all comes from the help we have been asking for. So that's great. Julian, I think it's fundamental when you talk about these projects and the fact that you have gone from a situation in which you could have thought that it was only a fact of being reactive to misinformation in the media, to stigmatization, but now instead of being reactive, it's just proactive, and you're proposing debates as the one you have mentioned about different things. Which strategies do you think that could be implemented to change from being reactive, which we can see so many times in THR society or groups, to be more positive or to propose new ideas? I think we were tired of giving our opinion because opinions are subjective. So people would say, I don't give in an opinion, so I let the others as social media detectives, they just think they can do whatever, but they are not just prepared for the historical moment. They are not updated to see what we're living nowadays, because if they're not censorship, it's a matter of hate. So we are just fed up of giving opinions. So we went from opinion to evidence, and we started compiling or gathering evidence. So we started at the beginning having certain conversations from people. So you just check the right platform. So we have social media with so many followers, hundreds of followers. So the last conversation we took part with Alejandra and the likes were about censorship in social media. So it was close because we were talking about marijuana or cocaine or heroin. So we just reported this. We have our own speech. We made a complaint. So we just managed to get to reach the goal. And then we started just being stronger about our opinions. And this has not been close. And people would ask us, how did you recover your account? And we just said, we just complained about this. And so we managed to go back. So you need to be an amplifier of what people is living in this conversation, what people is living every day. So that's what we managed to do. And the other thing is that you need to work hard, and you can see so much work behind what is not in the social media. So this we could receive a reply from a petition we submitted to the government 4 or 5 months ago, but I remember the answer. I would like to receive something. We receive 8 pages with a reply with every single detail. So there's so much job or so much work behind it. So you need to plan, you need to sit down and say, what are we going to ask the government? So we need to gather information and evidence and make the most of the platforms and just leverage the platforms. That's what we have been doing. You have to measure, you have to listen to people to know what's going on and to make the most of the platforms available to you to do your best. So you need to contact public officials, the government, you need to ask them and they need to reply. So in terms of being reactive, when you have all the information, first have information, you can take your time to publish that. So we are not a means of communication. We are not a journal to be competing for the audience, let's say, but this happens to the teams, which is full of young people, and they are in crisis. Oh no, my social media account has been closed, and I just said, okay, don't worry. We're a project which works with people dealing with politicians, assisting to meetings, attending meetings, and who have a social media to reply, to answer to people who only use a social media platform, or there are three different things that we do have to be positive and not reactive. Oh, that's great. I don't know whether to get involved in this topic, but well, I would like to talk in terms of communication of the pink elephant we have here, which is children consumption, kids consumption, because there's a speech organized by the opposition with which this happens. What you're just saying, Julian, we are panicking, so you need to go out and reach the public. I never heard any activists or doctors saying that everything was safe for children. People who are dealing with THR, we always said that people who don't smoke shouldn't start vaping. It's not for kids' consumption or for children consumption. But there's evidently something that we're doing wrong. The message is not definitely right, because the audience don't understand. We're the main advocates for this. So this made me think, are we doing this right? Which should be the new strategies we should be implementing so people can get the right message, that we're really worried about children's consumption? Is there any kind of negligence in terms of marketing? Because marketing promotes, is there a lack of regulation? Are there any methods promoting this? Because we know teenagers love to do research, to go beyond the limits. So if I say this is not for underage, am I promoting them to try this, to do this? I just want to know your opinion. This is another subject which I think is absurd. This is a war that we get involved in that one. They are setting this war to us, and we are fighting here. Because when they say this will be harmful for children, we can talk about football, American football, and the like, because they're all attractive and they can all be harmful. So what about being a fireman, a policeman, astronaut? Because all the children want to be that, and they're all dangerous professions. So this is a matter of life. It's not harm reduction system. Whatever thing we do can be attractive, but this can be a social problem. So as a social issue, should be treated like that, not as harm reduction. So we need to think that the main responsible people are the parents, the family, not a product which is in the market. So the state should provide the right information so that population is informed about this. And then we need to know what's going on. But it's a matter of information. It's the obligation to inform, not to ban. But the thing is that the government is making a stigma on it. So we shouldn't be taking this, because it's a society problem, it's a social problem. I think just to look for the guilty party, maybe to cover things. So because they start with this speech, the children's speech, to ban. So as a mother, my daughter already knows what a vapor is. And she told me that at school, there's this and that person who's vaping. And what did you tell her? That this is an alternative for people who want to quit smoking. And that's exactly the message. So that's what we need to do, to spread the information so that people, no matter if they are parents, who are the main responsible people, to educate their children and to let them know if you are vaping, let's say, I don't know vaping would be like, but the important thing is that the person has the information and what the media are saying, because the media, let's say, we have been seeing in the last month that because we attended a social event, that they were not aware of harm reduction. They had no idea about alternatives. And we saw people smoking there. And we would tell them, do you know anything about this? No. Are you aware of this alternative? Yeah, I know, but I've been told this is worse. Why do you think it's worse? Because that's what the media are saying. So, Juan Carlos, this is really sad because there's so much evidence and people are not allowed to take a decision, a personal decision, because they just digest all the information that's being submitted to them. So we need to work hard on this issue. And in Colombia, Iberoamérica, we just say, no, that's not an alternative for underage people. It's just for people who want to quit smoking. Please, I don't want to be crucified. I understand what Mike is saying, that it's a duty of the government to spread information. It's about parents. But I do think the THR of Brazil are not talking to parents. I know THR Brazil are not talking to children, because we do know it's an adult debate, adult use, but we can educate children without lying to them, telling that nicotine will kill them, and to let them understand that there's a risk, and no matter which the risk is, but we need to educate them in terms of harm reduction, vaping, without making an apology of vaping. And I think there's a lack of action. I do think that's for adults, that's not for children. But who's talking to children to let them know this is not for you? Because in Brazil, we are trying to teach something, we educate on something. This is really problematic. So Ingrid is helping us. There's people working directly with teenagers. So I don't have all the data. They're not available. I have a spoiler, which refers to Cincha, who's a researcher. And she said that when we started, we were worried about this being a problem. Now we have started. We are certain that it's more than urgent. The debate about drugs, illicit drugs, for example, is for adult use when a person chooses to use that. But they do talk to young people, and they are explained that that's not something right. The debate about HIV, sex, and things like that, those are subjects or topics for adults, but you need to start communicating this without lying to young people, because you cannot wait until a person is 18 years old when you start teaching this person about vaping and harm and things like that. So you need to tell the truth. And you need to be careful on how you talk, because it's a typical thing of teenagers to challenge what you're saying, to try to everything, especially when you ban something, when you ban access to something. So we need to start this action. So if we don't have a well-planned action, they will hit us. They will punish us. And if we do things wrong, yeah, we will be crucified. So we need to have the courage to start talking where the problem lies.
I'll pick up on 3 points. First of all, the parents, the families. When we worked with schools and we asked children where they saw it first, it was at home. Who gave it to me? My uncle, my brother, my cousin. So first of all, we have to take that into account. When they reach our services, it's because they're already consuming. So why do you do it? Because you failed. You failed in prevention. I don't do prevention. You do prevention. I do harm reduction. So that's not our problem. The second thing is that the industry has bad practices. It has bad practices, and we've seen how in Colombia, in front of a school, set up a publicity cart with the main character is a reggaeton singer done as a comic, and they gift them away. So the industry has bad practice, and we have to bring them, to make them accountable for it. And thirdly, it's a fact that the conversation with kids, with adolescents especially, kids are very, very strange cases, but adolescents are more prevailing. And they talk about kids starting vaping when they're 12. How many? The percentile is so low, but they love saying that it's 12-year-olds. It's like, and they say no, but they try illegal substances at 18, at 16. But the message there shouldn't be on the substance, but on the construction of an identity during their adolescence. All of us want to become adults, and to be adults, we take on behaviors that adults have. So it may be a vape, it may be a certain hair color, it could be a piercing or a tattoo. So in the industry and with the state, we have to normalize certain things for it not to be part of their character, so they don't aspire to consume it. And they say, oh, you use drugs to fit in. And yes, I ended up fitting in, and it ended up working, and people started respecting me in my friendship group. It's part of life. There's not much we can do about it. So they'll look anything that represents rebelliousness or a forming of character. They'll just look for any object. It doesn't matter if it's a vape or a piercing or whatever. You have to understand this moment in their lives because they want to fit in. And we want to avoid these products being something aspirational for them. I wanted to ask if anyone in the public had any questions. Yes.
Gracias. Mi pregunta es para Julián Quintero.
Thank you very much. My question is for Julián Quintero. Julián, first of all, it's a pleasure to have you here. You got such a long experience in harm reduction. Seeing you here and talk about harm reduction on tobacco fills me with pleasure. I'm going to talk about that. There's a couple of questions, but I want to say one of my experiences before. In the harm reduction conference in your country, I found someone from Mexico, a government employee who works on harm reduction. And to my surprise, it was sad that when I found this person, he asked me, "Oh, who brought you here?" And I told him, "No, I'm coming for a satellite event." And he told me, "Oh, you come with the fake harm reductionists." So do you find a certain stigma coming from other harm reduction people on other substances? Have you found this? Have you experienced this too? And if you find them, what can you tell them? Of course, every day. It's a relationship with industry and why are you involved in all of this? And when I got into this topic, we knew what we were getting into. And in a way, we've always been very transparent. We've always set everything out on the table. We've worked with the pharmaceutical industry in terms of medicine. We've worked with the alcohol industry, which is the most harmful thing, as we've said before. We've worked in the nicotine industry. But if you're transparent, if you lay everything on the table, and time ends up making you right, and everyone that used to criticize us 7, 6, 8 years ago, they're getting into the conversation on nicotine now. So that's key. Being transparent, trusting what you do, and that's the way we're going. Any substance, whether it's legal or illegal, in excess is bad for you, and that's what we're working on. You have to relax. You don't have to build up great movies and fantasize about the big enemy. Work with dealers. Imagine what I'm talking about. My analysis of substances comes, dealers come to me with all their bags, and they ask me, what does this have? What does this bag have? Imagine if I can work with them, why would I be scared to work with people that work legally? It does make me laugh sometimes when people worry too much. There's a report coming out this week on someone that cooks 2CB on our websites, and he asks what this does to you, and he asks us a lot of questions for his clients. I'm waiting for the mic to be turned on. Thank you. Hi, I'm Ignacio Leiva from Chile. For those that don't know Julian, he's like a super rock star in Latin America in terms of harm reduction. I know he's very modest, but I greatly admire you. Having said that, I also wanted to ask about something similar, but go further into the issue. In our case, in case of harm reduction activists, we have this stigma that's very deep regarding our harm reduction on tobacco compared to other substances that they accuse us of being close to the industry, which isn't true. So despite all the advances that we've had, what can we do, the activists that aren't close to the industry, in terms of global tobacco harm reduction, to convince everyone that this is just as valid, or at least just as valid as the harm reduction that's been done in other areas? What can you do? What can we do, in your experience? I think that science fights with science. Evidence is very important here. So one thing is having the evidence and putting it into speculation, but we also have to be patient. This doesn't happen from one day to the next, just like you said. We had a conference in Colombia, and getting the conversation in there was very tough. And it was tough because Bloomberg funded the conference too. And they would say, oh no, how can we talk about harm reduction in this sense? And that's what allowed the topic to be talked about. So many people talking about the people that just didn't have an interest, people that saw that this worked. So you have to be patient, you have to have the evidence, communicate it, listen to the users, and not get involved in these conversations about you being a part of the industry or you working with them, because you just end up just answering other people. You end up getting involved in something you don't want to get involved in. And this does happen. And I wanted to add that maybe through you, we could convey a message regarding a scientific data that we didn't have the opportunity to communicate at Harm Reduction 25, and it's that 90% of drug users is a user of traditional cigarette. That means that 1 out of every 2 drug users will die due to something caused directly by tobacco. And that's something that could open doors, and due to the lack of participation that we had, we couldn't raise this awareness. But I think this argument could be very important to make people understand that we're not a part of the industry, but instead that more people die due to tough drugs. People that use tough drugs die more due to cigarette use rather than the use of those hard drugs themselves. They're more likely to die from tobacco than the drug. I think that's a great entry point. If us, or if you, or if us that are at this scenario talking about tobacco health reduction want to make other harm reduction substances fall in love with us, I'm sure they will, because we're close to them. And what you said is very definitive. So I wanted to give you that. I wanted to give you that data so you could spread it around. There's people that are when they're in their first step of detoxing for 3 weeks, let's say. You ask to be able to smoke a cigarette rather than consume the hard drug that you're rehabbing for. If you ask for the door to be open, the door has to be open for you. You retire from the treatment immediately, and they ask to do this for nicotine. So there's programs, and we've seen that say, because they're extremely strict with the detox, and nothing is nothing. You can't have alcohol, you can't have nicotine. But in some cases, they decide to give us these cigarettes so they can keep them in the program. So if we can relate this could be a very important push. Most people that consume drugs also smoke, just like you said. The right number is 80%, sorry, not 90%. And some people that give that are in charge of rehab facilities are now allowing vaping too, which is important. Well, I wanted to say something to Ignacio and to Julian, that in my experience, I had to speak in front of the Senate. And I was thinking, what can I tell them? So right here, you spoke about this, and they don't know what harm reduction is. So I simply spoke as a toxicologist, setting the data up on putting the graphs and the rations, and I spoke in a very simple way, but without the possibility for them to answer me. Because every number I put on the presentation had a reference at the bottom. And I wasn't talking about tough science, talking extremely in-depth. I spoke about deep things, but very simply. And something else I want to say is that I didn't give them the opportunity to answer or to generate a fight. I spoke firmly, especially due to the time that I was given. Do you know what happened at the end? The floor was opened up for questions, and all you could hear was silence. No questions. So we don't have to fight. I was listening to this, and it's if the topic, they're not interested in the topic, we'll never talk about this. Thank you, Ingrid. We're kind of short on time. Just to close up, can we briefly, did everyone understand, briefly,
pensando en el futuro,
Talking about the
si
future,
tuvieran que
speaking about the
elegir
future,
una acción directa, financiada, que sea
if you had to choose
posible, que
one
sea
direct
real,
action
tangible,
that was finance
de
backed,
mejorar la
plausible,
comunicación en cada
to
una de
improve the
las áreas, ¿sí?
communication in
Una
each of
sola
the
acción, ¿qué
areas,
les parecería? ¿Qué
just one,
propondrían?
which one would
¿Están
it be?
haciendo
What would
todo
you
bien?
propose?
No, ¿qué mejorarían?
Are we doing
Rápido,
everything right? Are we not?
a la voz de Aura.
What would you improve quickly?
Yo sí me montaría un piloto duro de entregar dispositivos
I would back a tough
de
pilot
combustión a
of
personas que
granting non-combustible devices
drogas en
to people that
contextos
use other
problemáticos.
drugs
Sí, o sea, me
in
montaría un
problematic
piloto con
contexts.
consumidores de heroína,
I'd back
100
this project
personas
with heroin
consumidores de
users,
heroína, y
100
estarles
users, 100
suministrando
heroin consumers,
como un
and
piloto de
supply them
dispositivos
with
electrónicos y medir eso en unos 6 meses, 8
electronic
meses,
devices
a ver qué tal,
and give them
si
6
cambió la
months,
vida
8
o no,
months to see
si mejoró
if
su
their
estado de
lives
vida.
change or not, if their health improves
Ese
or
es
not.
un muy buen piloto. Podríamos también estar utilizando.
That's a good project that we
No,
could
pues
also
realmente,
use.
aparte de lo que dijo Julián, que siento que
But
podemos
apart from what
estar robando
Julian
la
said,
idea.
which I think we could steal
También
his
es,
idea,
básicamente, pues,
it's
seguir
also
trabajando con la
basically
información que tenemos.
to keep working with information that we have.
Y,
Can you hear me?
y lo
Yes.
que yo les decía, o sea, realmente lo que nos interesa
And what I was
es que
saying is, what we're
los
interested
políticos,
in
los médicos, bueno,
is that
muchas
politicians,
personas nos
doctors,
escuchen, pero no tenemos cómo acceder
a lot of
muchas veces
people
a ellos.
should
Entonces
listen to
podría
us,
ser,
but many times
diría
we
yo,
don't have a way of accessing them. So
financiarla y todo eso,
what would be
como
important
una micro plataforma chiquita
is if we
que
could finance a small
tenga varios
platform
videos chiquitos resumiendo
which has a
como
lot of
una
small
evidencia
videos
de
just
un estudio científico
summarizing some of the
y
evidence,
que esto sea pues
scientific
fácil y que sea
investigation,
menos de 2 minutos, porque
which
sabemos que
could
el
be
día a día
short,
de
easy,
cualquier
just
persona y más de
shorter
un
than 2
político, de
minutes,
un médico,
because we know that in the
etcétera,
day-to-day life
pues
of a
es
politician or a
menos
doctor
todo el día.
doesn't
Entonces,
have enough time,
que estos
and
videos ellos
their
los
lives
puedan
just
ver
run
como en
very
un
quickly.
ascensor o un
So
espacio así
just
rápido
videos that they could
y que
watch in an
entiendan qué es lo que les
elevator or
está
quickly,
pues
and for
transmitiendo
them
en
to
ese mensaje.
understand what's being
Básicamente yo creo que es eso, porque
transmitted
siento
in
que a
that
veces las
message.
redes y
I think
todo eso, o sea,
that's
la gente
what
pasa,
should
pasa
happen,
y
because
se pierde la información.
in social
Y
media
los
people just
likes y todo
scroll
eso
and
también
scroll
nos
and
dimos
scroll,
cuenta
and
que eso también ha
and
perdido
information's
mucho
just
alcance.
lost in the way.
Entonces yo siento que es algo más dirigido a ellos,
We've
algo
lost
que
some of the
podamos
reach
darle
in
más a
that
ellos,
sense.
a
So if we could
médicos,
direct this
políticos, bueno, esta es
to
una
the
plataforma para
politicians,
mamás para que entiendan también.
platform
Entonces,
for
pues,
something for
no sé, sería
mothers too,
chévere.
so they understand the product. That's just something that comes to my mind.
A mí, la parte difícil es una idea, de hecho.
The difficult part is just saying one idea.
Me encantaría, no creo, no, me encantaría poder entrar más en la
I would
universidad
love
para hablar
to
con
be
las
able to
personas, con los
enter
estudiantes de
universities
medicina,
more,
los
to talk
estudiantes
with
de la
people,
salud en
talk with
general,
medicine students,
para
talk with
formar una
students
nueva
on health in
generación
general,
de
to form a new
profesionales que sean más
generation
humanos,
of
que
professionals
puedan ver
that are more
esa
human
reducción de daños con los mismos ojos que nosotros
and that they
tenemos.
could see harm reduction with
No
the
es que
same
yo
eyes that
creo que
we
la
look at
generación
harm reduction.
actual está perdida, pero yo
I
creo
don't,
mucho
I'm not saying that the
ese
current
cambio
generation's
genera otros
lost,
cambios y se
but I
transforma
think that
en una bola de nieve.
this change will generate other changes and it'll be a snowball effect. Well, I'll say something I've thought about for many years, and every time I say it, people call me an idiot because it won't end up happening, but I still think about it. We have a very strong competition. We have everyone that's against us who have great economic strengths and they can just keep spreading lies constantly. And as Hitler said, if you say a lie 1,000 times, it'll become true. I've always thought that we should create an international movement, an international vaping day for all of us who go out on the streets. As Latins, we love parties, coming out in every sense of the way, creating a party so that people can see that people that look for harm reduction and users are healthy people that you see us on the streets. We arrive at home smelling of strawberries. So we're normal people, but we should come out and inform people. We should be on the streets, all of us, on the same day in the whole world, so the media have to genuinely find out what's behind us. Once it comes out in every media, it'll be news. It will reach everyone and reach the society that maybe don't know what harm reduction is. I would love that. And it's still in my mind. So hopefully it does happen at some point.
Bueno, todos los presentes, primero que todo, muchísimas gracias por haber participado.
Well, thank you very much to everyone that's participated and everyone that's been here listening to us. It's been incredible as per usual. And I don't know, Diego, if you want to say something else. Yes, thank you very much to everyone. And a brief thought. Everyone from your sector, from wherever you work, if we're doing the right things, if we're communicating properly, if the subject that we're talking to is understanding us, and we have to do this constantly. We shouldn't just believe that we're doing everything properly, because the doubt that you generate in yourself will allow us to keep evolving further. And that's what this is all about. People keep evolving, and all of us from tobacco harm reduction have the need to keep evolving in our message. That's what I wanted to say, and I know we're on time. So that's all. Finished. Thank you very much, everyone.
Right, hello everyone. It's just gone 4 o'clock, so I'm going to start, even though people are still coming in. I hope they can pick up what we've been talking about. Anyway, my name's Martin Cullip. I'm a former smoker. I'm a consumer advocate. I use nicotine products. I vape and I use nicotine pouches. And I'm currently a contractor with the Taxpayers Protection Alliance in Washington, D.C. So I'll be your host today. I just want to start off talking about something that happened. People who've come to this event might remember from 2017. Ethan Nadelman delivered the Michael Russell Oration back then. And he comes from a drugs background, and he compared nicotine use with drug use back then. And he said, we're on easy street here, because when you're talking about drugs, it's completely different. Whereas you can just, you can use nicotine openly, millions of people do it, and we're not traumatized by that. But what a difference we have now, where nicotine is now being demonized more and more. So just in the last 7 or 8 years, the whole situation has changed. We're now seeing some countries like France, Netherlands, Belgium talking about banning nicotine pouches, and they're attacking them. The UK government is now saying they're going to bring in regulations on pouches. And there's a different regulatory landscape around the world with the USA, obviously Australia, and other countries as well. So we're going to talk about pouches. I want to talk first about the fact that some countries are banning these products. Now, this seems to me to go against the harm principle, which was exposed by J.S. Mill in 1859. And he says on restricting products, which are only harmful to one person, that the only purpose for which power can be rightfully exercised over any member of a civilized community against his will is to prevent harm to others. His own good, either physical or moral, is not a sufficient warrant. And he talks specifically about restricting access to these products that is only suited to a state of society in which the labouring classes are avowedly treated as children and savages. So we have these countries now banning products that are far less harmful, but it's important to realise that cigarettes are legally available in every single country in the world. There's not a single restriction anywhere. They do talk about how pouches could be dangerous for children, and that's definitely a concern. But it seems to me that using that is really blaming the products for the problems rather than the regulations on the products. We don't do that with other age-gated products. And I just want to leave you with a letter that I saw in April in the New Yorker, because there's still this controversy about pouches in America. And it was from a guy called Robert Bailey, who's a clinical psychologist from Seattle, Washington State. And he said in this letter, smoking is still, in 2025, the leading cause of preventable mortality and morbidity in America. In a broader context, if you were to regularly drive a motor vehicle, walk on city sidewalks, or ride a bike, you would almost certainly be putting yourself at more risk than you would be by popping in a Zyn pouch. Smokers would be wise to consider the switch safe. So that's a clinical psychologist said that, not me. But it was an interesting letter. So we're going to introduce the panel here. We've got some people who know about nicotine pouches, more than me as a user. So I will introduce them to you. We'll start on my left here. We have Anna Fransson, who holds an MSc in pharmaceutical biosciences and a PhD in toxicology from Uppsala University, Sweden. With over 20 years' experience in the pharmaceutical industry and regulatory environments such as the Swedish Medical Products Agency, Anna has developed a deep expertise in risk assessment, clinical research, and regulatory strategies. She has also worked extensively in the industry, academic collaborations, supporting the development of innovative healthcare solutions. Anna joined Emplicure in 2021 and leads the company's regulatory strategy. Passionate about innovation and safety, she is dedicated to advancing novel solutions for nicotine and drug delivery. So, welcome, Anna. Mark Oates, on my far left, is the director of WeVape and the Snus Users Association in the UK, which are both consumer groups standing up for the right of individuals to use safer nicotine products. He advocates for evidence-based harm reduction in a range of areas, from tobacco to drug policy, a subject he has written on for the Institute of Economic Affairs and the Adam Smith Institute, where he is a fellow. He's also provided consumer evidence in the 2018 ECJ case to overturn the ban of snus across the European Union when he was a parliamentary researcher to an MP. Cecilia Kinstrand is an editorial director, has spent the last 15 years working for Swedish Match in Brussels, a company with tobacco harm reduction at the core of its business. She predominantly focuses on EU regulatory matters, especially the TPD 2014/40, the legislation banning the proof of concept of tobacco harm reduction in 26 of the 27 member states. Since PMI's acquisition of Swedish Match, she now represents PMI. The focus of her work remains the same. And lastly, Barnaby Page, editorial director of Tamarind Intelligence, the publisher of e-cig Intelligence, Tobacco Intelligence, and Can Intelligence. As a journalist, he has been covering the worldwide reduced-risk nicotine sector since 2014, with a particular focus on public health and regulatory issues. In his current role, he manages Tamarind's editorial and reporting teams, producing a wide range of nicotine-related content. He's been participating in the Global Forum on Nicotine since its inception. Before coming into this field, Barnaby spent 30 years as a reporter and editor for newspapers, magazines, and online services, specialising in technology and business, and is based near London. So welcome to everyone. I want to start with you, Barnaby, because you can maybe explain the market as it is for pouches at the moment before we get into the more technical matters.
Sure, yeah, I'll try to give a quick overview. Well, I think it may surprise a lot of people to know that nicotine pouches have been around a lot longer than we generally think. ZYN, in fact, will be 10 years old next year, so it's much the same age as the Global Forum on Nicotine, which is slightly older than 10. But of course, it's only really in the last 2-3 years that they have really rocketed into the public consciousness. Having been pretty much niche products for a long time, familiar to users, familiar to consumers, and familiar to some people in THR, but really until a few years ago, completely off the radar of regulators and policymakers and the media as well. That is now changing, of course, very rapidly, and I think one of the things I will probably come back to in today's session is the question of whether we are now going to have a pouch moral panic as we did have a vape moral panic a decade or so ago. But just to give you a very, very quick idea of the pouch market and how it is regulated, I'm certainly not going to go country by country. Our estimates at Tamarind are that the market is currently worth about $7.5 billion annually. That's roughly speaking, a quarter of the size of the vape market or the heated tobacco market. So it's still pretty small in comparison with those. But the significant thing is it is growing very, very, very quickly. Barclays, in fact, in a recent report, forecast a quite astonishing 1,000% growth over the next 10 years. I don't know that we go quite that far, and they're actually starting from a slightly higher base than us. But we're certainly looking at that kind of escalation in market size that, again, parallels what we saw with vape in the early days. In terms of the market structure, a couple of things are worth noting. One is that, and much of this will be familiar to many people in this room, of course. One is that, unlike the vape sector, the pouch market is pretty much dominated by the big tobacco players. Another one, which perhaps is less obvious, is that while the vape sector, online purchasing, online shopping is a pretty important channel, pouch users, interestingly, are very, very much more enthusiastic about face-to-face purchases. So it's much more dominated by bricks-and-mortar retail stores. We can speculate as to the reasons for that, but it's a sort of interesting quirk of the market. And so then the question of regulation, well, I think the one thing we can say with certainty about pouch regulation is that the story isn't over yet. It's in a state of flux right at the moment. In a lot of countries, I mean, if you look at Europe, for example, you have a big split with many countries currently regulating pouches basically as any other consumer product, while there's a sort of strip of countries in Central and Eastern Europe and also in the Nordic nations that regulate them as tobacco products. So once again, it's looking very like the vape market did, perhaps 10 or a little less years ago. But we have a lot of moves afoot to change that. People will know about the bans that already exist in Belgium and the Netherlands, Lithuania as well. We have a proposal to ban pouches in France, as well as, I think, 3 counter-proposals to regulate them. There are talks about reducing nicotine limits to effectively ban levels in Spain. And then looking further afield, of course, there are countries like Canada where pouches are classified as pharmaceutical products. Australia, ditto, although there it's a kind of notional classification because nobody actually has a license to produce them. And then you have countries with outright bans, as sort of mentioned, I think, Belgium, the Netherlands, Russia, Brazil, Argentina, for example. And finally, just as an example of the complexity of how this product can be regulated, you have the very odd case in Germany where pouches are treated as foods, they're treated as novel foods under EU regulation, so you would need authorization for them as a novel foodstuff to sell them legally. Needless to add, that hasn't been forthcoming. I won't talk about tax at length. I think it's just worth noting, because it's probably a thing that has come up or will come up elsewhere in the conference. There's been, again, yet another recently leaked EU proposal or the EC proposal for taxes on nicotine and tobacco products generally in the past couple of weeks, which would see a very, very heavy tax rate go on to pouches, about 40–50% of the retail price. So I'm afraid I don't have a single takeaway from that, except that the situation is pretty mixed. The direction of travel is not necessarily an entirely positive one. You know, people are more talking about prohibiting pouches than about liberalising the market, but certainly nothing is resolved yet. So I'm sure a great deal to talk about in that context. Anyway, I've probably spoken enough now. So.
I want to ask you one quick question, because you touched on a number of jurisdictions there. What do you make of what's happening in America? Because it's almost become political in America, isn't it? And there's a big rise in products, and we have the FDA has given MRTP or FDA orders to it. What's going on there?
That is an interesting question. In fact, thank you for reminding me, because I meant to mention the US, and in the excitement of talking about Germany's novel food status, I completely, the biggest market in the world, completely slipped my mind. Yes, I mean, the US, of course, is a curious situation because we all know it has the PMTA system, exactly the same as applies to e-cigarettes or indeed to combustibles, also applies to pouches. We all know that system doesn't work terribly well. Its dysfunctionality is less obvious in the world of pouch, simply because you don't have tens of millions of applications of pouch products. Now, the FDA has, of course, approved the Zyn product, for sale, so that's legally on sale. And there's now an application has gone in for modified risk status for Zyn, which, if granted, would allow essentially statements, formal statements on packaging, etc., that the product is less harmful than others. That would be quite a coup if it is granted. It was granted, of course, before to Swedish Match Snus. In fact, it's been granted to IQOS, so that seems, the heated tobacco product, that seems to have been largely forgotten. So in a sense, the US market is actually a more officially tolerant one for pouch than many other markets are. What we do have in the US, at the same time, I think we have signs of the potential emergence of a nicotine-naive consumer market for pouches, rather than simply a substitute or an off-ramp for smoking, which is precisely the kind of thing that, of course, is going to get regulators and the public health establishment worried. So that's the downside in the US. So the bottom line there is US less vehement in opposition at the moment, but I think the makings for future opposition and panic are certainly there.
Okay, thanks very much for that. Okay, we're going to go to you next, Anna, because we've heard the regulatory, the market aspect, but you can talk about the science behind these pouches, can't you?
Well, yes. So with a background as a toxicologist, I was asked to offer more of a risk management perspective of this. And, you know, I considered starting with, you know, letting you know the well-known, that more than 8 million people die every year from tobacco use, the links to lung cancer, heart disease, and COPD, or maybe just walk you through the toxicity profile of tobacco smoke with carbon monoxide, tar, and more than 50 known carcinogens. But all of this you already know. And then I thought I would highlight Sweden, where the daily smoking rates has dropped below 5%. This is one of the lowest, if not the lowest, in the world. And according to the WHO, the definition of a non-smoking country. So that is really a remarkable public health achievement, with the Swedish snus being one of the parameters for that. But again, I think that is familiar territory for you. So, because the risks and consequences of tobacco smoking, they are extremely well known. So what I think really matters now is how we manage these risks. And risk management, that is really the process of identifying, assessing, and prioritizing risks, and really taking actions to minimize harm. And this is like the core framework in any assessment of the public health. And also I think it's a driving force for innovations, from the safety belt to vaccines, or even the innovation of the bioceramic nicotine pouches that I stand for. So the goal here is really not to eliminate all risks, because that is rarely achievable, but to manage the risks well for the greatest possible public health gain. So that I think, we all can agree upon that is the goal. And in this case, we need to make an important distinction between nicotine in itself and the hundreds of toxicants that are included in tobacco smoke. So, and I sometimes hear this statement that we lack long-term studies on nicotine. I would say that this is a misunderstanding. In fact, nicotine has been available on the market as a medicinal drug for smoking cessation for more than 40 years. Nicotine replacement therapy it is approved by regulatory authorities. It is recommended by physicians, and it has been used safely for decades. So when nicotine is separated from tobacco and combustion, the risk profile dramatically decreases, both short-term and long-term. So, this we know. So for a risk-benefit assessment, it's also essential to consider the dose-response relationship and exposure. And that said, I think it's important that we need to ensure that the nicotine levels and the delivery profile in nicotine pouches, that they are appropriately balanced. So on one side, they need to drive the transition from tobacco smoking. And on the other side, they shouldn't be so high as to increase any potential for unintended consequences. So I would say that with all the science and evidence knowledge that we have, along with new innovations within this category, we are very well positioned to support policymakers in making informed regulatory decisions. And I think that these regulatory strategies really should acknowledge the needs of the intended users, while also, of course, safeguarding the underage use. So, I also think it's important that if we only a fraction of the 1.1 billion tobacco smokers worldwide, if they switch to nicotine alternatives, the public health gain would really be profound, and millions of lives extended and population health improved. And with that, the economic benefits would, of course, naturally follow as well. Reducing, I just read the estimated global cost attributed to tobacco smoking is about $1.4 trillion US. So really from a toxicology and risk management perspective, nicotine pouches represents a highly effective intervention, eliminating the exposure to the most harmful aspects of tobacco use, which is combustion. So in that sense, I think the science is clear. So given the favorable risk-benefit profile of nicotine pouches, these consumer products definitely have an important role in advancing the public health.
I want to ask you a question which may be a bit frivolous, I suppose. I went to Sweden last year, and I spoke to Swedish people because I'd never seen. I've heard about Sweden. I've written about it, but I was there for 4 days. I think I saw one person smoking a cigarette. Yeah. And you go into the bars. I think there was a football competition at the time. I don't know what it was. I'm not a football fan. And you just saw people sitting there, and you saw no cigarette packets. You just saw cans of pouches or snus. And we know what happened to Sweden, but talking to Swedish people, they don't know that we talk about them. I said, we talk about Sweden all the time. And they said, we didn't know why, but what are we doing so different? You know, they just don't know. So why does the rest of the world kind of ignore what Sweden's doing and the results from Sweden, which seem undeniably good from a public health?
Well, that's a hard question, but one reason might be that the Swedes hasn't been, I mean, we have forgotten that we are unique in this way, and we have forgotten that in Sweden we used to smoke. We have normalized that we don't smoke anymore. So I think that is one big reason, and I also think that, I mean, until just recently, the Swedish government hasn't talked so much about this. But now they're starting to do that regarding both France and Spain, I think, and they are really telling the message that the use of both Swedish snus and nicotine pouches is one reason that we have so low smoking levels, but also a reason why we have so low prevalence of lung cancer, because the Swedish snus has been around for so long time, so we can do that kind of research.
It was about 200 years they've used snus, haven't they, in Sweden? Something like that?
Perhaps, if you say so.
Okay, thanks. Mark, you're a consumer like me, a very enthusiastic consumer, as I know. Do you want to give us a talk about what your experiences are with consumer use of snus?
Yes.
And pouches, sorry.
So I quit smoking through a combination of snus and vaping, but I was working in China smoking 50p pack cigarettes, and I flew home via Sweden and bought what I thought was chewing tobacco. Found out later it wasn't. It was pasteurized Swedish snus. And then on my return to the UK, couldn't get hold of any more snus because it was illegal to sell. So the British government and the European Union were complicit in keeping me smoking for a number of years because I could only so often get some snus. And, you know, I've looked at this, and anyone can try and find a different law. But I think the ban on Swedish snus in the European Union is the law that has killed the most people. I'll happily buy someone a meal if someone can find me a law that competes with it. But it's shocking, really, and there's a real risk that we do the same thing with nicotine pouches. But let's go big picture for a second. Nicotine pouches could be the 21st century invention that saves the most lives this century. That's really possible. You know, in the 20th century, we had vaccines. But this century, potentially, nicotine pouches, if they're given the opportunity, could save millions of lives each year. Now, why nicotine pouches compared to vaping on that? Well, the real point there is that nicotine pouches can be produced at a price competitive rate to cigarettes, which when it comes to low and middle income countries is vitally important because vapes are more expensive to produce and so can't be sold to compete with 50p a pack cigarettes. We know the price point works. You know, in the developed world, vaping has been successful because it's cheaper in most countries than smoking. But that's only because the developed world taxes cigarettes at such a high rate that it's cheaper. But that doesn't really exist in the lower middle income countries. So it really frustrates me that when you Google nicotine pouches, you can find nothing but negative stories when there's this amazing story to be told. And I would just encourage any journalist to look at this and realize this is the story that should be being told about this product. And journalists are extremely powerful. They can have an effect on the number of people that use this product and therefore the number of people that die from smoking. Yeah, I very much believe in a hierarchy of preference. So I have a sort of preference list of what I choose when it comes to nicotine consumption. And, you know, right at the top is snus, actually. And second, probably vaping, and then or nicotine pouches. And then fourth, probably smoking, okay? Now, my point with this is that if countries remove the top one from the list and the next one down for that consumer is smoking, they're going to go to smoking. And I see that a lot, where you'll have someone that, say, would use heat-not-burn products, and their second choice would be smoking, and third would be vaping. But that country potentially has banned heat not burn. So politicians should leave the decision-making of what product the consumers want to choose to that consumer. I think policymakers and those in public health struggle with that philosophy. They're so used to prescribing the answer. They're so used to telling people what they should do with their lives and not realizing they should leave a smorgasbord of options to the consumer to make their own decision. So choice is vitally important. And on that matter of choice, there's demand. And frankly, politicians can't control the demands of the public. They can shape them with regulations. They can shape them with allowing or disallowing advertising. But if there's a demand there for a product, implementing bans like we're now doing in the UK, with bans on disposable vapes, potentially bans on flavors, taxes, it doesn't end demand. We know that from the world of drugs. All it does is remove legal supply. And like with me, I found my illegal supply of snus on the market. And if they go and ban nicotine pouches, I will therefore be forced to go to the black market. But I will, and nothing will stop me doing that.
Let me bring up the subject of education, because you're talking about these products as if you have a perfectly educated population, you know, of these products. But I speak to people often, and they confuse pouches with other forms of smokeless tobacco, like chewing tobacco or some of the stuff you get in Asian countries. And you'll regularly see, if there's an article about nicotine pouches, something in, below the line in Daily Mail or somewhere saying, oh, well, they're fine if you want a hole in your throat or something, where they're talking about a completely different product. So how do we get the public to understand what pouches are and what snus is? Because, I mean, snus has only recently talked about in the subject of footballers using, for example. I mean, how do we get the public to understand what the difference these products are? Because I didn't know myself, really, until I started using them.
Well, it would be helpful if journalists were reporting more accurately. Not all journalists are inaccurate, but most in the UK press are. And I work very hard to try and inform journalists of the facts. The public sector has a very strong role. So in our country, the National Health Service, the effect of Public Health England coming out and saying vaping is 95% safer, at least in comparison to smoking. And for, you know, this product's been around in the UK for a good 6 years, but yet it hasn't been jumped on by smoking cessation services, and it should do. And I think that would be a really big win if alongside vaping products there was also nicotine pouches. The biggest comparison is the COVID vaccine, okay? The public perception of the COVID vaccine, a huge amount of money and effort was put in by governments across the world, but in Britain we put hundreds of millions into informing the public of the facts. And the government just doesn't seem willing to do the same thing when it comes to smoking and safer nicotine products. Now, they don't actually have to. It can be left to industry, because they're the ones that are going to make the money out of the product, with a framework that they have to work to, allow that message to get out to the public. I think in the UK, cigarette packets should have a little card in them that informs the smoker of the options and alternatives, so that they know that there's heat not burn out there. Heat not burn suffers from a lack of marketing because of the fact it's got tobacco in. And there's so many smokers that have tried vaping, it's not for them. But if they knew about heat not burn, they could make the switch. They could be informed on pouches, they could be informed on vaping products too. So if government's unwilling to put money in, then at least leave the opportunity for industry to have a clearly defined message, not a commercial message. You know, I don't think that would be right, but a facts-based message. Perhaps a message from our chief medical officer. You know, he was very keen to tell us all that the COVID vaccine was safe. It was a very successful campaign, quite rightly. We should do the same thing with safer nicotine products.
Okay, thanks, yeah. And last, we come to you, Cecilia. Do you want to give us your initial views?
Thank you. The theme of this panel is what's the real story regarding nicotine pouches, and as many other in the panel has been talking about snus, I think it's impossible to separate the development or the growth of snus in the Swedish and Norwegian market from what we see now with nicotine pouches. Snus used to be a very clay-like, fairly not attractive product, but there was consumer demand, and according to the urban legend, there was a retirement home outside Gothenburg that went to the company that was the state company at the time and asked them to sort out the administration of snus, because they felt that the staff shouldn't be able to bake the snus for the retired older gentlemen. So the company, the state monopoly, went back and figured out that we'll just stick it in a tea bag. And this was done in the 1970s. That led to, it took some time, but it led to uptake of snus because it became an attractive product. It became more attractive to use. It became easier to use. And since that time, since the 1970s, it has really grown in Sweden. As Anna pointed out, we are below 5%. And there are, if you look at different age groups, if you look at the younger age group, you have virtually no one going into smoking. And you see the same pattern in Norway, that young people do not start. So it's almost like a vaccination. And this is according to public health data, public statistics. And then, of course, this all took place. Sweden was not a member of the European Union. UST started their factory in Scotland and with moist snuff, Skull Bandits. And then the UK, thank you very much for that, decided to ban oral tobacco. And that ban later was transferred into the European communities. So we came with and that happened before Sweden and Finland and Austria joined in '95. And this is quite interesting because we managed to get an exemption. We wouldn't have joined the European Union if we wouldn't have been allowed to keep snus on the market, because it became a matter of national pride. The Norwegians negotiated membership at the same time. They never joined, but that became their agreement with the European Union. Finland also initially had the same exemption, but they traded it towards the end of the negotiations for agricultural subsidies. So it was the last trade they did in the negotiation. So we joined with the possibility to keep snus on the market, and the same was the case for Norway in their agreement with the EU. And that led to remarkable public health impact. I know other people, the other side is usually saying that, well, Swedish men don't smoke because they're very good at understanding public health information. There is one such quote in a Commission article. During the Court of Justice, the council representative said that the reason Swedish men don't smoke is because our paternity leave. There's so many different explanations from the public health side trying to explain why Swedish men don't smoke, but they will not entertain the idea that snus could have something to do with it, which is interesting if you consider the tobacco consumption pattern in Sweden. I don't want to talk to you about the enormous amount of data we have, public health data, on the impact of using pasteurized, low nitrosamine smokeless tobacco. It's there. I joined the company Swedish Match 15 years ago because we thought that it would be possible to remove the ban on snus. We have the data. Look at the statistics. Look at the data. But then it's not about logic. This is about politics. It's not about logic. It's about deep beliefs, and there are two sides. One side is whatever the industry is doing is absolutely madness, and our side is that we have developed product that can actually help people away from smoking. This was the mission of our company. We divested our cigarette business in 1999, so we got rid of the combustibles. We had a bit of cigars on the side, but our aim was to catch that piece of the market, to get the consumers that are smoking. But we weren't allowed to do that because we were stopped. We could do it in Sweden, but we were stopped from our wider home market, which is the European Union. there are as I said, there's a lot of data, but it doesn't matter because the ban remained. It remained in 2001, it remained in 2014, and it still remains. And I've sometimes heard people saying that, well, we don't want snus because people are not going to use it anyway, so why should we put a new product on the market? But if people wouldn't like it, it wouldn't be a problem. But if even 2 or 5 or 10 or 1,000 people would use it that are smoking currently, that's a public health gain. So going to pouches and what we're seeing, and I think this is not only about pouches, it's about the political debate that's coming in Europe. And I'm going to read you a couple of quotes from the almighty administration, the European Commission. Quotes or paraphrasing. So there are no safe levels of nicotine, which is a response from the Commission, Commission on a parliamentary question. I think that the Commission's risk assessment management people would take offense. I guess you take offense also if you're an Oration, because I mean there are safe levels of nicotine. But this is an illustration of where the debate is going. The popcorn lung, the sort of suggestion in a debate that, well, we have all seen the media on vaping and popcorn lungs. That's something we don't want to have. I mean, what is this? This is like the guardian representatives of the institution gardening the treaties, and with all principles in there, stating stuff which is far from true. Popcorn lungs and vapes. Vaping kills, another excellent statement from the Commissioner for Taxation. Vaping kills in relation to what? It's those kind of bland overarching statements which doesn't put things in context. And you have to put, politics and decision making is all about compromising. It's all about finding a good solution. You have to compromise. But I think it's extraordinary how you see the narrative going from the Commission, and it's underpinned by the tobacco control organizations. And I think it's a stupefying debate. Another one is, that I read in a paper, attraction of reduced risk products stems from the fact that they are perceived as less harmful. Perceived. I think we can, from a tox point of view, from a risk assessment point of view, I don't think it's a perception, I think it's a fact. Apparently, we are targeting children. Anyone who believes that we are targeting children, I can invite you to a compliance training with PMI. This is also an interesting one, which is no study has shown that less harmful products are better for cessation than current available methods. I think we have an interesting case study in Sweden with what less harmful products results in. And yeah, it's a gateway to smoking for young people, the gateway. The gateway has been around. I have not seen any interesting evidence that gateway from reduced risk to combustion exists, but maybe there is. What we have seen is that there is a gateway out of smoking. All in all, we should remember that it could have been much worse. Had the Commission gotten what they wanted in 2012 when they released the draft directive, there wouldn't have been, and the member states and parliament had voted in favor, vaping would have been not a consumer product. Vaping wouldn't have been available. I think if you look at the narrative, they will go after, they want to equalize, is our sense. They want to equalize reduced risk products because they're equally bad. And that's what's coming. I will stop there.
Okay, well, consider you ended there talking about the EU. I have got a question about the EU. I mean, I've seen the plans that the EU's got. Will there be a credible opposition from MEPs at the EU level? Or, and I was involved in protesting against some of the wild things they were going to do at the 2012 TPD 2, wasn't it? Is there going to be some opposition at EU level, do you think, to these plans that the EU has?
I think there are people in the European Parliament who sees the potential with the pragmatic regulation around reduced risk products. It's not like it should be like free for all and we should have whatever 50 milligrams nicotine. I mean, and this comes back to the importance of a proper risk assessment and the proper assessment of the products, because you want to balance from a regulatory perspective. You want to balance the availability of the products for the smokers that wants to continue using nicotine so they can switch. But there's also a public health element. So you need regulation to protect kids, groups that shouldn't use nicotine, etc., etc. So there are people being pragmatic. What I'm afraid of is that you will have this sort of increasing moral panic on kids and adolescent brain, and it's so easy that sticks. In Denmark, there was a moral panic because apparently Danish dogs consume nicotine pouches, which is not the case with Swedish dogs. And then you get more. So, and if you're a policymaker, you want to have a rational approach. So I do believe that there are people in the European Parliament, and we will see. But you remember from last TPD as well, it was pragmatism versus, because on the member state side, it's quite clear that we have some member states that have already regulated it because they want to protect public health, but they also feel that these products should be available. Sweden is such an example, but there are a couple of other member states that have pragmatic regulation, and then you go have the countries going for a ban. The Spanish ban, the French draft ban is interesting. It's apparently it will be banned to possess and use nicotine pouches, and good luck enforcing that when you have like thousands and thousands of Swedes going to the Alps every year for skiing. Luxembourg has put this they're proposing to regulate the product as a tobacco product, which is good. I mean, because then you get the advertising and you get some measures. And then they're putting this limit of 0.048 milligrams per pouch, and that's like nothing. And that's based on a risk assessment from 2009 that the European Food Agency did to establish how much nicotine you should be allowed as a pesticide residue in mushrooms. But we're not talking about the fact that people smoke like there's no tomorrow in Luxembourg. That kind of nicotine we don't talk about, but they choose to go for this one. And as Anna said, if you look at the toxic profile, it's just ridiculous. Why don't they ban cigarettes?
Okay, thanks. I want to ask a question because it's something no one's mentioned. Policymakers and politicians will all talk about these products: vaping, heated tobacco, pouches snus, and they'll talk about the fact they're addictive. So I think you, Mark, do you want to explain that? How do you counter those messages from government that, yeah, okay, these are less harmful, but they're addictive?
Well, the purest way of doing it, and how many people I know here have spoken about, is that dependence and addiction are two different things. And dependence is continuous use, a requirement to use it, but it doesn't come with harm, which is what we're really looking at with these products. And addiction is the dependence with the harm. Now, when I say that, I think, is that too complicated for politicians to understand? Perhaps, but we've got to try. And when I speak to politicians and I speak to the public, getting that point around what the aim is here is to reduce the harm caused, not a dependence on a product. The dependence issue is really you're going to use a product for a long period of your life. Okay, a product that I personally feel brings me a lot. My wife loves her coffee, and I know you've spoken about this, Martin. She probably has a dependence on a caffeine. But I don't do a huge amount of caffeine. I spend my time consuming nicotine, and I find my concentration's better. There are benefits to it. Working. I mean, we know that nicotine can give a performance-enhancing improvement when it comes to cardiovascular performance. So on the World Anti-Doping Agency list, nicotine's there because it can give about 10.4% increase in cardiovascular performance. We know that athletes are consuming it. That's not a problem. They're consuming caffeine and other products to improve performance. So I think trying to get the message home to politicians that it's the harm that matters, not continuous use of a product. Because where do we go? If they focus on continuous use and dependence, then the next step is dependence on caffeine. You know, that would be Starbucks banned, that would be plain packaging on that. Alcohol is a slightly different subject because dependence and addiction for that drug is in itself harming. And it's harming for the body as well as it is for being in a continuous state of drunkenness. It's each drug in itself is different, and nicotine is not something that you consume which is going to make you dangerous in any way. In fact, quite the opposite. You're going to see improved performance. So a lot of this comes, let's not forget, a lot of this comes from the newspapers who are driven by a certain billionaire, and it seems to get the attention of readers, having that word addiction in.
Yeah, I admit, as a vapor, it does irritate me when they'll conflate the two. They'll say, you know, people say that vapes are much less harmful than smoking, but they're still addictive. And addiction and harm are two separate things. Yeah, but don't talk to me about coffee. I went to the Philippines a couple of years ago, and every breakfast someone was trying to give me coffee, and I don't drink tea or coffee. And on about the third day, the guy crept up behind me to put the coffee on the table because he felt I should be drinking coffee. It's fine for him to force that on me, but you know, if I'd wanted the vape, he probably would have reacted like I'd set off a hand grenade or something. So we're talking about harm. So can I ask you, we know about the continuum of risk of different nicotine products. So we say they're less harmful, pouches are less harmful, and vape. How much less harmful would you say?
You want a number?
Well, just just try and explain as best you can.
No. So as Mark also pointed out, if you take away the chemicals that are causing the COPD, that are causing the cardiovascular effect, that are causing the cancer, then you won't have any harm in that sense left. And that's what we have in nicotine pouches. So what is left is nicotine. And if we compare to nicotine replacement therapy that I was talking about before, there has been long-term studies done, of course, because it's been around for so long time. And none of these studies could show any statistically significant effects on cardiovascular. So on this continuum of risk, I would say that nicotine pouches and NRT are exactly the same.
Actually, there is a paper that I recommend, Back at All, where we compare smokeless tobacco, our nicotine pouches and NRT, and it's actually that our nicotine pouch is slightly less, contains slightly fewer toxicants than gum, nicotine gum.
Right, okay. I want to ask you, Barnaby, because we're talking about these products, we talked about addiction, we talked about they're less harmful. What about popularity? As we spoke about USA, there's a massive growth. Is that going to be a problem in the future, or is that something we should be pleased with? Well, I suppose we should be pleased with, but is it going to be a problem in the long run?
Well, yeah, I think that's quite right. It's a double-edged sword in many ways. It's something we should be pleased by. This this take-up of a new or newly significant form of tobacco harm reduction. At the same time, it poses a problem because it clearly will bring nicotine pouches much more to the attention of people who are opposed to THR for one reason or another. Now, I mean, and this kind of ties in very much with the points that have been made about addiction and dependency. So, you know, if we look at it logically, dependency is only a problem if you have large numbers of nicotine-naive users coming in and if you then have a gateway to combustibles. And as far as we can see, we have neither. I mean, for example, we did a survey of pouch users in the United States. We found about half were coming to pouch straight from smoking. Only 5%, 1 in 20, were nicotine-naive. The rest were coming from various combinations of smoking, vaping, other oral products, and so on. However, that is not necessarily the perception. I think the perception of pouch very much is driven by its online presence, particularly its presence among influencers. The so-called Zinfluencers are very big here. And of course, there is also the issue of big tobacco involvement. Again, it's a sector that is relatively dominated by the big tobacco companies. So those are, if you like, issues that we may have to confront with pouch. We're also seeing, you know, some signs of concern about pouch usage among minors. There was a University of Southern California study recently suggesting that high school usage had doubled over the year 23 to 24. Now, this was only doubling to about 4%, far less than vape. And of course, most people in this room will know that's against the background of a massive reduction in high school smoking over recent years. So, you know, we might say nothing to be concerned about. But these kind of numbers are very much the numbers that will be, you know, that can and will be used against pouch. I think said against that, on the positive side, in the US, for example, you know, there is the precedent set by FDA approval and then potentially, you know, the FDA modified risk authorization coming up. In Europe, you know, there's certainly, although there are certainly countries where there's a strong anti-pouch sentiment, there are others where there is a, you know, there is much stronger pro. And of course, we have the, you know, if you like, the classic success story right on our doorstep in the form of Sweden, as alluded to. I think if I can just go back to the question of addiction for 1 second as well. I mean, just one other point to make there is, you know, quite appropriate to mention this at a harm reduction conference, because I know a lot of people at this conference over the years have come from the drug harm reduction background. There is an antipathy toward addiction in general. I mean, when I was growing up in the 1970s, and I'm sure many of people in this room will recognize this, to say, oh, you know, if you do that, if you don't brush your teeth or whatever, my son, you'll grow up to be a drug addict. You know, that was pretty much the worst fate imaginable. You know, much better you should be a serial killer or something like that. And so, you know, those sort of perceptions of addiction in itself being an absolute terrible disaster that we must at all costs protect society from, you know, is still, I think, very dominant in a lot of public health thinking. Now, that there is some validity to that, to be sure. But it can certainly overshadow any perception of the benefits. And I think that's, you know, one of the issues we have coming up here with the issues about addiction and dependency that you talked about.
Okay, that's great. Yeah, that's a great answer. Thanks very much. I want to talk finally about, we'll come to the audience soon, and that includes people, because this is being live streamed, so I think there's a facility you can put your questions at home as well. But I want to talk about regulatory things to do with the World Health Organization. I mean, they've recently come out and said that all flavors of every nicotine product should be banned. They say that pouches should be banned worldwide. Will we ever be able to persuade the WHO to come out with more sympathetic policies, do you think? And what threats are we going to see maybe in November at the next WHO COP meeting? Do you want to start on that one?
I don't know, to be honest, and I'm not following WHO that closely. I believe that if we can demonstrate, if people are actually switching from combustibles to reduced risk products, whether it's pouches or snus or whatever, then those products has a role to play in public health. We have good examples from Sweden and Norway with snus. I think UK is a good example when it comes to vapes. Had the UK government at that point been successful in persuading the medicinal world to take over vapes, we wouldn't have had the 3 million plus ex-smokers that we have today. So for me, this is a bit of power to the people. I think if I look at the European Commission, the WHO, Europe, and sort of their thinking at the moment, I think it's going to be tough. But it's really, if smokers are going for less harmful products because they want to take control, then we will be successful as an industry. If they don't, we will not.
Yeah, but there's a question here from people at home on that subject. Why does the harm reduction clause in WHO FCTC get ignored, especially when the WHO and UN recognise harm reduction in other drug use? Does someone want to take that one?
I think it's the fact that, I mean, harm reduction is a rational policy. But I think that the issue here is the industry, that it's easy to, being an industry representative myself, I think it's fascinating that people tend to not want to engage on substance. They are looking, they're like, oh, we don't want to talk to industry because they are like the most evil thing you can think of. But no one ever addresses the substance. And I think that's the problem.
I should explain, people will probably know this, but Article 1D of the preamble to the FCTC Treaty does talk about harm reduction being one of the methods that you can use to help reduce people smoking tobacco. And it seems to be routinely ignored, unfortunately. I think we've got 15 minutes left. Have we got any questions from the audience? Yes, one from Richard down there.
Yeah, so in the UK we are seeing some, I think, positive moves in terms of legislation around nicotine pouches, particularly the 18+ age gate that will hopefully shortly be introduced. Is there any other positive news from around the world to contrast some of the doom and gloom we've unfortunately heard?
You're probably the best person to answer this, Barnaby. By the way, that's Richard Crosby from Considerate Pouches. I should have said, when people stand up and ask a question, can they say who they are?
Yeah, I don't think there's a great avalanche of positive news in the sense of lots of countries rushing to reverse bans on nicotine pouches. Let's put it that way. There are still a lot of opportunities of positive news, I think. France, for example, would be a very, very good example where, as I think I mentioned earlier, there's an official proposal to ban pouches. There are 3 counter proposals to regulate them in various ways. I think within the EU and the next incarnation of the Tobacco Products Directive and the Tobacco Excise Directive and so on, there is still quite a lot to play for. I think there's been an assumption that the position will be very, very negative on pouch. However, as we saw in the past, with vape in the TPD, there is a certain pattern that the Commission proposes very stringent regulation, the Parliament then moderates that. Elsewhere in the world, I mean, we have countries where bans are quite entrenched. Brazil would be an example. I don't necessarily see anything like that being reversed very soon. But the position in the United States is the other good news. Yes, it is a country where pouch is certainly vulnerable to public health criticism. It's a country where I think we could see municipal or state level action against pouches, as we did with vape. But on a federal level, pouches, if anything, so far probably more accepted than vape. And, insofar as you're going to argue the Trump administration has any position at all on specific nicotine products, it's probably quite pro-pouch. So yeah, there are glimmers of good or at least not bad news, but I wouldn't say there's anything to throw a party about just yet.
Okay, thanks. There's a gentleman over there, if you could have a microphone.
George Castlesmith, Tobacco Technology, United States of America. Barnaby, in the beginning, and first of all, I love e-cigarette intelligence. It's great data. You were starting in your preamble, and you said the rise of the naive in the market of nicotine pouches in the United States. And I think words matter. And right now we see approximately 65% of the global consumption of nicotine pouches occurring in the United States. and we see a precipitous drop in the conversion of cigarette smokers to these safer nicotine products. How naive is the US consumer, and how is this rise occurring? Because I would say that we've already lumped globally the consumption of hookah and pan masala, which is a very deadly cocktail, into the oral category to make it seem as if it's more dangerous than it really is in the moist snuff and the snus categories. But these consumers are changing because the government tells them that this is just as deadly and as deadly a form of nicotine as any other. But they're not naive. They know this. They know that's not true. And that's where they're growing. They might be younger, but how naive are they?
Thanks. Well, yeah, just to put some numbers on it, I mean, when we did our US survey, for example, recently, we found that, in fact, only to address one form of naivety, which is nicotine naivety, people who have not used nicotine before, we found that only 5% of pouch users, as I said, were nicotine naive. All others had used nicotine in other forms. What's kind of interesting, though, in that context as well, I think, is the reasons that people adopted pouch use. And health was generally not a big reason there. It was around 20% of users had been driven to pouch primarily for health reasons. Now, that doesn't mean the other 80% were unaware of the health factors. They may well have been, you know, there in their mind. But social influence and curiosity, social influence, no doubt tying in with social media as well, were really the dominant reasons that people moved to pouch. So, yeah, I think it's probably safe to say that the movement toward pouch is perhaps a little more trend-led, a little more media-led than, you know, a health-led move toward vape would be. However, that's not to say that this is dominant by any means. You know, and in a sense, if the risk profile is sufficiently low, as long as you're not bringing in large numbers of nicotine-naive users, you might say, well, who cares why they start? The good thing is that they do start.
Okay, we can have one from Jeannie here, but I'll answer one of the questions on the Q&A from home from Kurt Yo, who is a consumer advocate from South Africa. He says, if the WHO FCTC is politically driven, why have we not seen the likes of Sweden, UK and New Zealand insist on more robust conversations on tobacco harm reduction? And I can actually answer this one because Clive Bates mentioned this recently in something he spoke about, where he said that these treaties tend to be countries go along and they have a red line. And as long as someone doesn't cross that red line and start infringing on their own policies, they're not going to say anything. They're not going to stand up and say, we love harm reduction. So I think that's why these things don't happen. At those international treaties, the UK especially will just sit there and defend its own policies. And so it's not going to actually come out and push itself out and make a fuss. So I think that's the answer to that question. Jeannie, have you got a microphone?
Thank you. I think my question was very similar to that last question. I was going to say, given that Sweden is the only country the WHO deems to be smoke-free, and the position of the Swedish government, what more can be done for the Swedish government to actually stand up and talk about its position, maybe at COP11, or, you know, what's holding the Swedish government back from doing that? I know for many years it has not said anything. And given the derogation that it has in the EU and why it fought for that at that time, is it not willing to share its experience more broadly and bring other countries along at something like the COP?
Thank you. It's of course political as always, and every country in the European Union wants to be I mean, we're a team playing, and we respect international law. And I think what we've seen so far have been worked on the last TPD. The Swedish government looked at this ban on snus from a trade perspective, because there were discussions within the government, and my sense was that the public health, they didn't want to push the public health agenda. And I think that's also because the country is committed to the WHO. Generally, they're committed to the framework agreement for good reasons, because smoking is a massive problem. So, but I think what has shifted with the Swedish the detailed opinions to Spain and to France is that besides the trade argumentation, they're actually engaging on stuff substantially on health, where they're actually making the point that the fact that there has been an alternative product on the Swedish market has resulted in public health gains. And that's something new. I guess this might be addressed when the EU negotiates its mandate for the next COP. But then there's also, as I'm sure you're aware, that the health part of the government has one view, whereas and then you might have a conflicting view from other parts of the government. So that's also in play there.
Can we have John in the third row?
Hi, it's John Fell from London. Question for the panel. In this phase where pouches, or regulation of pouches, is still undeveloped, it's a bit of a wild west, do you think industry, and I mean that in a big, small, retailers as well, is industry doing enough to shape pouches being perceived positively by the wider public and shape regulation? Is there a role for self-regulation?
Oh, do you want to tackle that one?
I mean, there's very little opportunities, I think, for industry because of the lack of the ability to get engaged with politics. But the modified risk point over in America, I mean, what can go on there is fantastic. And obviously Zinn is going for that, and they've done it with heat not burn as well. So that should be the target, I think, trying to get the FDA, modified risk. We don't have, as far as I'm aware, a system like that in Europe or the UK. But yeah, strangely, you know, America has been such a success. Culturally, you know, Zinn has become part of the lexicon, and it's taken a political position. And so there's an irony in that you could spend all your time thinking very strategically and thinking very scientifically and about public health, but sometimes something just sets off in a country and it becomes a subculture. And I've really noticed that in the UK. Nicotine pouches are a bit of a subculture. I used to go to the pub, pull out my nicotine pouches about 5, 6, 7 years ago, or snus, and my friends would be saying, why have you brought your hair gel to the pub? But now everyone knows what they are. And the military is a really fascinating small subculture. And in America, it's massive. And I know of British Army units that have gone out to train in America. And, you know, there's a high smoking rate in the military. People don't really think about their existence in 35, 40 years' time. And those smokers have come back using nicotine pouches. And it's really taken off in the British military because of those links. So you could say NATO's done more for harm reduction than the World Health Organization. Yeah.
I knew you'd get NATO in there somewhere. I really did.
I just wanted to add that I think that what we are seeing now with new startups, new small companies, new innovations, that is important to drive this even further and making this category more credible. And I think that's important.
Can I just, on what the industry has done something, there is a technical specification in Sweden and there is a standard in the UK, and those were developed in anticipation of regulation, and it looks at maximum nicotine, like quality stuff that you need to think through during manufacturing, limits or bans on unwanted substances. There is also a discussion within ISO, because all the industry colleagues I'm speaking to, we all recognize that there's the lawmakers are running behind. But if you look at European countries, there are quite a number which have pragmatic regulations. So you have the Scandinavian countries, you have Finland, Romania, Greece, Czech Republic, Slovakia. So I think you have quite a lot of countries. And then there are still a number of countries which regulate it as, or they view it as a consumer product, and that is a problem because then you don't get the age gating, then you don't get the marketing restriction, etc., etc. So we can do more, but we have done something at least.
I'll just quickly ask the last question. Skip Murray there from America. She's asking, are there any studies following individuals who use NRTs for an extended period?
Yes, so there are a lot of studies on NRT, and they haven't shown any connection specifically to, I mean, because the cardiovascular effects has been the talk about nicotine, but those long-term studies haven't shown any effects on the cardiovascular system. So that I think is very important to state.
Okay, we're just coming to the end, so I'm just going to ask one last question to the panel. I would like you all to answer in about a minute or less, if you could. So I'll ask everyone, are nicotine pouches here to stay? That's it.
Yes.
A real mic drop moment, that one. Absolutely, yeah. Yeah, with all these attacks and regulatory bans that we're seeing, are these things here to stay long term?
Yes, yes, of course. I mean, I don't think that if you're looking at the harm reduction, the risk management, the toxicology, the science, we don't have a choice. I mean, why should we ban nicotine pouches and not cigarettes? I don't know.
That's the question, isn't it? Barnaby?
At the risk of being predictable, I'd also say yes. And I point for comparison to the vape market. You know, terrific regulatory headwinds against vape, terrific level of negative opinion that hasn't actually stopped the market itself and the use of vape from, just going up and up and up. I see no, unless some completely unexpected development comes out of left field, I see no reason that shouldn't happen with pouch as well.
Nicotine pouches are going to save a lot of lives globally. The question is how many? And that really is the gift of politicians on how they regulate it. And I'm hopeful, and this comes a little bit back to the World Health Organization FCTC question. Politicians love legacy. If you do any work with a politician, they're thinking about legacy. And it just takes a politician to realize their legacy could be saving millions of lives globally. And maybe attend the COP process. They do it with the environment. If one politician really realized how much impact they can have globally on this subject, it could do an enormous good.
I think you said before, haven't you, that someone from the UK should invite COP to London and get the Minister of Health to talk about harm reduction, which would be a wonderful thing, wouldn't it? Talking during Jeannie's panel about how it would take one country to do that, but that's something I suppose we can only dream of. But we're just coming to the end here. We've got seconds left, so could everyone just please thank my team, the panel, Cecilia, Anna, Barnaby, and Mark, for some great responses. And thanks very much for coming.
Hi everyone, it's Paddy Costall from Global Forum on Nicotine. I'm here with a couple of guests for the final commentary team of the day. It's been a very long day and I hope it's been very useful for everybody who's been involved. And I'd like to introduce the two guests. I've got Dorrie Heemskirk and David Williams, and they're going to be asked a series of questions about the conference and the themes and what's good and what's not good. We've got about 30 minutes, so I'll start by asking Dorrie to tell you a little bit about herself and perspective that she's coming from and what have been the highlights for the first day.
Okay, great. Thank you. And where I come from, I support the trade association, the Dutch Trade Association for e-cigarettes in the Netherlands. And we have been facing a lot of headwind with regard to e-cigarettes. So there's a lot of restrictions, which is not really helpful, I guess, for consumers. Mm-hmm. So we've seen a very significant drop in sales, but people didn't change their behavior. So what they did, they had to find their products somewhere else, so they go abroad or they buy it from the back market. So that's a bit the situation where I'm coming from. And it's a very hostile environment for safer products, alternatives for nicotine, smoking. So what I experience here is very pleasant because it's all talking to people that understand
not a hostile environment.
Not a hostile environment. No, that's right. No. So that has really been interesting, and also the starting session with Mark Tyndall, coming from the drugs area and harm reduction in that field, and the idea that what he said is in tobacco it's so different. Yeah. So that was really an eye-opener, I guess, to see that. And there's no answer yet. So why is that? So that's interesting.
David, I know it's your second visit to the wonderful city of Warsaw, and obviously the background that you have is in a regulatory mess, shall we say, at the moment in the United States. Yeah. And I just wonder what your initial thoughts on the day here and what may be needed in addition.
So, Paddy, first of all, thank you for putting this together, bringing folks together to talk about this. And I was mentioning to someone the other day that I've been looking at this issue for the past 10 or 15 years. That's not really accurate, because in the mid-1970s, my father smoked 3.5 packs of cigarettes a day. He would load us in the car, roll up the windows, and the car would be filled with smoke. And I didn't realize then what I'd be doing now. And looking back at the mid-70s, I wish these products were available to my father. And this is one of the reasons why we're involved in this issue. It's a taxpayer issue, it's a consumer issue. And to see the innovation that has happened, I mean, obviously since the 1970s, but just in the last 10 or 15 years, has been incredible. And I think today really put a stamp on that. Is we heard from Mark Tyndall, and his progression of harm reduction, talking about HIV, then talking about drugs and needle exchange and free needles, and now to tobacco harm reduction. There's a progression here, and that's why it's so important, because this is a health issue. It's a taxation issue, it's a health issue. And then the last panel with Martin Cullup talking about pouches. And my takeaway from that and today has been, you look at governments, they are stagnant. Bureaucracies are stagnant. People are not. People are looking for ways to quit smoking. They've done it with vapes, they've done it with pouches, they've done it with heated tobacco. My goodness, look at Japan, the revolution of heated tobacco in Japan and how it's changing their lifestyles and their health. And this is all about, it's also about taxpayer money. It's because these people, when you improve your health, you're not as much of a burden on the state. But the private sector, the free market, they are innovating. Governments don't innovate. And governments don't listen to the private sector. And we see that with the World Health Organization and how they've ignored these technologies. Yet people are doing this anyway. And the explosion of pouches in the United States has been amazing. I mean, dollar-wise, the amount of people using pouches. And this is only a good thing for people, the more that we can bring these products to market and really and market them. I think that's part of the problem is a lot of these products can't be marketed. We should be able to market these products.
I think people always think about the Netherlands as a kind of hippie, liberal society. Anyone who's been there, I think, would probably dispute that. But it's actually quite interesting that it's probably now moving towards being the most harshly regulated market.
Absolutely.
In the entire, certainly within the EU and probably within Europe generally.
Yeah, that's right.
How's that happened?
Well, I guess it started with a political stream that was more from the Christian party, so trying to avoid people to use any substance, I guess. So they were in position for 8 years, long years. So they have initiated changes. Yeah. And of course, there was a good initiative broadly across the country from also big organizations. It was not only tobacco, but it was also food, etc., which was good, I guess, to try to prevent harmful products for entering the market. But they don't see the distinction between products that can actually help save people. Yeah. And what we see in statistics is that year on year on year, there's only 1/3 who's trying to seriously quit smoking. And the rest, either they are not reached or they are not willing, or they've tried and they've given up. But if that group is not reached, you will continue smoking for the next 20 years. And that's, I guess, I also heard people say it is in fact, well, they didn't use the word criminal, but in fact they say that keeping away products that can help people to get better or improve health is, of course, not a good thing.
I find it incredibly contradictory that in many countries, the United States is a good example, and most European countries, there is a massive move to legalize or at least decriminalize cannabis. And it seems to me, I might be wrong, but it seems to me that the places that are strongest on trying to legalize or decriminalize are the ones that are strongest against tobacco harm reduction.
Yeah, this is
an absurdity.
It's absurd, and this is really a fascinating sort of comparison, right? Is that they're saying people should have the freedom to use cannabis, but not the freedom to use tobacco harm reduction products. We have to go through this process in the Food and Drug Administration, the PMTA, the MRTP, this really long, laborious process that costs companies millions and some companies billions of dollars to get through this process. This should not be happening.
Or not to get through the process.
Or not to get through the process. There are millions of applications that are pending at the FDA in the United States. Yet, you're right, states are legalizing cannabis. And if we are truly about freedom, let's take it to the next level with tobacco harm reduction.
But I think this is one of the challenges that we face. I think that I'm happy that we've got the Global Forum, because I think it's the place where people come together and we can exchange views in an open and honest manner. I think that we're always looking to see what's next, because by the time we've discussed what's already happened, it's too late. Now, what would you say would be some of the topics that we might need to look at going forward? What are going to be the key areas that we need to look at?
Well, I think you've started it with this conference, is focusing on communication and media, because as a group, we have been pretty insular. We're talking to each other, a lot. We need to talk to other people. And there are what, 1 billion people that need to be talked to about what these products are. So I think how do we talk to the media and getting this in the mainstream media? Because there are a lot of excellent media folks here, but we need to expand that to the mainstream media because people are using these products. And what I love about this is that it's nonpartisan, is that people have all different political views at this conference, but we have one singular focus, are these products. So I think that it's a non-political or apolitical issue that we can communicate. So that's what we need to do is more communication. Because I think the more people find out about these products, the more they're going to shrug their shoulders and say, why are governments preventing me from using this? Why can't I go get pouches? Why can't I get a vape? Why can't I get heated tobacco? I think that's the question they're going to ask when they hear about what's happening.
I think, I mean, as I say, it's a long haul. Yeah. Whether I'll live to see it, I don't know. But you represent a lot of people who are in the business, small retailers, small manufacturers. Is there a wear and tear element where they can just pack up and say, I don't want to do this anymore?
Well, it's already happened, I guess, because of all the restrictions, like the flavor ban, only allowing 16 ingredients. Yeah. And that meant that going from like 50 different varieties to like 12. Yeah. So that means the real vape shops, they were not able to make a living. So they either started selling tobacco products because they had the idea, at least we can still help smokers, trying to convince them to use something else. Or they just quit, and online sales was completely banned as well 6 months before, and 40% of the market was.
What's the evidence of a growing black market in?
Of course, the statistics. Of course, the statistics don't mention a lot of decrease of use. We see there is a lot of decrease of sales. What we see is then that people try it somewhere else. And our consumer organization in the Netherlands, they've done surveys and they have proof that, at least from consumers, older consumers, saying we are now buying our stuff abroad or on the black market. So that's, I guess, what we can say. And we are not prepared to quit.
But your members, and I suspect an awful lot of consumers, would not object to a proper regulatory framework.
Of course not, no.
Where the products are principally, the most important thing, safe.
Yes.
And available, and no restrictions on purchase, etc. But I think that, I mean, in the UK, we've just had this enormous mess around disposables. And, the solution of our Secretary of State for Health is we'll ban them. He's not a very bright lad, but, But it's, how do you ban it when the only people who police this are trading standards, and they've just cut the funding for trading standards by 60%. And trading standards cover everything from children's nappies to high-end electrical goods. And I don't really think that a bit of a plastic vape's really going to be that much of an important issue for them. But how can we go about establishing this proper regulatory framework? Because at the present moment, it seems to me that we've got lots of people shouting at each other from afar, and nobody wants to actually sit down and say, right, what's in them? What can we keep? What can't we keep? Who's going to police all of this? Who is the person who decides?
This is going to be tricky, Paddy, because you want a proper regulatory framework, but when the government gets involved, they always go too far. Yeah. And they will put such excessive regulations. If you really want to sell this product, you have to go through A through Z to sell a product. So yes, it's important, but they're going to take advantage of that. And then we'll have high taxation. Yeah. And so you're opening Pandora's box, but it has to be opened just a little bit so we don't, look at prohibition in the US. Mm-hmm. Did that stop drinking? No. Absolutely not.
Apparently not.
No, it did not.
No.
So there needs to be a balance here, is that government is involved, but not, too much.
That's right.
I totally agree. And that's why I say who should be the regulator, because I don't actually think it should be a government regulator. I think it should be people who are acceptable to everybody. And everyone, as far as I can see, manufacturers and distributors, all they want is a level playing field.
Yeah.
And they want a level playing field across borders, because we have that ludicrous no cross-border advertising in the EU, all that kind of stuff. And although we're no longer members of the EU, we are straight behind all of that. Everything that they do. The only thing we don't have now is a say in what goes on. But I don't know. I get confused about where the priorities lie. Where should we be targeting our resources? Considering the resources that we're up against in terms of tobacco control, we've got very little. And this is probably the most resource-intensive event in the tobacco harm reduction space. And what do we need to be doing? What's the messaging that we need to get right? Who do we need to be talking to?
Well, it's younger folks. So I'm talking about 21 and above, is the younger folks. And this is the reason why, is that this is a generational issue, is that you have people in power that are in their 60s, 70s, and 80s, and they are not using these products. They don't understand the benefits of these products. But the longer we move forward, and in Congress, in the United States, we need more people in Congress that vape. We need more people in Congress that use pouches. And the same for Europe. You need your elected officials to be using these products. So I think there is going to be a generational change. And I know it's a slow process, but it has happened over the years with cannabis. I mean, look at what the cannabis people have done over the past 20 or 30 years. They have been very patient. We need to be patient. And conferences like this need to continue to happen on a regular basis for the education.
It's good to hear that, 'cause that's what we do. I think that the big challenge for us now at the moment with this event is we don't attract the regulators. We attract very few academics, and we need those people to start. When we first started this in 2014, we had all of those people. We had Public Health England here. We had professors from universities across Europe speaking. Gradually, they've been, I think, warned off. They've been threatened, and their livelihoods have been put at stake. I'm hopeful that we might be able to start getting them back, but I'm very loath to change the composition of the conference. We have to have everybody in the room. All the actors need to be in here. You cannot ignore the elephant in the room that is industry.
Let me offer you one suggestion for potentially next year, is finding a member of Congress who vapes, is finding an MP and MEP that vapes or uses these products. Have them speak, give them a keynote speech, because that, I think, will send a message that people inside government are sympathetic to what's happening outside of government.
If you can find me one,
I will look. I will look in the States, absolutely.
That's a good
And I mean, we're open to anything. Yeah. We want to reflect the field as a whole. We want to reflect what people think in different ways. One thing that's lacking is we don't have an awful lot of people who are implacably opposed who turn up and tell us. We did invite Stanton Glantz on one occasion about 8 years ago. Still haven't had a reply. But it's kind of, we want those people here. Yeah. And I don't want them here so that they can be humiliated and abused. We want them here so that we can have the conversation. Rather than, as I say, standing on two hills opposite each other shouting slogans and abuse. No, it's not going to get us anywhere.
No, that's right. And I think that's the fact that there's a paradox because we all want the same thing, but we are opposite.
Yes.
So it doesn't really help to say, okay, trying to convince the other party to think like you. I guess we have to use like more psychology about that and say, okay, trying to bridge and trying to first understand before you can actually talk. So don't try to start convincing the other party, but first listen. Listen to their concerns, genuinely listen. And I think that's lacking more and more, because every party is like getting confirmation bias, and so they're digging in deeper, deeper, deeper. And that will not help. And ultimately, we want the same thing.
And I love that idea, Paddy, is to have a discussion and to have opposite sides, because as you said, we're trying to accomplish the same thing, that Michael Bloomberg is trying to get people to stop smoking. So are we.
Yeah.
We just have two different ways of doing this. Bloomberg wants to tax the heck out of things and make them these products not available. We have a different tactic. So why not bring the two groups together and talk about this?
I think,
absolutely,
you know, the theme for this event around effective communication and honesty in communication is a very, very key issue. I hope we've had an awful lot of people register for media passes for this event, and I just hope they turn up and they listen. And if they don't like it, they can say they don't like it, but tackle us on the evidence, the science, not the moral issues.
And the experience of the users.
And yes, I mean, I have to say one of the things we're proudest of is that the central feature of the Global Forum is that we build it around consumer experience. Because without them, none of this discussion takes place. But it's really, it's a very important message to the media. Just please, let's have this conversation. Don't just go away with an idea that that was wrong. Ask me why it was wrong. We're open, we'll talk to anybody, and we want to be, we want to be open house. We want to have open discussion and dialogue. And it's a plea really to people, please come and talk to us.
Yeah, and just for some background here, the Taxpayers Protection Alliance, we didn't get involved in GFN until last year. And I can't imagine not being here every year, because we're talking about policy and policymakers and regulation. And you know, we want to expand that. So there's other groups in the United States, policy, taxation, regulation groups that we want to bring into the fold to talk about that aspect of this, because it's a reality. In the Netherlands, you have to worry about regulation and how it's closing businesses. So we need to talk more about how the government is controlling and keeping these products off the market.
So, I mean, kind of summing it up really, we've got the whole issue about how do we regulate, who regulates. We've got the issue about how do we communicate risk, and how do we actually solve this problem where people will not speak to one another. And it is as simple as that, really. I can't come into the room because he's in there or she's in there. It's a bit like having a party and people want to see the guest list.
Yeah,
it's just not going to work.
Yeah,
I can't see it being a runner.
And social media doesn't help. I mean, you have people go on social media trying to be the biggest flame and trying to, you know, make the biggest point. It's like, let's tone it down.
Yeah.
Let's bring people into a room and have an intellectual discussion about this.
Yeah, that's a good.
I mean, there's always the concept of Chatham House, and we would be perfectly happy to host any kind of Chatham House style event where people would come and be open and honest with each other. And that would be something to see. But I know we're probably running a little short of time now, but I just want to get your thoughts on the rest of the time that we've got here and some of the things that are coming up and what you're actually looking forward to most.
Well, I guess for me, when you look at Europe, of course, there's this TBD coming on. So trying to see what we can do in that field. And if there are other people thinking about the same. And of course, I already met people, and everybody's looking at how to bring across and educate the members of parliament, of course. So that will be one. And also practical, like, okay, they say, okay, nicotine is bad. So trying to learn things like, okay, what is it exactly? And talking to scientists here as well, and of course consumers. So yeah, more like practical things that I can use.
I'm looking to meet more people. I mean, this is the first time that we've spoken, and it's great to meet you. But also looking forward to the FCTC in November. Because what happened in Panama with their COP meeting was not good for the World Health Organization. And I want, countries like St. Kitts and Nevis, they were very outspoken against the WHO in 2024. And I want to make sure that they know that there are other people out there that support them. And I want a big country, like I want, a significant country to say, St. Kitts and Nevis, we agree with you and we're going to help you in November, because there needs to be more transparency and countries need to be more outspoken to retain their sovereignty when it comes to these products.
We've covered to an extent in the conference agenda, we've covered to an extent FCTC. We could have majored on it. And the reason that we chose not to was because you just get sidetracked then into a kind of a mindset that they're all bad, it's all terrible, and we can't do anything. I know it's possible to have an impact there. I know you did in Panama, and I know you did because they got annoyed about you.
Yeah.
And that's when you know you're achieving something, when you piss somebody off and they get very annoyed. I've got a history of it. And I think that COP is an important thing, but I also don't think that we should get hung up on what goes on there, because what goes on there is going to happen anyway. And what we need to be saying is there is an alternative. And we need to pursue that with vigor, particularly in places where the most absurd things are happening.
Yeah.
And, as I say, Netherlands has got that kind of, people think of the Netherlands in a certain way, and then people who live there tell you what it's really like.
Yeah, no, that's right.
But, the liberal society isn't quite what one imagined.
Yeah. And also there's no, memory of history. So now our government just, of course, pulled the plug. So we get new elections, there are new people coming in, of course. So what we did in 2020, of course, all those people are gone. We try to educate them, of course, and we had talks, but they are no longer there. So we have to start all over again and try to get the experience of consumers across and how it can actually help.
And listen to the consumers.
We
want the elected officials and the bureaucrats to listen to the consumers.
Yeah.
The success stories. We celebrate people when they quit drinking.
Yeah.
We should celebrate people that are switching from combustible cigarettes to pouches or vaping or whatever it is. We need to celebrate those people.
Absolutely. Yeah.
I think when we spoke earlier, we were talking about, cultural icons, and you mentioned Magic Johnson and his recovery from a life-threatening illness. And we've got people, we see them in the newspapers, we see them holding a vape at the Oscars, we see them, we have an England footballer who's using snus. Oh, terrible. And we see these people, but they need to be more vocal. And I think that's where I think we should put some effort in, is actually recruiting some high-profile individuals to give us a real lift.
Absolutely. And I don't know if you just saw, but now there's a twice-a-year shot that you can take to help with AIDS and HIV. And no one's questioning that.
No.
And no one questions the advancements in the other areas of science, yet they stop with cigarettes. I don't know why their minds shut down when it comes to
that's right.
the smoking cessation.
I've just been told by my controller, because I am controlled, we have about a minute left. Okay. So if you've got any final thoughts you'd like to express them quickly.
Well, Mark Tyndall said we're on the right side of history, and I think that's a good thing, because we are.
There's a bright future. And I think that with these products, we're going to see a brighter future for people around the world. And it's really dependent upon the area of the world, whether it's pouches, whether it's Japan and heated, but the products are there. And we have an opportunity to really save a lot of lives, as Mark Tyndall has said, that we can save a lot of lives now.
It's always nice to end something on a positive note. And I hope that positive note continues throughout the rest of the proceedings here. I'd just like to say a big thank you to David and Dori for taking part today. And now I hope we can neatly segue to my colleague Clive Bates in the main auditorium to begin the Michael Russell Oration. Thank you very much, and please keep watching. Thank you.
Please take a seat. We are all that stands between you and the party at the moment, so think of it that way. Okay, I'm Clive Bates. It's my great pleasure and privilege to introduce Ariel Celia for this year's Michael Russell Oration. I'm going to take the liberty to say a few kind of fanboy remarks about Ariel, who is, in my view, one of the best, if not the best, scientist in this field, one of the nicest people, one of the most energetic people in this field. I don't know whether it's a pleasure, a privilege, or a punishment, but Ariel and I collaborate weekly on producing a review of all the papers that have come out in PubMed. We get them on Friday afternoon. I send them over to Ariel. She chooses the ones that she wants. Thankfully, she chooses all the difficult ones and writes absolutely brilliant reviews of all of them. If you don't get this publication, you're missing out, not on what I say, but on what she says, which is the most educational content you can get in tobacco harm reduction. Just by way of introduction, she is an awesome scientist, and total respect. First degree in physics, a PhD in neuroscience, and a postgraduate fellowship in psychology. Now, if that's not intimidating enough, I don't know what is. She spent 10 years in academia, got in with the wrong sort, doing sort of tobacco control research, and was very much, and I think you'll probably say something about this experience, but very much in the tobacco control zeitgeist of finding harm reduction a problem and, working on proving there was a gateway effect. And then science happened, and she found results that were contrary to the dominant narrative in tobacco control. And instead of working out how to do something else or to change her mind or to polish the results, she followed the science. She's not only a full-time scientist, but a full-time mum. Is that right? Full-time or more than full-time? Full-time mum. One son, Obi, a chess prodigy. The other, Dorian, an electrical genius, I am told already. So she's rearing the next generation of intimidating geniuses. She lives like a kind of warrior from ancient Sparta, eating a sort of ketogenic diet, 1 meal per day, fasting regularly, and probably slaying demons with a two-handed sword, for all I know, but that's not actually in the notes. She's a taste for the weird and loves fantasy science fiction. I would say she's just a great person to pass time with, really interesting, really funny, really clever. We are here to honor Michael Russell. I knew Michael Russell reasonably well. He died, unfortunately, in 2009. But I can tell you this. If he had met Ariel Celia, she would have been one of his favorite students, one of his favorite academics. This approach to science and this attitude questioning, of relentless curiosity, of a drive to understand science as it is and how it can help people. That is very much Michael Russell, and he would have been, you know, dying to have her in his team when he was sort of a famous professor. So I think it's great. I think we're really lucky to have Arielle here to commemorate both Michael Russell and to give us her own insights into her academic experience. So, ladies and gentlemen, put your hands together. I'd like to give you Arielle Seller for the Michael Russell Oration.
Thank you so much, Clive, for that introduction. And I'm not sure if Clive remembers this, but you were also kind of instrumental, just as I was on the cusp of discovering tobacco harm reduction. You reviewed one of my papers in addiction and gave me the idea of exit gateway. And I was like, wow. So you were very instrumental too. And thank you to the GFN team for inviting me to this. I'm very honored to be here giving the Michael Russell Oration. Thank you. Okay, so I've got my slide deck ready to go through. Thank you. So my talk is on the state of the academic research. As Clive mentioned, I'm a voracious consumer and try to produce it as well when I can. And I'll be talking about flaws in the existing research, incentive structures that led to the current state of affairs, and opportunities for moving forward. By way of disclosures, Clive mentioned this, but I'm an employee of Pinney Associates. We consult for Juul, and in the recent past consulted to PMI. I also consult with Ricardo Pelosa at COIHAR, which accepted Global Action funding. But this presentation is entirely my own and mainly draws from my time in academia. 3 overall parts to my talk. First, I'll briefly cover the state of the academic research. I could go on about this and fill the entire time just on this, but I won't. I want to focus mainly on number 2, how did it get this way in terms of incentive structures in research. And I'll wrap up with how we can improve things. On the state of the academic research, tobacco harm reduction research is, as you guys know, a highly polarized field. By number, the anti-THR papers currently predominate. One of the problems, however, is that so many of them suffer from fundamental flaws, and the same fundamental flaws across many different papers, week after week. And some of these flaws are not preventable, but many of them are at least mitigatable to an extent. But the research currently is not doing that. There's also a lot of hostility to industry. There's many places that I can no longer publish. And there's even criticisms that I've seen of industry-adjacent authors or authors that write papers that are cited by industry or make the same arguments used by industry. Clive and I did a really fun panel last year identifying what we thought were the 10 common flaws in THR research. We got a lot of great feedback from the audience, and we're currently trying to figure out how to write this up and publish it as a guide to evaluating the research and hopefully make it more digestible. But just to give you a sense and a reminder for those who were there last year, this is our current working list of 10 common flaws. I'm not going to go into these into detail, but briefly, things like exaggerated harms or exposures is a big problem. Number 3 is also a common problem, unfounded causal conclusions, and a related note, failure to consider alternative explanations that would produce exactly the same findings, but the authors kind of conclude one finding and don't consider the others. Number 7 is sort of related from this, inappropriate policy recommendations. Sometimes the policy recommendations assume a causal relationship, even if the authors admit that one hasn't been established. And of course, hostility to industry and the questions not being asked. So Clive's major example of this is we need to have a better understanding of why people use nicotine and what the benefits are. And my example of this is policy studies that look at only the intended effects rather than looking at offshoot or unintended effects. I'm going to go through a couple examples of recent papers and how they map onto this list of 10 flaws. And these are chosen simply because they were recent and a good example. These aren't even particularly glaring papers, but just goes to show how common some of these flaws are in run-of-the-mill research articles in this field. The first example I picked is a study of snus and nicotine pouch use among the Finnish adult population, 15 plus. The main results of this paper were that 29% of people ever used snus, 14% ever used pouches, and about 30% who used one of those products didn't know the nicotine strength of that product. The conclusions of the article were to focus concern on the fact that a lot of people don't know the strength that they're using, and they call for regulation, regulating specifically the nicotine levels and addictive potential. How does this map onto the flaws? It hits it hits half the flaws at least on this list. Number one, it ignores the continuum of harm. So current snus use was 8.4%, current pouch use was 3.7%, and all the paper's narrative is focused on this when cigarette smoking was much higher than the two of the other products combined. There's a missing counterfactual. What would people be using otherwise if they weren't using snus or pouches? Would they be using nothing, or would they be smoking? Questionable definitions. The paper reports ever use, which by the paper's own breakdown is mostly 60% tried once or twice. So this is transient experimentation that doesn't continue. In fact, current use was 25% of those two figures. It also makes inappropriate policy recommendations. So the conclusions, as I mentioned, called for regulating the nicotine content. However, both of those products were illegal at the time of the survey, and there's no reflection or consideration of how would additional regulations be expected to improve things when there's already a more severe one in place. A bonus flaw here, the use of snus is associated with the use of stronger snus. That's an illogical analysis. What's the alternative there? Not using snus is lower strength snus. So there's something going wrong in the analysis, probably with the way they handled missing data, but this should have been caught during peer review. Next recent example is on tobacco retail outlet marketing exposure. And this is using a longitudinal cohort of Texas students aged 11 to 22. Asking them whether they were exposed to tobacco retail marketing for cigarettes or e-cigarettes, and then measuring use of the corresponding product. And they found that exposure to cigarette marketing is associated with higher odds of past month smoking, similar result for e-cigarette marketing and e-cigarette use. The conclusions were that exposure to marketing increased the odds of tobacco product use for youths aging into young adulthood. And it calls for marketing restrictions to reduce tobacco use among youth and young adults. Kind of similar to the last paper, it has unfounded causal conclusions. So one of the sentences was e-cigarette marketing may be particularly influential in early adolescence. Technically, this is not claiming causality because of the word may, but it's a causal assumption, and it's the only interpretation discussed in the paper. But there's important alternative explanations. For all of these studies on self-reported marketing exposure, there's attentional bias and recall bias, which means that youth who are already using these products or are interested in using them tend to notice and remember seeing such content before. I'm going to skip ahead into 7 because the unfounded causal interpretation leads directly into the policy recommendation, which of course is for calls for increased marketing restrictions. But again, there's kind of no consideration of the current marketing environment, which is already heavily restricted for youth, and what specifically might be done differently. And it also doesn't consider harmful consequences of that, such as on adults who smoke or on risk perceptions. And again, jumping back to number 5, there's also questionable definitions here. So the definition of marketing exposure included simply visiting gas stations or convenience stores. And then this was multiplied by the actual variable for self-reported exposure. So the variable that they analyzed didn't really capture what it was supposed to. So I could go all day on that, but I won't. I want to focus more on how did it get this way. And from this, I'm going to pull on my decade in academia. Clive mentioned a lot of this history. I was a postdoc at Wesleyan University. My postdoc advisor was fantastic, and the team of collaborators I worked with were very supportive of everything I did. It was more when I made it into the junior faculty role and I was expected to carry on my own independent line of research that I got into more difficulty. My research activity throughout this time, when I started, it was on adolescent smoking behavior, and I was studying things like trajectories, development of dependence, and risk factors. When e-cigarettes came out and started becoming a big story around 2014, I initially bought the anti-THR view. I bought the idea that e-cigarettes are gateway products and they attract youth and they might lead to smoking. But I changed my mind, as Clive mentioned, with my own analysis. And I don't have time to get into that particular story, but happy to share that later at the after party. 4 to 8 publications per year, so I was always a pretty prolific publisher, but where I ran into trouble was grant applications. And a disclaimer that what follows is my own experience. I don't know if it's any better at other universities. If this might not be representative, but I feel it's important to share that these are some experiences and opinions that are out there in academia. So starting with kind of the basics, life as a tenure-track faculty member revolves around your % annual effort on paper in each of these 3 buckets: research, teaching, and service. So on paper, I was supposed to spend 50% of my time on research, 40% on teaching, and then some for service, which includes service to the university on committees and service to the profession through peer reviews and things like that. In reality, it looked much different. So I spent almost all my time when I had a joint research teaching position on teaching. So not only the courses, like teaching time during the day, course prep, grading, helping students in office hours, and then another 25% where I was supervising master's students projects. So this was very time intensive. I only, probably out of the year, if I add up all my days, there were only about 3 weeks in the early summer where I was actually able to work on publications, so that was catch-up time for getting papers ready for the year, and the rest of my research time was spent on grant applications that ended up going nowhere. And then service, as I mentioned, is split between soul-sucking committee work at the university and peer reviews. There's increasingly high expectations for faculty. So based on the % effort on paper, you're expected to meet certain quotas within each of those buckets. Teaching takes a lot more time, but it's actually less valued over research. There's really no incentive for putting in effort to better educate your students or improve your coursework. In fact, it's considered much more highly prestigious to buy your way out of teaching with research grants. In the research bucket, it's still publish or perish, but it's also now get grants or get out. Grants determine survival for academic faculty members now. I was lucky and I joined at the tail end of when grants were encouraged but not specifically required. But now in most places, I think they're required to, even for entry-level positions, to come in with grant funding that you attained from your previous institution. This was a quote from an administrator to me at one of my institutions that will be fine budget-wise as long as you faculty members keep getting 10% more in NIH funding every year. This is obviously not sustainable, and this was during a time of shrinking funding, and I'm sure administrators all over the country were telling their faculty members the same thing. And what this results in, this is a plot from NIH themselves tracking grant applications. So the tall blue bars are the applications submitted, and the smaller blue bars are the ones that are actually given out. And then the red line going across is the success rate. So obviously, as there's more applications going in and fewer grants getting awarded, the success rate goes down. This graphic says 20% as an ending value. For the type of grant I was applying for, as somebody that didn't have existing funding, it was more like 7% when I was in academia. A colleague at another institution was expected to file multiple grant applications every cycle, so at least 6 per year, and cover more than 100% of their salary. And not all grants are created equal. This gets into the issue of indirect costs. So indirect costs have recently become a political issue, but I've recognized the problems of this for 10 years now, that indirect costs are an extra % given to the university on top of the grant amount to cover overhead or operational costs. At least that's the intention. NIH grants are especially highly valued by institutions because they pay the institution's set rate for indirect costs. There's a wide range here, but it's roughly around 50% as a ballpark figure, whereas other funding agencies, such as Robert Wood Johnson, cap their indirects at 12%. And again, this is a direct quote from an administrator, that any non-NIH grants or contracts don't count towards your tenure and promotion because the university only cares about the indirects. So from the university's perspective, it's more about the financial bottom line than the quality of the research. So this kind of leads to a vicious cycle, because the more administrative pressure there is, the more faculty have to spend time and energy writing grant applications. And this creates its own ecosystem, because for every grant that's filed, there needs to be specialist staff that check everything, provide supporting documents, do the actual filing, and if a grant is awarded, they do the administration of those funds. And that raises the need for indirect costs. So I think the indirect cost issue is kind of offsetting some of the demands created by the need to apply for grants. And the reason this is all relevant to research is that NIH's high indirect rates in particular make academic research beholden to their funding priorities. They have to shape their research to fit into one of the research areas that NIH is specifically funding. How did things get so competitive with grants? This goes into a long-term side interest of mine, system dynamics, simulation modeling. This is from a colleague who was one of the people who taught me system dynamics, but he has a really informative model treating the academic workforce as a population. So instead of a birth rate, there's a PhD production rate. And the idea is that because faculty positions are kind of stagnant over time, there's not a lot of growth in faculty positions, for every academic professor, they graduate more than one PhD over the course of their career, but only one of those students can take their place. For biomedical sciences, this number is 6.3. So that leaves 5.3 PhDs on average in competing and unable to find an academic position. So academia is oversaturated, and it's been like this for some time. And there's, meanwhile, only slow growth in faculty positions. This overproduction leads to, and continuing the system dynamics thread, I'm going to show a causal loop diagram, or a kind of conceptual diagram of what I think the dynamics are here. So this is what I've just described, the circle of the academic and PhD overproduction. Anybody that fails out of, is unable to find an academic position is considered failed if they leave academia to work for industry, for example. And the other ones might get stuck as perma postdocs or low-paid research staff with not a lot of upward mobility in their career. And of course, the oversaturation of PhDs leads to competition for those limited slots. And this increases the pressure for grant funding. And this leads to, as I mentioned in the last slide, a kind of ecosystem of grant applications. And there's also, unrelated to the grant issue maybe, but there's also been a large increase in what these authors call the bullshit jobs in academia, including high-paid administrators. High-paid administrative positions have increased much faster than faculty positions. Grant applications mostly lead to wasted effort in my experience because the funding success rate is so low, but some grants are awarded, and the ones that are kind of require conformity with the funding agency priorities and views. And this is now in many places explicitly tied to hiring, promotion, and retention of faculty members. So many faculty members are kicked out after a certain number of years if they're not able to obtain NIH funding. Put a pin in this mentally. I'm going to come back to the conformity issue in a few slides, but just to follow through with some of the other offshoot effects in academia. I mentioned that successful grant awardees can buy their way out of teaching responsibilities. So that reduces their teaching load for those faculty members, but the courses still have to be taught. And this leads to a lot of outsourcing to low-paid adjunct positions. And these are very difficult jobs to have. As an adjunct, you're paid, last time I looked, was like $3,000 to $5,000 US for an entire semester of work. And if you want to do a thorough job at teaching and course prep, it can easily turn to be lower than minimum wage. Grant priorities influence publications too, because to get a successful grant for NIH, you need supporting papers to cite in the grant proposal. You need to produce new papers during the course of that grant to provide as updates to the funding agency. And it's common practice to use some of each grant to fund the pilot research for the next grant. So even when a grant is awarded, faculty members still aren't safe. They have to start immediately planning for what's the next one. And so they use some of those funds to produce publications that they can then use to ask for more money later. So all of these things create an incentive to produce a large number of, oh, did I do that? Oh, sorry, it's different on my screen up here, but I think it's okay. On the other hand, if you espouse THR, so this is a quote from a grant review that I submitted, and this was early on as a junior faculty member. I wrote what I thought was a pretty neutrally and balanced grant proposing to look at the gateway versus diversion scenarios for youth e-cigarette use. And the comment that I got back was, it would appear inadvisable to encourage a teen to smoke e-cigarettes because they're better than traditional cigarettes. I did not get the grant, obviously, but that goes to show that going against the grain can really work against you when it comes to obtaining this sort of funding. Other publication disincentives that are worth talking about is going back to the annual evaluations and faculty quotas for producing publications. This incentivizes what's called salami publishing, where you might have a lot of content that you could slice up and publish as 3 separate papers instead of one more comprehensive paper. And there's an incentive to do that because then you can check your quota off for publications. So it encourages incremental rather than revolutionary papers. From the publisher's perspective, they are mainly interested in novel findings, and so that's an incentive for researchers to overstate their findings and engage in things like p-value hacking, where they'll run a ton of analyses and only present the ones that turned out to be significant. Peer review is also fairly broken. It's a thankless, unpaid task. It takes a lot of hours and probably isn't thorough unless the peer reviewer has access to the data and has the time to try to replicate the analyses. And there's really no incentive from the university structure to do a thorough job at peer review. I was told, don't do too many peer reviews, just do enough to check off the box for your 10% effort on service. And then, of course, confirmation bias by reviewers that are invested in aligning with a certain viewpoint. So back to this slide, I highlighted the conformity issue. And in my opinion, this is the main driver of low quality and anti-THR research. So if the funding agency priorities drives that, what drives funding agency priorities? I don't know, but some speculation is that I think a lot of it is honestly naive with good intentions. And this aligns with the misperceptions of risk that there's so many sessions about in this conference. I think some people genuinely believe that e-cigarettes are harmful, and from that perspective, what they're doing makes sense to them. But there's also distrust of profit motive, especially considering the past bad behavior of the tobacco industry. I think there's also an emotional objection to recreational nicotine use. And Dr. Mike Siegel, I think, was the first to talk about this, the not invented here phenomenon, where if e-cigarettes came from the public health group, then they would be highly touted as a successful solution. But because they came outside of public health, outside of academia, and from industry, they're opposed. And this brings to mind a quote from the Dune series that I thought was relevant. Quite naturally, holders of power wish to suppress wild research. Unrestricted questing after knowledge has a long history of producing unwanted competition. The powerful want a safe line of investigations, which will develop only those products and ideas that can be controlled, and most important, that will allow the larger part of the benefits to be captured by inside investors. Unfortunately, in a random universe of relative variables, does not ensure a safe line of investigations. So I think that describes well some of the dynamics playing out here with the e-cigarette and tobacco harm reduction research being the wild line of research. Moving on to how we can improve things. Academic funding maybe is in flux, at least in the US. There's legal challenges to this, so we'll see what happens. There's obviously upsides and downsides to this. But the fact is we're potentially facing the cancellation of a large number of grants, and not only the number of grants, but the funding for indirect research costs, which previously made NIH the singular thing to attain for junior faculty members. A couple of scenarios. Pessimistically, universities could respond by pressuring their faculty even more to go after a shrinking pool of money. They could raise already sky-high tuition rates because they're used to having a certain income level and they need to recoup it from somewhere. They could rely even more on low-paid research staff and adjunct faculty, all while preserving high-paid administrator salaries. I hope that doesn't happen. So ending on a positive scenario, if there is a major change at NIH, it could force a realignment of what's considered acceptable by universities in terms of funding sources. And if there's a variety of funders available, this might reduce conformity of thought and broaden what's considered a scientifically valid line of inquiry. However, for the optimistic scenario to happen, a change needs to happen in the set of funding agencies. There are other funders of academic research, but at the moment, the major ones all have the same stance on THR. So American Cancer Society, American Lung Association, and of course, Bloomberg. So even if funding incentives change as far as the preference for NIH, the current options would not improve the state of the science. Ultimately, what we need is a range of funders with diversity of thought. I don't know what to do about this, but possibly it's a role for grants or contracts from industry. And even more optimistically, if this becomes normalized for academic researchers to start relying on grants or contracts from industry, maybe it could help the ostracization. Communication is also an opportunity going forward. So one more anecdote from academia. This is my Google Scholar profile in order of, including my papers in order from most cited to least cited. That top one there kind of has an interesting story. It's by far my highest impact paper, but it wasn't novel in academic sense. I was wanting to do a certain statistical procedure for another paper I was working on, and it was hard to find how to do that because there wasn't one source. So essentially what I did is cobble together different parts of the process from disparate sources, and my postdoc advisor encouraged me to publish it, thinking it could help other people. And she was right, but the problem was with publishing, you need some novel angle to be able to publish it, and I didn't invent anything here. So as a result, we didn't pursue a traditional journal. We went open access to Frontiers. And I was slapped on the wrist a few years later. I was told in one of my annual evaluations, this doesn't count, don't publish in Frontiers because it's predatory. Some open access journals are predatory, but there are some that are legit, and they reduce the focus on novelty, and they're more open to replication studies, negative findings, and other studies that are not as exciting, but still important for the science. So when even open access scientific journals are not considered pure enough, academia has a communication problem. But it needs to go just, oh yeah, this might be changing. I saw this recent defense of open access journals, which I agree with. But it needs to go much further beyond dialogue with other like-minded academics. And if I'm right that a lot of academics just have naive good intentions, maybe they're in a bubble like I was at one point, maybe they've just never heard of THR, then that's a good opportunity to engage in dialogue with people with different viewpoints, and maybe they just need to be exposed to different ideas. However, more communication in and of itself isn't always better. Most of you are aware of this alarmist article from earlier this year that severely over-exaggerated the risks of vaping based on a study that was not only not published, but not even complete yet. So maybe it's not more communication we need, maybe it's impact. A couple of thoughts since leaving academia are that one of the biggest challenges for me going to industry was learning how to communicate to normal people. It's almost its own language to write for academic journals, and it's hard to break out of that. And I'm still trying to improve my language and like how I can clearly explain my science using non-technical language. But I think that's a good practice that more academics should have. They need to be encouraged to communicate with people outside of academia. And I think maybe this could even cut down on some of the alarmist media coverage of research if academics are able to clearly communicate the limitations of their studies in plain language. Something that universities and journals can do is require better research practices. Encourage transparency in data and analyses, like making your data available or your analysis code. I'm a big fan of pre-registration as well, because that will cut down on things like selectively publishing only the exciting findings and p-value hacking. And also adversarial collaborations. It's good, it strengthens the science to plan a study with somebody of the opposing viewpoint and decide ahead of time what counts in one camp or the other. I'm involved in the early stages of an adversarial collaboration, and it's been informative already. Lastly, there needs to be more understanding of how someone's research affects people, and the consumer voices are invaluable. You guys have been saying nothing about us without us for a while, and in other academic fields, that's been accepted and embraced by the researchers, but tobacco research seems to be slower on the uptake with that, but I think we're making progress. So keep sharing your stories, change people's emotions, because facts don't always work. Also, for those producing science, keep publishing good science. For those consuming it, keep spreading good science. There's a quote from Arthur Schopenhauer that all truth passes through 3 stages. First, it's ridiculed. Second, it's violently opposed. And third, it's accepted as self-evident. I do see some signs, I think, that we're entering the 3rd stage of truth. So there's been some recent pro-THR papers from research groups that are historically anti-THR. And there seems to be more acceptance at academic conferences that switching to e-cigarettes is a valid harm reduction strategy. There's still some pushback and concerns about things like dual use, but I think we're making progress. Wrapping this all up, nicotine tobacco research is highly polarized. There's pervasive flaws that are somewhat preventable. And unfortunately, at the moment, anti-THR studies currently dominate. Oh, sorry. This stems from academic incentive structures, so kind of a vicious cycle of PhD overproduction leading to overcompetition with grants, and this affects faculty members' survival. If the incentives change, then the behavior can change. So opportunities going forward for researchers: keep producing strong science with best practices, collaborate, reach out to those as much as they're willing, to those with different viewpoints, and communicate outside academia. Media, there's a lot of alarmist media studies out there, or media coverage out there, obviously, but I think they need to do better at acknowledging the limitations of the underlying research they're reporting on, and not only that, but understanding the harms that they're causing by perpetuating misperceptions. And finally, for consumers, keep sharing your stories and keep pushing for inclusion into research. And I'd like to thank all these people that have been very influential in my career and continue to be. And thank you so much for your attention.
Thank you, Ariel. Brilliant. My dream of being a professor at a prestigious American university has ended here today. I don't think I'm going to be doing that. It sounds utterly awful. We have got a bit of time, I think, Jerry, is that right? I would like to just take any questions, if anyone would like to follow up. I'm going to start. I'm going to put one question. Why isn't science self-correcting? Where are the missing self-correction mechanisms? I'll come and sit next to you. Switch it on. Speak into it. Hello?
Hello? Okay. That's a great question. I think just because the incentive is missing for that. There's nobody incentivizing a corrective mechanism, and there's too much incentive to keep producing because the science these days is so incremental. You have to publish a paper and then seek a grant for it and keep publishing along the same lines. So people build their careers on a certain narrative, and there's a disincentive for them to change that. And nobody's rewarding people criticizing other people's studies.
But is that true in other fields? I mean, my impression is in other fields, it's like a dog eat dog. If I can disprove this other person's theory or rubbish their paper, that's prestige for me. Why isn't that a thing in the tobacco control science, if that's a reasonable reading?
Yeah, I'm not sure what to think about other fields, because I know nutrition research is similarly awful. And I know Roberto Sussman has talked about how physics is much better, so I'm not sure what the difference is. I think, again, it would probably go back to the funding incentives and the need to align with a singular voice.
All right. Any questions to Ariel from the audience? There's Roberto. If you're in that corner, you're basically invisible, so make some sort of move. Roberto, please. Has somebody got a mic they can hand to him? No? Yes? Good. I've got you, yeah.
Hi. A very simple question, like we are seeing now with the Trump administration a massive disruption of this system. The details are uncertain, at least for me, but the question is, how is all this MAHA and all this disruption affecting what you described?
Yeah, that's a great question. And we don't know what's going to happen. There's been legal challenges to the cuts to NIH, so I guess we'll see if anything changes. If it does, I think optimistically it could force a reevaluation by universities to deprioritize NIH as the primary source of funding. But then again, it goes into, well, where would they get funding from? If they go to American Cancer Society or Bloomberg, it's not going to be any different as far as the incentives to align with that particular viewpoint.
Okay, just a couple more questions maximum, and then we'll move on to the Michael Russell Awards. Yes, there, please.
My question near the field about some self-regulation of academia. Was those articles that were mentioned in the start retracted from journals, or some mails to journals about changes in these articles, or retract them?
Yeah, that's a great question too. It's very difficult to get a paper retracted. At best, in my experience, on the particularly offending papers, I will take some time to compose a letter to the editor and submit that. And the idea is that the original authors can respond and maybe make corrections if they need to. I think I've only had a letter to the editor accepted and published once, and it didn't change anything about the underlying paper. Another source for that is PubPeer, which is kind of a crowdsourcing platform to leave comments on published papers. And there's a browser plugin that will alert you if an article that you're viewing on a page has a PubPeer comment. So that's a good way of doing it without having to be gated by the journal's process. But as far as retraction, it rarely happens. It happens sometimes, but it's very difficult to do that. I don't think journals, it seems like they should care more about cleaning up their journal if there's something terribly wrong with a paper they've published. But in my experience, it's slow at best and very unlikely.
And they don't want the embarrassment. Ariel, I think we're going to wrap it up there. Thank you so much for sharing those insights. If anybody wants to take up these discussions in greater depth with Ariel, she'll be in position in the Sphinx later, I think, taking questions from all comers, no matter how drunk. So yes, put your hands together for Ariel Celia, a great Michael Russell oration. If I may, thanks Ariel, I would now, keep going mate. I would now like to welcome Jerry Stimson up to make this year's Michael Russell Award. Jerry, please.
Thank you, Clive, and thank you, Ariel. My younger colleagues in the GFN team only trust me with one job these days, but it is the best job, which is presenting the Michael Russell Award. The award was established in 2018 with the kind permission of Mike's family, and it recognises individuals who've made a significant contribution to the science or the advancement of tobacco harm reduction. So Mike was a psychiatrist and a research scientist at the Institute of Psychiatry. He had huge insights into the future for nicotine at a time when there were few safer alternatives to smoking. Now, as we know, the full potential of his vision is realizable with the plethora of safer nicotine products, so a smoke-free nicotine future is easily attainable. But the simple harm reduction proposition that people who like nicotine should be able to purchase safer nicotine products is being met in many places by well-organized opposition. And nowhere is that more so in Australia, where there's almost universal hostile opposition to vaping from government departments, health charities, and medical and public health organizations. Bizarre, because drugs harm reduction has been at the core of Australia's response to HIV/AIDS. Harm reduction has been at the core of Australia's response to sex work and to drug use. So this year's award is special. It goes to a woman at last. We've had a whole string of blokes up here, but that's going to change forever now. And it goes to someone whose campaigning for the rights of vapers reflects her broader vision of human rights, personal freedom and law reform. So I'm pleased to announce that the 2025 Michael Russell Award goes to Fiona Patton. Fiona. I haven't finished. You're too keen. So as you can see already, Fiona represents the kind of what I call the fun, joyous, life-affirming, freedom-loving side of Australia. There is another side, which is miserabilist and wants to ban things and stop people doing things. But Fiona actually, is all those lovely positive things that can happen in that country. And of course, a lot of things that happen in that country are not good at the moment. Fiona's always been an activist, working in the fields of decriminalisation of sex work, sexual health, working on HIV/AIDS, working for rights of drug users, access to safer injecting facilities, and more recently, the legalisation of cannabis. So that's the broader context for her opposition to the de facto ban on access to vaping products in Australia. And I think it's that big vision that the rights of vapers align with other human rights issues that makes Fiona so special. She is a passionate and compassionate campaigner. Her journey included the establishment of, wait for it, the Australian Sex Party, which is a political party, lovely name, in 2009, and that focused on personal freedoms after her frustration with the stagnation on censorship reform, marriage equality, and drug law reform. In 2017, the party gave itself a rather more sensible name, the Reason Party, but that's, anyhow, marking its broader focus on social issues. As party leader, she was elected to the Australian Victorian Parliament between 2014 and 2022. And earlier this year, she was the lead Senate candidate of the Legalised Cannabis Australia group in the Australian federal election. But they didn't choose you, which is a great shame. So a formidable presence during her time in the Victorian Parliament, and her campaigning skills were brought to the fore. So as a consumer of nicotine, she also embraced the rights of vapers and has campaigned to challenge the morally driven prohibitionists in Australia and to argue for appropriate and proportionate regulation for safer nicotine products. So her efforts have been acknowledged and welcomed by vapor advocates around the world, and she is, one of the few lone voices in Australia. We need a lot more trying to work against the miserablest anti-fun side of Australia. So the award recognises her pioneering spirit, her continued efforts to support a regulatory framework that can deliver the full potential of tobacco harm reduction and help bring about the end to smoking. So Fiona is a harm reduction and a human rights hero and well-deserved recipient of the 2025 award. Now you can come up. So I have to get this thing safely out of the box, and it's very heavy. It really affects your baggage when you go back to when you check in going back. So congratulations.
Thank you so much, Jerry. Thank you to the GFN team, to Paddy and to Jess. I feel like coming from Australia, we really don't deserve this. I coined us as the global village idiot when it comes to tobacco harm reduction. But I have to say that this award does give me more strength in my arm to continue to fight for tobacco harm reduction in Australia. And maybe Australia can at one stage in the future not be the country that shows everybody else what not to do. We might become one day the country that actually does something right in this area. Recently, just the other day, they've sacked the e-cigarette czar, mainly because organised crime in Australia is making $13 million a day out of illicit tobacco and illicit vapes. I thought getting this award might actually help me in my job application to be the next e-cigarette czar, but I suspect not. Thank you very much to GFN and to everyone here and to all the work that you all put in every day. Thank you.
Thank you. So that's the end of the formalities for now, and we have the conference party, which starts at 7:30, I believe, in the Sphinx. I haven't a clue. Paddy's in charge, and he hasn't a clue. So, and we normally have a little slide. Has it gone up? Oh, it shows you where it is. It's kind of round. It's in the same block as the hotel. You can go outside round the corner, and you'll find the Sphinx. And I think you need to bring your badge with you. So this keeps everybody at the conference in and everybody we don't want in out. Does that make sense? So thank you very much, everybody. Great evening. Thank you.